Next paper, the Nagabhushan Rao, clinical evaluation of results of autologous platelet-rich plasma injection in knee OA.
Topic open. Next. ఇది కాదు బ్రో, టాపిక్ నాది కాదు. సార్ గుడ్ మార్నింగ్ సార్. నాగభూషణ్ గారు. Good morning, one and all. Topic is clinical evaluation of results of autologous platelet-rich plasma injection in knee osteoarthritis. The main aim is knee osteoarthritis is a major public health problem. Current treatments for osteoarthritis are palliative, and autologous platelet-rich plasma provides concentrate of growth factors to promote the chondral healing. Main aim to evaluate the clinical effects of intraarticular platelet-rich plasma injections in group of patients in osteoarthritis. The materials and methods. My study is a prospective study of 60 members of patients in Kimsamala Hospital and in period of 1 year. The inclusion criteria include the study group age group is 50 to 80 years with colloquial large grade 1, grade 2 osteoarthritis knee. Informed consent taken from all the patients. Study approved by ethics committee of Kimsamala. The exclusive criteria includes history of diabetes, that previously treated anticoagulant antiplatelet medication 10 days before the injection, infection and active around the knee area, and use of NSAIDs 2 days before the injection, history of intraarticular knee injection within 2 weeks. Preparation of PRP is by differential centrifugation. 30 ml of venous blood harvested from the patient into the acid citrate dextrose tube, mixing of 9:1 rate. The blood is sent it to the first soft spin 1500 rotations per minute, but in a period of 3 minutes. The supernative fluid is collected and second supernative fluid is sent it to the hard spin, that is 2700 revolution per minute in a period of 15 minutes. The lower half is platelet rich plasma, upper half of the platelet poor plasma that discarded. This is the flowchart image showing the how to prepare the PRP. This is left one shows centrifugation machine. After soft spin separation and after the plasma separation. The definition of PRP for therapeutic effective platelet count is 10 lakhs per microliter in 5 ml of PRP. According to FDA, at least 2 lakhs 50,000 platelets per microliter. Mechanism of action of PRP injection. Once activated, there is a secretion of growth factors by degranulation of alpha granules. Key factors are platelet dividing growth factor, transforming growth factor beta, vascular endothelial growth factors. The intraarticular injection, strict aseptic precautions. Patient in supine with knee extension. PRP is activated with calcium chloride and injected into knee joint. The total 3 PRP injection at 3 weekly intervals with review at 3 weeks, 6 weeks, and 6 months. PRP activation with calcium chloride images, then intraarticular injection. Post-injection advice. Crepe applied, advised rest for few hours. Ice compression and limb band elevation for persistent pain and swelling. 3 days of oral antibiotics. Patient advised not to take any NSAIDs. Results: 2 patients had persistent swelling for 3 days, resolved with ice compression. No case of infection seen, no dropouts. Patient evaluated for improvement of patient results outcome measures. Different scores are available. Whose WOMAC VAS. The patient 1 pre-injection and post-injection. X-ray shows grade 2 osteoarthritis knee. The patient 2 pre-injection post-injection. Grade patient 3 pre-injection post-injection. The scores, the different parameters are pain, symptoms, activity of living, daily living function, sport and recreation functions, quality of life. Based on these parameters, pre-injection and post 3rd week and 6th week and 6th month of follow-up, the p-value is less than 0.001. the graphical representation of WHO score pre and post injection. The second one is a VAMAX score. The mainly indicates the pain. The pre and post injection like 3 weeks, 6 weeks, and 6 months. The p value is less than 0.01. Graphical representation score is pre and post injection. The average VAS score for the pain at 6 months 3.5 compared to pre-injection. The discussion International Osteoarthritis Research Institute evidence to currently used drugs have action against the prognosis of osteoarthritis. Relatively new strategy for cell use for cell elements and biomediators for tissue response. PRP stimulate the natural healing of cascade tissue regeneration by supraphysiological release of platelet-derived growth factor directly site of treatment. Different authors says PRP injections are better compared with other treatments. The negative clinical results associated with poor quality PRP, variability of platelet concentrating techniques may alter the platelet degranulation characteristics could affect the clinical outcomes. The conclusion in PRP is novel therapy. It is a simple daycare, cost-effective, safe procedure. Studies show significant improvement in the pain and daily activities patient measurable increase the active flexion without pain. And so we conclude the PRP promising therapy is early osteoarthritis. These are references. Thank you, sir.
You have shown one X-ray.
Yes, sir.
What is that grade? OA grade?
Grade 2, sir.
Grade 2.
Yes, sir.
So that the more functional results should be shown in clinical pictures.
Yes, sir.
Okay.
Yes, sir.
Anyway, good paper.
Thank you, sir.
Right. Okay, thank you.
Thank you, sir.
The third paper by Dr. D. Lakshmikant, functional outcome following proximal humeral interlocking system, rating for displaced proximal humeral fractures. Interlocking versus plating.
Good morning, sir. My name is Lakshmi.
Only plating. Okay, right. Filas, okay, right.
It's a functional outcome following the Filos plating for displaced proximal humerus fracture. Introduction. The indication for the fixing such a fracture depending on the fracture pattern. The goal is to achieve the normal anatomical reduction and stabilization so as to achieve the early mobilization. We report the outcome following this new technique as surgical option in the management of the proximal humerus fracture. We hypothesize that the locking plate provides a good fracture stability and they helps to advocate the early mobilization without compromising the fracture union. The materials and methods. We treated 30 consecutive patients. We have displayed the proximal humerus fractures with the Filos plating. The fracture is classified using the needs classification. It is based on the degree of displacement and angulation of the anatomical segments, regardless of the level of the fracture or mechanism of the fracture. The mean age group of 30 patients was 58 years. The causes for the trauma is a simple fall, but other causes are road traffic accidents and fall from the height. The operation was done within 2 weeks of the injury, and post-operatively the patients were assessed clinically and radiologically. The average follow-up period was 9 months. In surgical techniques, through a deltopectoral approach, the fracture site is exposed to taking care of the soft tissue envelope to maintain a good vascular supply. The anterolateral branch of the anterior humerus circumflex artery which is a primary blood supply to the proximal humerus can be damaged while exposing the tendons in the bicipital groove, and care should be taken to avoid this complication as this may jeopardize the blood supply to the humeral head and increase the risk of the avascular necrosis. This is the intraoperative picture. The fracture is then reduced anatomically and the locking plate is applied on the proximal humerus. The technique demanding part of the operation is to get the correct version of the humerus while applying the plate. The height of the implant is set by inserting the guide wire. It can't be too high due to it may lead to the risk of the impingement, and it cannot be too low, as there will be insufficient holes to put the screw into the head of the humerus. The post-operative rehabilitation or physiotherapy regime consists of the polishing for 3 weeks with pendulum exercises and followed by the active assistant external rotation to neutral and the active assistant flexion. At 6 weeks, they have to be, allowed the full range of movements. This is a post-operative X-ray. 30 patients underwent the surgery with the proximal humerus locking plate. Out of 30, the 10 were the males and 20 were the females. And the radiological union was achieved within 12 weeks following surgery. The one patient underwent the wound infection, which was initially treated with the wound debridement, and washout and antibiotics, but subsequently, and she required the removal of the implants and revision of the locking plate once the infection was settled. And wound infection, subacromial impingement, an implant failure, an avian of the head of the humerus are the complications of this procedure. And discussion. The majority of the proximal humerus fractures are treated conservatively. The different surgical options for fixing the proximal humerus fractures are the interfragmentary fixation with the sutures and percutaneous pinning and intramedullary fixation and hemiarthroplasty. The recent trends is to use the less invasive procedures for reduction and fixation of the fracture. The lesser the invasive the procedure, the more the operative prerequisites, the good bone stock and minimum comminution of the tuberosity, and patients will be to participate in the post-operative physiotherapy regime and advanced operative skills. The most recent newer implants such as the plantar fixator plate and Polaris nail and the Philos plating has been used for the fixation of the proximal humerus fracture. Plantar humerus fixator plate involves the two cancellous screws in the humerus head together with the plate in the humerus shaft. Our result shows that the good fracture stability was achieved and the functional outcome was very good in the younger patients, and it is declined with the increased age, and early mobilization of the shoulder can achieve without compromising the fracture union. And thank you, sir.
You didn't show any X-rays. Your pre-op, post-op,
Post-op one.
not even one couple of X-rays also didn't show.
Sir, post-op X-ray one.
Okay. Anyway, thank you.
X-ray kuda ledu. We have not seen any one single X-ray. No issue. But you have to better next time.
Yes, sir.
Okay. Unless you show the X-rays, how can we believe your results? But to show a few X-rays, at least 2 or 3 X-rays, clinical pictures, range of movement, and you have to show. No, the complication is short stiffness, but you haven't shown even single case of your clinical pictures. So unless you show the clinical pictures, that will not be considered for any competitions. Okay, because for presentation also we won't accept it, right? So next time when you present, you take care of all these things. Okay, Lakshmikant. Right.
Okay, sir. May I invite Sai Shashidhar, a comparative study of extra-articular distal tibial fractures managed by intramedullary nailing versus locking plate.
Good morning, sir. Today, my topic of paper presentation is comparative study of extra-articular distal tibia fractures managed by intramedullary nailing versus locking plate. Coming to the introduction, distal tibia fractures accounts for 7% of all the tibia fractures and more commonly seen in the age group of 25 to 50 years. Spectrum of injuries varies from low energy to high energy injuries like road traffic accidents, fall from height, and twisting of ankle. Several methods of treatment include conservative, intramedullary nailing, X-fix, open reduction internal fixation with plating. The aim of treating the fracture is to preserve normal mechanical axis, ensure joint stability, and restore a near full range of motion. Results of the operative treatment will depend on the severity of the initial injury and quality and stability of the reduction. Mechanism of injury, status of soft tissue, degree of comminution, and articular damage affects the long-term clinical outcome. This is the AO classification for distal tibia fractures, classified into 43A, 43B, 43C, corresponds to extra-articular fractures, partial articular fractures, and complete articular fractures. Aim of the study was to compare the functional outcome of distal tibia fractures managed by intramedullary nailing versus locking plate. Materials and methods is a prospective study consisting of 10 patients, out of which 5 patients are treated with nailing and other 5 patients treated with plating, and were followed up for radiological and clinical outcome using the American Orthopedic Foot and Ankle Society score. Inclusion criteria, it includes extra-articular closed fractures of the distal tibia, AO type including 4-3A, 1, 2, and 3, simple wedge and comminuted fractures, age between 18 to 60 years, fracture line between 4 to 8 centimeters from tibial plafond. Exclusion criteria, age above 60 years, open fractures, intra-articular fractures, pathological fractures, and patients with neurovascular injury. Coming to the procedure, first, the patients were seen in the casualty. History was taken, followed by general and local examination of the patient. Neurovascular status was checked, X-rays and CT done to rule out the articular extension. Fracture is temporarily immobilized with ebony slab. Pre-operative planning and investigations were done, and the patient was posted for surgery. Patients who underwent intramedullary nailing and plating both were done in supine under spinal anesthesia with patients on supine. To the inferior patellar approach technique for intramedullary nailing, approach is through infrapatellar approach. The entry point is just medial to the lateral tibial spine on AP view and anterior to the lateral surface on lateral radiograph. Fracture was reduced and ball tip guide wire is passed to center position in ankle. Reaming was done. Nail was locked distally and proximally through the interlocking screws. And post-op radiographs taken to confirm the alignment. Technique of plating, same supine position under spinal anesthesia through medial approach. A plane is created between the skin and bone. A fracture was reduced. Long plate was inserted with appropriate contour. Reduction was checked under the fluoroscopy and screws are fixed. Wound is closed in layers and post-op radiographs taken to confirm alignment. Post-operative protocol, IV antibiotics was continued till POD3. Suture as staple removal was done on 12th to 14th post-operative day. Active quadriceps exercises are started on first POD with active ankle and toe movements as far as the patient is comfortable. Patients are made to ambulate from 4th POD with or without the weight bearing on operated leg on basis of mode of fixation and reduction. And the patients were followed up for clinical and radiological evaluation at 2nd, 6th, 12th, 26 weeks. Partial weight bearing was allowed after signs of radiological union is seen in X-rays. Uniform union is confirmed radiologically after showing the bony trabecula or cortical bone crossing fracture site on at least 3 surfaces on X-rays. These are the pre-op, immediate post-op, and follow-up X-rays of the distal tibia fracture managed with plating. And this is the pre-op and post-op X-rays of distal tibia fracture managed with nailing. Results are age-wise distribution. Most of the patients falls under the age group of 18 to 45 years, as these patients are exposed to outdoor activity and rotor accidents. Gender-wise distribution, most commonly seen in males. Mode of injury is because due to road traffic accidents and fall from height. Full weight bearing is immediately seen in cases of nailing, whereas it is delayed in plating. Complications in nailing, knee pain and malunion is seen. And in cases of plating, implant impingement and superficial infection is seen. Discussion, distal tibia fractures are most often high energy fractures result from axial and rotational forces on distal tibia, where non-operative treatment is also used in case of stable fractures with severe comorbidities, but complications like delayed union, malunion, joint stiffness are very common. Lock and plate fixation, it gives a good rigid construct, anatomical reduction, and biomechanical superior to intramedullary nailing. However, it results in soft tissue dissection, resulting wound complications and infections. Hardware complications are more with locking plates, warranting the implant removal more frequently. With use of minimally invasive technique, these complications are significantly reduced. Coming to the intramedullary nailing, it is used for commonly used treatment for distal tibia fractures. So it is less invasive than plating, technically more challenging to achieve and maintain reduction because of anatomic characteristics of distal tibia. Our study is to compare the distal tibia fractures with intramedullary nailing and locking plate. In case of plating, we have lower rates of non-union and malunion, but more healing time than nail. And one patient had superficial infection in plating group post-operatively, which was managed by regular dressings and antibiotic according to the culture. In cases of nailing, anterior knee pain are seen in 2 cases, small union in 1 case. Radiological healing is earlier in case of nailing, that is 14.5 weeks, and in case of plating, it is 17.5 weeks. Conclusion, in case of nailing, there is better range of motion at ankle joint. Fracture union was seen earlier. As being a load sharing device, early mobilization can be started. With plating, there is superficial infection rate, implant impingement, and prolonged duration of protected weight bearing. So we conclude that intramedullary nailing is a reliable and marginally advantaged method for treatment of fractures of distal tibia 4-3 A-type fractures, that is extra-articular, with good functional results and high early union rates with compared to lower complications. These are the references. Thank you.
What is your demarcation regarding the length of the tibia to go for the nailing or plating, lower level? If there is regarding the length, of 2 centimeters or 1 inch or 2 inches is there, I'll go for nailing.
For nailing, at least 2 distal screws should be possible.
Yes. How early you operate to do a locking plate in, because when they come initially, it will be swollen up. Sometimes it is closure is little difficult. You wait for some time or you do this day one.
So immediately we'll
You wait.
do immediately.
Inpadala.
We'll do. We'll go for surgery.
Immediately go for surgery. How many cases you come across any difficulty in closure or infection, any incidents?
For plating, one patient has that superficial infections.
I hope you do percutaneous plating,
Yes, sir.
not open.
Yes.
What is the role of influence of the fibula fracture in distal third tibial fractures?
If the patient comes with both tibia and fibula fractures, we'll first fix the fibula fracture to maintain the alignment, and after that we'll go for tibia fixation.
You always fix the fibula to restore the length of the fibula, which is very important. Once you fix the fibula, almost majority the tibial fractures comes into alignment.
Yes.
So basically I'm a nailer. So maximum I'll try my level best to go for nailing. Fix the fibula.
And then
At least I can, if I can pass the 2 screws distally, I prefer nail because it is a swollen ankle, and even you do a percutaneous also sometimes it's difficult to close, and sometimes do a very tight closure. Once you put a tight closure, it gives way. Anyway, thank you.
thank you, sir.
May I request Satchagopal, a study of midterm clinical outcome of all insight technique in ACL reconstruction.
Good morning, sir. I'm Dr. Satyagopal from Apollo Medical College. I am here to discuss about the study of midterm clinical outcome of all inside technique of ACL reconstruction. So the ACL is the primary stabilizer of the knee, which prevents the anterior translation of tibia. It restricts the valgus and rotational forces. And nearly 2 lakh ACLs are torn every year, and almost 1 lakh ACL reconstructions are done every year. So anterior cruciate ligament deficient knees, due to repeated episodes of instability, they lead to meniscal tears and osteochondral injuries, which leads to arthritis. So a pop-up sound followed by pain and swelling of the knee, giving away of the knee joint, locking, and knee instability are the most common symptoms. And clinically, we can diagnose by the anterior draw test, Lachman's test, the pivot shift test, and jerk test. And MRI is very sensitive in diagnosing the ACL. We have the non-visualization of ACL in its usual location, focal interruption, and flattened areas of distal ACL with poor visualization of the proximal ACL. So the gold standard for the treatment of ACL has been ACL reconstruction, and there has been a lot of advancement in the arthroscopic technique since 80s. So due to our increasing understanding knowledge of the graft and tendon placements and fixation devices usage, there have been a lot of modifications in the arthroscopic ACL reconstruction. So the standard ACL reconstruction, there may be earlier they used to use the bone patellar tendon graft due to patellofemoral pain. Then we have shifted to the hamstring grafts. In the standard, we use the semitendinous and gracilis tendons autografts from the same leg, and they are doubled up to create a fourth standard graft, and femoral closed socket is drilled by the medial arthroscopic portal, and tibia has an open tunnel drilled in from the outside. And the graft is fixed using a suspensory fixation on the femur side and an interference screw on the tibial side. In the all-inside ACL reconstruction, we have two closed sockets instead of the tunnels in the femur and tibia, and we have the double suspensory fixation by using an adjustable loop endo button and the attachable button system on the tibial side. And we can have a smaller skin incision, and a quadruple semitendinous autograft alone can be used. So the aim of this study was to study the functional outcome of all-inside ACL reconstruction using hamstring tendon at the medium-term follow-up. So we plan to study the patient-reported outcome measure with the international knee documentation, COMDIS score, and the lysome score at different stages of the treatment. So this is a prospective study conducted at the Apollo Medical College from July 2021. 15 patients were enrolled. The young and middle-aged patients with complaint of knee pain and history of RTA or any trauma reporting to OPD and ER have been included. After the clinical diagnosis and confirmation with MRI, they have been included. And the inclusion criteria was clinical or MRI evidence of ACL insufficiency, patients between the age of 20 to 45, and those associated with the medial or lateral meniscal test, and no history of previous surgery, and a normal contralateral knee. And those with PCL and local skin infection, associated fracture of tibial plateau, severe OA were excluded. So after the pre-operative rehabilitation, consent and the patient IKDC 2000 score will be obtained. After the surgical procedure, post-operative management rehabilitation, at 6 months, 1 year and 2 years, we plan to assess the same. So 6 months follow-up has been completed for the patients. So the rhizome and IKDC 2000 score has been again obtained, and we record the complications like infection, deep vein thrombosis, and technical or hardware-related problems. So the portal setup, using two anteromedial and anterolateral portals, and the graft harvester is semitendinous graft with the knee flexed at 90, and the graft is prepared by quadrupling the semitendinous graft and fashioning it in a double loop, and we create the tibial socket creation with a flexible reamer, and similarly we create a femoral socket creation, and we do the graft passage and fixation, and we use an adjustable loop endo button and attachable button system. So this is a case, is a pre-op MRI showing the ACL insufficiency, and the post-op X-ray showing the adjustable loop and endo button with the ABS button, and the patient is able to squat at the end of 6 months, and full knee range of motion with flexion and full ROM present. And we use the 2000 IKDC knee score. This is a form which is a subjective thing which will be this by the patients. And similarly, lysome score will be testing of 8 parameters. So among the 15 cases, the 6 cases completed 1 year follow-up. Majority were in the age group of 20 to 25 years, followed by 30 to 35 years. Out of 15 patients, 9 were male, 3 were female, and right side was more involved than the left side. And most common cause of the injury was road traffic accidents in our study. And among the sports, football was the most common cause of injury of ACL. And the patients usually, the duration between the injury and surgery, most patients presented 4 to 6 months after surgery. And the most common symptom was knee pain. And this was almost 73% were associated with meniscal tears. And the lysome knee score were 7 patients showed excellent and 6 were good results, 2 were 5 results. And the pre-op score, the IKDC pre-op knee score was 53.76, whereas the post-op was 85.6, and the p-value was less than 0.01. And we have earlier studies which have been compared with this. So the conclusion is we have a good term result at medium-term follow-up. It requires shorter prepared graft, 5 to 7 centimeters. Advantages of using sockets, and there is less graft motion, so there will be less chance of graft failure. And the graft insertion through arthroscopic portal, so there will be less minimal post-operative bleeding, soft tissue damage, and post-operative pain. So it is an ideal for ACL reconstruction in young individuals despite the time and skill needed. And there's a small sample, shorter duration of follow-up, and these are based on subjective scores and not based on objective assessment. So follow-up study for longer duration has been required to assess the long-term outcome of this procedure. Thank you.
Thank you. May I invite Sweta Reddy. Sweta Reddy, joint salvage by sandwich technique and internal fixation for giant cell tumors around the knee joint, a case series.
Morning, sir. My topic is joint salvage by sandwich technique and internal fixation for giant cell tumors around the knee joint, a case series. So aim of the study was to evaluate the functional outcomes of 15 patients who underwent extended curettage reconstruction with sandwich technique using iliac crest autograft slivers, gel foam, and bone cement, followed by internal fixation for the giant cell tumor around the knee joint. So as we know, giant cell tumor of the bone is one of the most common benign tumors occurring around the knee joint in those aged 30 to 40 years. It's a locally aggressive tumor and is more prone for recurrence and malignant transformation. It's moving here. So it's a locally aggressive tumor and is more prone for recurrence and malignant transformation, and treatment by curettage alone would have high risk of recurrence. And so we resorted to make use of adjuvants like hydrogen peroxide, phenol, bone cement, cryosurgery, or combination of all these, and followed by reconstruction with autograft, allograft, and bone cement. So in our institute, the surgical protocol for the treatment of giant cell tumor of the distal femur and proximal tibia was intralesional extended curettage with high-speed burr, followed by use of hydrogen peroxide and reconstruction using a sandwich technique, in which iliac crest autograft slivers of about 4 to 5 centimeters in length and 2 to 3 mm thickness were used, which are placed beneath the subchondral region, which is then overlaid with a layer of gel foam, and the rest of cavity is filled with polymethyl methacrylate bone cement, followed by open reduction and internal fixation with locking compression screws and plates. The study was conducted between January 2017 and May 2021, where 9 women and 6 men aged between 32 to 68 years underwent intralesional extended curettage with high-speed burr and the use of hydrogen peroxide and reconstruction using a sandwich technique of the GCT, where the sample of the femur was 10 and proximal tibia were 5. And the diagnosis of GCT was made based on the radiological and histopathological examination. There was no recurrence found during our follow-up period per se. And according to the Campanacci grading system, of the 15 patients, 12 were of grade 2 with a relatively well-defined margin, thinned out and moderately expanded cortex, and 3 were of grade 3 with indistinct borders with cortical destruction, but without any soft tissue extension. And we had a loss of follow-up of 2 patients of the total. The procedure was through a large cortical window. The tumor tissue was curated until normal appearing bone was seen, and the cavity was then enlarged in all directions using a high-speed burr with care to avoid contamination of the surrounding soft tissues. And the cavity was cleaned with hydrogen peroxide, and the peroxide soaked gauze was placed inside the cavity for a span of 2 minutes. And autogenous iliac crest sliver grafts of about 4 to 5 centimeter in length and 2 to 3 mm thickness were placed beneath the subarticular surface, making the layer up to 1 centimeter thickness. And the layer of gel foam was laid over the graft slivers, and the remaining cavity was packed with bone cement, followed by internal fixation with a locking plate. And post-operatively, early weight bearing was allowed as per patient's tolerance, and oral supplementation of vitamin D3 of about 8,000 international units and oral bisphosphonates were given for a span of 6 months. And functional outcomes were evaluated using musculoskeletal tumor society score, which involves 6 parameters. They are the pain, function, emotional acceptance, use of walking aids, walking ability, and the gait. So the results attained were, the mean follow-up period was 4 years, that is 7 months to 4 years was an average. And the mean MSTS score was 25 out of 30. Merrill score was 8 on 10. And the post-operative range of motion of the knee joint was comparable to the pre-operative range of motion in Campanacci grade 2 cases. So this is a case scenario showing giant cell tumor of the distal femur, followed by an intra picture of use of high-speed burr of about 20,000 RPM. And followed by application of the locking compression plate and screw. Then we have cementing and the post-op X-ray. And this is another case scenario showing GCT of the proximal tibia with intra-op and post-operative pictures and the post-operative range of motion that was attained. The preservation of joint function is an advantage of the intralesional curettage along with the sandwich technique compared to wide resection. In our study, intralesional extended curettage and reconstruction with the sandwich technique yielded a good functional outcome. To ensure thorough extended curettage, adequate exposure through a wide cortical window is necessary, followed by breaking of the bony ridges of the tumor using a high-speed burr. So that is why we had to use the high-speed burr of 20,000 RPM. And the use of hydrogen peroxide acts as a chemical adjuvant for the removal of residual tumor cells, and presumably by effervescent cleansing with minimal damage to surrounding soft tissues and bone cells. So the conclusion will be intralesional extended curettage with high-speed burr and use of hydrogen peroxide and reconstruction with a sandwich technique using iliac crest autograft slivers, gel foam, and bone cement, followed by internal fixation with locking plate and screws. For the giant cell tumor of the distal femur and proximal tibia, achieved good functional outcomes. Thank you, sir.
May I invite T. Narendra, functional outcome of mid-clavicular fracture fixation with locking clavicular plate.
Next slide. Good morning, one and all. My paper of presentation is functional outcome of mid-clavicular fracture fixation with locking clavicular plate. Coming to introduction, clavicular fractures are common injuries accounting for 2.6% of all fractures. Fractures of the middle third, midshaft account for approximately 80% of all clavicular fracture. The traditional view that the vast majority of the clavicle fractures heal with good functional outcome following non-operative treatment is no longer valid. Recent studies have identified a higher rate of non-union and specific deficits of shoulder function in subgroups of patients with these injuries. Prompt fixation of this clavicular fractures permits increased patient comfort and early shoulder mobility. This fracture should therefore be viewed in the spectrum of injuries with diverse functional outcomes, each requiring careful assessment and individualized treatment. And when indicated, these fractures should be treated by primary operative fixation. Aim of the study to functional outcome of the mid-third displaced clavicular fractures treated by open reduction and internal fixation with locking clavicular plate. Materials and methods. This is a prospective study consisting data of 20 patients with mid-clavicular fractures operated with locking clavicular plate. Patients were followed up for radiological and clinical outcome using with constant score. Coming to inclusion criteria, completely displaced more than 2 centimeter mid-shaft fractures of clavicle, comminuted middle third fractures of the clavicle with inferior cortical defect, painful non-union, and age between 16 and 60 years, no medical contraindication to general anesthesia, and informed consent. Exclusion criteria, an age of less than 16 years or greater than 60 years, a fracture in the proximal or distal third of the clavicle, pathological fractures, undisplaced or minimally displaced clavicle fractures. Allman classified clavicle fractures into 3 groups. Group 1, which is middle third fractures, accounts for 80%. Group 2, distal third fractures, accounts for 50%. And Group 3, fractures of proximal third, accounts for 5%. Operative technique under regional or general anesthesia, the patient positioned in supine position with sandbag beneath the ipsilateral scapula, the involved shoulder prepared and draped, and oblique incision made over superior surface of the clavicle, centering the fracture site. The fracture site identified and 3.5 mm clavicular plate after countering. Plate is applied to the superior surface of the bone with the goal being a minimum of 3 screws in the main proximal and 2 screws in the distal fragments in most cases. The deltotrapezial fascia was closed with interrupted number 1 absorbable sutures as a distinct layer, followed by skin closure. No drain were used. When fracture union was evident, typically at 6 weeks, overhead abduction and strengthening were allowed with return of full activities in 3 months. This is the image showing incision over the clavicle region, centering the fracture fragments and fracture reduction and plate fixation, then post-operative. The image showing pre-operative X-ray and post-operative X-ray of the same patient. Coming to results of the 20 patients, 19 male and 1 female, and most of them aged below 30 years, studied between the August 2020 and December 2021. All had primary plate fixation except the one with painful non-union for whom plate osteosynthesis with bone grafting was done. 3 patients were lost to follow-up and remaining 7 patients had mean of 15.5 months follow-up. All 17 patients had fracture union in the mean of 16 weeks. Most of the patients, that is 82%, had constant shoulder score above 90 with the excellent grade except for 3 patients. Patient satisfaction after the surgery, all patients were satisfied with their shoulder except the above mentioned 3 patients with complications. Of 17 patients in regular follow-up, 13 patients had returned to the pre-injury levels of work with recreational activity. 2 patients with post-op infection did not go to work. Patients with shoulder stiffness found difficult with household activities. Range of motion well maintained in all patients except the old lady who developed shoulder stiffness. The values were all as of the normal contralateral shoulder, 82% of the patients having more than 90% of the normal function. Rate of union, fracture union was assessed with clinical and radiological means. Fracture united at an average of 16 weeks. 2 patients had wound infection and the plate were removed. 1 patient except hardware prominence was doing well. 1 patient developed shoulder stiffness due to improper follow-up and physiotherapy. There were no non-union, malunion in a study. There were no neurovascular complications. There were no refractures. The traditional view that the vast majority of the clavicle fractures heal with good functional outcome following non-operative treatment is no longer valid. Recent studies have identified a higher rate of non-union, late neurovascular compromise, and specific deficits of shoulder function in subgroups of patients with these injuries who are treated by conservative means. Internal fixation by plate osteosynthesis has the advantage of early pain resolution, early return to the shoulder function, and potentially early return to the work. The clavicle fractures should therefore be viewed as a spectrum of injuries with diverse functional outcomes, each requiring careful assessment and individualized treatment, and plate osteosynthesis should be preferred for the treatment of indicated middle third clavicle fractures in the active individuals. Thank you.
There's one statement in your talk saying that the non-operative method is no valid. I think you have to withdraw that statement from your talk.
Okay.
What is your indication for the fracture clavicle fixation?
For plate fixation, if the displacement is more than 2 centimeters, then we go for plate fixation, sir. Otherwise, it can be treated non-operative.
When we were told 30 years back,
yes, sir.
the flail shoulder was the only indication for clavicle fixation.
Okay.
I have been practicing past 30 years. I have treated 5,000 clavicle fractures roughly.
Okay.
I have not seen any of my patients came back and saying I got some problem.
Okay.
Absolutely they heal well. Probably they may having a little bump.
Okay.
So no longer non-operative method is no longer valid, is absolutely you have to withdraw.
Okay. Sorry, sir.
Because still there is a debate. Because of this bloody Arogyasri came, people are operating clavicle fractures.
Okay.
Before Arogyasri, it was in 2007, Arogyasri came. Before 2007, only 1 or 2% people only operating clavicle fractures. Then there is an indication only.
Sorry, sir.
Right?
Okay.
Okay, thank you.
Thank you, sir.
May I invite Vijita, therapeutic efficacy of proximal fibular osteotomy in alleviating pain of sympathetic primary degenerative middle compartment knee arthritis.
Good morning, sir. This is Dr. B. Vijita, postgraduate in orthopedics, Vishwavarthi Medical College, Karnool. And my topic is therapeutic efficacy of proximal fibular osteotomy in alleviating pain of symptomatic primary degenerative medial compartment knee arthritis. Coming to the introduction, primary degenerative osteoarthritis of the knee is the most common chronic condition occurring in the middle-aged and elderly population, causing pain, reduced range of movements in the joint, and functional disability, severely affecting the activities of daily living. There are wide range of treatment options available, both conservative and surgical. for treating this primary degenerative osteoarthritis. Proximal fibular osteotomy is a novel, simple, low cost and effective surgical procedure in reducing the pain of ONE. So the purpose of the study is to evaluate the therapeutic efficacy of proximal fibular osteotomy in alleviating pain of symptomatic unicompartmental osteoarthritis of knee and improvement in functional outcome of the patient. So ideal indications for proximal fibular osteotomy are predominantly medial unicompartment osteoarthritis with good lateral joint space in the weight-bearing X-rays of knee joint, and a motivated patient who understands that this is a procedure that buys time and delays the knee replacement surgery, and patients with the BMI less than 23. So in the study, the inclusion criteria was patients with knee pain and difficulty in walking due to isolated medial compartment osteoarthritis, and the weight-bearing X-ray film showing reduced joint space in medial compartment. So the patients with genu valgum in the case of rheumatoid arthritis are excluded from the study, and patients with lateral compartment bicompartmental ONE and patients with acute major trauma and inflammatory joint diseases like septic arthritis are also excluded from the study, and patients not willing for surgery are excluded. So coming to the materials and methods, this is a case series study was conducted at Vishwavarthi Medical College, Kurnool, Andhra Pradesh, for a period of 2.5 years from March 2017 to September 2019. In this, the medial and lateral joint space were measured and recorded both pre-operatively and post-operatively. Pre and post-operative clinical assessment was done by visual analog score, that is VAS score, and their values were recorded accordingly. After explaining about the surgical procedure and acquiring an informed written consent, proximal fibular osteotomy was performed. All patients were followed post-operatively at regular intervals and assessed for relief of pain in the knee, and overall functional outcome of the patient was assessed in the follow-up basis. Coming to the incidence, a total number of patients selected for the study with 30, among which 17 were men and 13 were women. This is a bar diagram showing the joint space and clinical VAS score. This blue bar indicates the medial pre-op value, and the red bar indicates the post-op value. And the medial joint space, the pre-op was about 2.75 mm, which was improved to 3.75 after the post-op, and the lateral joint space was 4.75 pre-operatively and was decreased to 3.75 post-operatively, and the VAS score was 7 pre-operatively, and at 2 weeks follow-up when patient came for suture removal, the score was VAS score was 3. This is the intra pictures of the procedure. Here we have marked the head of the fibula on the lateral direct approach, and the incision was given approximately 6 to 8 centimeter below the head of the fibula, and we have identified the fibula bone, and using a drill we have made 4 holes on 4 margins, and by using an oscillating saw we have cut the fibula and replaced it with a bone suture. So this is the image of X-ray showing pre-op and post-op X-rays. Here we can see the decrease in the joint space pre-operatively, which was improved post-operatively. The clinical pictures showing a patient is able to squat and sit cross-legged. So discussion, proximal fibular osteotomy is one of the emerging new method of treatment for early stages of medial compartment ONE. Although high tibial osteotomy and unicompartment arthroplasty were previously the treatment options for isolated medial compartment arthritis, both have their advantages and disadvantages and are associated with major complications, which include infection, deep vein thrombosis, insufficient correction, intra-articular fractures, peroneal nerve injuries, compartmental syndromes, and knee stiffness. So the mean preoperative joint space on radiograph was 2.75 and post-operative was improved to 3.75, and the mean preoperative lateral joint space was 4.75 and was improved, decreased to 3.75. VAS score was preoperatively 7, which was significantly improved. So in the 3rd month follow-up, the mean preoperative medial joint space on AP radiograph was 2.75 and post-operative medial joint space at 3 months follow-up showed 3.80 mm. The mean preoperative lateral joint space was 4.75 mm and post-operative at 3rd month it was 3.75 and the VAS score was improved from 7 to 3. The conclusion, in our view, PFO is a good surgical alternative to high tibial osteotomy, unicondylar knee arthroplasty, or total knee replacement in patients with medial compartment osteoarthritis knee, especially for the rural population at large who do not have access to advanced healthcare facilities and resources as well as willingness and affordability to undergo such expensive surgeries.
Okay, thank you. May I invite Abel Raj to speak on surgical outcome of percutaneous pin fixation of proximal third fracture of ulna in Mondigio fracture dislocation in children.
Is it forward to backward? Okay.
Morning, sir. My topic is surgical outcome of percutaneous pin fixation of proximal third fractures of ulna in Mondigio fracture dislocation in children. So moving on to the topic, these two were the great personalities who defined and gave the classifications for Mondigio fracture. Giovanni Battista Mondigio, he first identified Mondigio fracture dislocation, and Jose Luis Bardo, he classified these into 4 types. So moving on to the topic, Mondigio fracture dislocation is a rare and severe injury of both pediatric and adult forearm and elbow. So in early 80s, Giovanni Battista Mondigio, who was actually a surgical pathologist, he gave the definition, which is traumatic. He defined it as traumatic lesion distinguished by a fracture of the proximal third of ulna and an anterior dislocation of the proximal epiphyse of the radius. It constitutes about 1 to 2% of all forearm fractures. So the reason why we chose this as a study topic is because it remains one of the most challenging pediatric injuries because of the difficulty in diagnosis, the propensity of instability, and the complexity in late reconstruction. And more than 50% of these fracture dislocations are misdiagnosed and leads to dysfunction of elbow joint. So in this radiograph, you can see this is an 8-year-old child, came with history of fall on house's hand with forearm in excessive pronation. And you can see the proximal 1/3 ulnar fracture with the anterior dislocation of the radial joint. And this is the classification given by Jose Luis Bardo. And this type 1, proximal third ulnar fracture with anterior radial head dislocation. Type 2 with posterior radial head dislocation. Type 3 with lateral. And type 4 is type 1 plus fracture of the proximal third radius. And there are, in addition to this 4 types, there are some Mondigio variants, which includes plastic deformity of ulna. There might be isolated radial head fracture, etc. So in our study, we mainly observed that the reduction and stability of the dislocated radiohumeral joint will depend upon the perfect reduction and stabilization of the proximal fracture of ulna. And the stable anatomic reduction of
of the ulnar fracture results in anatomic reduction of the radial head, and which was achieved by precuneous fixation with K-wire that automatically stabilized the radial head. So we conducted this study in 18 patients whose age were ranging from 6 to 12 years with a mean age of 7.24 plus or minus 1.32 years. And in the gap of 6 to 9 years, we conducted study in 4 females, 9 males, and 9 to 12, we conducted it in 2 female and 3 male. It showed a male predominance. And our aims and objectives was to achieve normal anatomic reduction and stabilization of the fracture and the radial head dislocation, and to study the final functional outcome. The inclusion criteria included 6 to 12 years and closed fractures. So in X-rays, pre-op evaluation, true AP and true lateral views were taken. And in AP and lateral view, you have to check for radiocapital line or McLaughlin lines. And always check for posterior border of ulna. It should be a straight line. So surgical position, patient was kept in supine position under anesthesia, and a stab incision was given over the tip of the olecranon. And using T-handle, we introduced the K-wire. Reduction was achieved by close manipulation, and the radial head was also manipulated by close manipulation only, and we passed the K-wire across the fracture site to the distal part of ulna. You can see some of the X-rays. Proximal third fracture ulna and radial head. We achieved close reduction with K-wire. We haven't opened any cases, all were close reduction. The results were functional outcome was very good. The fracture united very well at the end of 6 to 8 weeks. And the only complication we observed was pinion tract infection, that too in 3 children out of the 18 cases that we studied. So to conclude, Mondigio fracture dislocations can be easily missed on X-rays, more than 50%. So in all cases of proximal ulnar fractures, always look for the radial head dislocation or subluxation. And we have done it in minimally invasive procedure, and the reduction and fixation is always required. The functional outcome was very good. Thank you, sir. Sir,
Why do you want to, for simple procedure, why do you want to put a tourniquet?
Sir?
Why do you want to put a tourniquet? Can't you do without tourniquet? How much time did you take for that procedure?
30 to 45 minutes maximum, sir.
45 minutes.
30 to 45 minutes maximum.
Maximum.
Thank you, sir.
Okay, okay. Right.
Thank you, sir.
I advise you not to apply tourniquet for such short case, no?
Sir.
I think 45 minutes is too long.
Yes, sir. And this,
So you can finish up early also.
Sir. So we were actually expecting if at all reduction was not coming, so we were planning for a nick incision, sir. So that's why.
Subcutaneous bone, very easy procedure.
Yes, sir. Sir. Yes, sir.
Anyway, good paper.
Thank you, sir.
Good. Next paper is by Rishikumar. J. Rishikumar. Comparative study of philos versus percutance K-wire fixation and proximal humerus fractures.
Good morning, everyone. I am Dr. Rishi Kumar. I am from Maharaja Institute of Medical Sciences, Nellmarla. So today, my topic for presentation is a comparative study of philos plating versus percutaneous K-wire fixation in proximal humerus fractures. So coming to the introduction, the proximal humerus fractures, they constitute 4 to 5% of all the fractures, and they represent the most common humerus fractures, and 85% of these proximal humerus fractures are non-displaced and they can be treated conservatively. And older individuals, they have a higher incidence of proximal humerus fractures secondary to osteoporosis. These are the fragility fractures. So the most common mechanism of injury here is fall onto an outstretched upper extremity from a standing height, typically seen in older women, and younger patients typically sustain a proximal humerus fracture following a high energy trauma, that is road traffic accidents. So the aims and objectives of the study is to compare and analyze percutaneous K-wire fixation versus proximal humerus interlocking system Philos plating in proximal humerus fractures, and to evaluate the functional results, advantages, disadvantages, and complications of K-wire fixation in Philos plating in proximal humerus fractures. So the materials and methods adopted are, so the study is a non-randomized prospective study of 30 patients treated with these procedures from November 2020 to November 21, and 15 patients underwent Philos plating, and 15 patients underwent percutaneous K-wire fixation. The setting, the study is done at Department of Orthopedics, MIMS Vijayanagram, and the subjects were recruited from there. So all the sample is all the subjects were selected according to the inclusion criteria, and all patients were treated by shoulder immobilizer after other life-threatening injuries were ruled out, and definitive treatment was based on the decision of the surgeon on a non-randomized basis. Coming to the assessment of the patients, it is done by non-blinder assessment, and subjective assessment is done according to the pain, numbness, weakness of the upper limb, and stiffness, and objective assessment was done by range of motion, that is flexion, extension, abduction, adduction, internal rotation, and external rotation. The movements range were measured with the help of a handheld goniometer. The functional outcome of the patient was assessed using the DASH method, that is disability of the arm, shoulder, and hand. The following protocol was observed for the patients. First, we have to do general examination and systemic examination, and then come to the local examination according to the ATLS guidelines. And thorough assessment of the patient to rule out other injuries should be done, and evaluation of the patient in terms of age, sex, the mode of trauma, and the period between the injury and arrival should be taken into consideration. And next, first we have to do stabilization of the patient and a careful assessment of the injured limb as regards to neurovascular status. My inclusion criteria are the patients who are giving valid consent, and 2-part, 3-part, and 4-part fractures, and surgical neck fractures, age between 18 to 70 years, both male patients and female patients, and the patients who are fit for surgery, and the proximal humerus fractures which are operated within 2 to 7 days with or without associated injuries. The exclusion criteria are associated humerus shaft fracture, and any associated neurovascular injury, acute infection, pathological fractures, old and compound fractures. During the study, the intraoperative and post-operative findings observed were the mean operative time was 90 minutes, ranging around 80 to 110 minutes in patients who underwent open reduction and internal fixation with Philos plating, whereas in K-wire fixation, it is 70 minutes ranging around 60 to 80. The average blood loss was around 500 ml in Philos plating, whereas in K-wire fixation, it was around 100 ml. Antibiotics were given in both groups post-operatively, and no intraoperative complications were seen. The statistical methods were employed for this study. We can see the results between male and female. The results were corrected using chi-square method, and the value was found to be 0.17 and p-value of 0.91, showing sex of the patient doesn't influence the outcome of the treatment. And sex distribution among Philos plating and K-wire fixation. Coming to the age distribution, we can see as the age increases from younger patient to older age group, the number of cases are increasing. And age-wise functional outcome also. The chi-square value was found to be 41.18, and p-value less than 0.001 shows that age factor does not influence the outcome of the treatment. And majority of the fractures were on the right side. and side-wise functional outcome among phyllospalating and cavern fixation. Here also, the side involved does not influence the outcome of the treatment. Coming to NIRS classification of fracture and management, the 2-part, 3-part, and 4-part fractures were assigned with the cases, and phyllospalating and cavern fixation was done. And the method of fixation was done for 15 cases with the phyllospalating and 15 cases with cavern fixation. And the patient's follow-up, the patients were assessed, which included an objective impression of the patient, objective grading of function and the deformity, and a comparison of a final and initial X-ray were done. Subjective factors such as pain, functional limitations, technical considerations were taken into account, and follow-up intervals were regularly made at 6 weeks, 12 weeks, and 24 weeks. Clinical examination includes the strength evaluation and assessment of the range of motion. And pain assessment is done according to constant Murley score and visual analog score scale. And the complications seen with the phyllospalating are wound infections, impingement, screw perforation, malreduction, distal screw and plate pullout, and avascular necrosis. Whereas with cavern fixation, it is malunion and non-union, implant loosening, avian of the humeral head, loss of reduction, and pin tract infection. Coming to the conclusion, phyllospalating fixation in cases of osteoporotic proximal humerus fractures gives better results, and it has advantages of proper reduction, and we can do early mobilization. Whereas in cavern fixation, it has some advantages like less tissue damage and minimal invasiveness. But always good results. Good results were obtained in phyllospalating fixation compared with the cavern fixation. These are my references. Thank you.
X-rays cases. Where are the cases? Those and మనం చాలా చేస్తాం కదా. You have to include the clinical cases also. So otherwise the paper is incomplete. Your paper will be considered incomplete. So next time onwards, try to include cases. Okay, okay, good.
So, thank you, sir. Thank you.
There is one question from the Professor Ashok Kumar.
So in the clinical examination, you showed all the range of movements pre-operative, abduction, adduction, internal rotation, external rotation. Does the patient allow all this examination because he is in pain?
Yes, sir.
And there are a lot of hematoma, fractures, they get displaced. First question number 1. And as our professor says, it should be the evidence-based. It should be evidence-based. Without this, this is only a copy and paste, nothing else. And what is the conclusion? Which cases you want to, after your 15, 20 cases, which cases you want to advise KY? Which cases advise philosopher? These are the things which you have to bring up. Take home message must be there. Yes. This is NIRS 1 is KY. NIRS 2, 3, 4. Something like that. The always this particular the paper should give a message. Thank you.
Thank you, Ashok, for your suggestions. Okay, take the suggestions and then do a better performance next time.
Thank you, sir.
Next by Kishore Kintala. So some of the cases, presentations of papers from Bihar has been shifted because of some problem there. So now I call upon Dr. Kishore Kintala to present his paper on functional outcome grade 1 and 2 OA treated with PRP.
Good morning, sir. My topic of paper presentation is functional outcome in grade 1, grade 2 osteoarthritis knee joint, patient treated with platelet-rich plasma injections. Introduction: osteoarthritis is slowly progressive degenerative disorder of synovial joint, in which there is a gradual softening and degradation of articular cartilage accompanied by osteophyte formation, affecting the individuals from fourth decade. The most commonly involved in is knee joint, role of platelets in coagulation, inflammatory process, and in immunity modulation is well known. During degranulation, platelets release various growth factors like vascular endothelial growth factor, platelet-derived growth factor, transforming growth factor B, insulin growth factor 1, and hepatocyte growth factor, which promote angiogenesis, tissue remodeling, and wound healing, and also proteases, which are thought to be responsible for their analgesic properties. Therefore, platelet-rich plasma, which is cost-effective method, is used as a treatment option for osteoarthritis. My aims and objectives: to evaluate the functional outcome in grade 1, grade 2 osteoarthritis knee joint after platelet-rich plasma injection. Material and methods. Source of study: 30 patients of grade 1, grade 2 osteoarthritis knee joint patients from the Department of Orthopedics, Great Eastern Medical School and Hospital, Srikakulam were taken. Informed consent was taken from all patients. Study design: prospective observational study. Study period is January 2021 to July 2021. Duration of study is 6 months. My inclusion criteria is patients of both sex between 40 to 60 years, a patient with grade 1, grade 2 osteoarthritis knee joint. Exclusion criteria is any patient above 60 years, patient with diabetes mellitus, patient with coexisting local infection, immunocompromised patients, and patient with grade 3 and 4 osteoarthritis knee joint. Collection of data: the 30 patients suffering from grade 1, grade 2 osteoarthritis knee joint who attended the outpatient department of Orthopedics, Great Eastern Medical School and Hospital were including the study. Informed written consent was taken from the patient. General physical and systemic examination done. Neurovascular status of both limbs assessed. The X-ray, knee, anterior, posterior, and lateral view were taken in standing position. Routine pre-injection VAS score was assessed. Under aseptic condition, 2 platelet-rich plasma injections were injected to knee joint at 4 weeks interval. The procedure is simple. With a sterile technique, we obtained appropriate amount of venous blood and transferred it to centrifuge machine. After the processing was completed, we extracted the PRP from the centrifuge. Cleansing of the patient's skin around the injection site was done. Towels and drapes were used to create a aseptic field. Administration of local anesthesia was done. Under aseptic conditions, 2 platelet plasma injections were injected into knee joint at 4 weeks interval. Dressing and bandage was applied to protect the needle entry site. Functional status of knee joint evaluated 1 week, 3 weeks, 6 weeks, and 6 months interval. This is statistical analysis. Gender distribution. In grade 1, grade 2 osteoarthritis, coming to the discussion, the present study aimed to demonstrate the efficacy of platelet-rich plasma injection in grade 1, grade 2 osteoarthritis knee joint. 30 patients suffering from grade 1, grade 2 osteoarthritis knee joint who attended to the outpatient department of orthopedics, Great Eastern Medical School and Hospital were including in the study. X-ray, knee, anterior, posterior, and lateral view were taken in standing position. VAS score was taken for assessment of functional outcome. Pre-injection and post-injection score, first week, third week, and 6 weeks and 6 months interval were taken. In our study, 30 patients were taken between 40 to 60 years. Out of them, 60 are females, and 60% of females and 40% are males. Most often them lie between 45 to 50 years of age. Kellgren-Lawrence grading was used out of Out of them, 30% had grade 1 and 70% had grade 2 knee osteoarthritis. There is a significant difference in VAS score before and after giving injection. The VAS score showed a mean of 7.16 at pre-injection, which decreased to 5.95 at first week, 4.81 at third week, 4.06 at 6 weeks, and 3.21 at 6 months. It concluded that intra-articular platelet-rich plasma injections are more effective in the treatment of knee osteoarthritis in terms of relief pain and self-reported functions, improvement in follow-up. Age and physical activity can also influence the outcome of intra-articular platelet-rich plasma injections. Age is the most important factor, and older age have poor prognosis. Platelet-rich plasma is derived from centrifugation of patient own blood. Own blood platelet concentration is increased by 5 to 10 folds from the baseline. It contains growth factors in the alpha granule, which are chondroprotective and cause the chondrocyte proliferation and production of matrix molecules. Platelet-rich plasma reduce the inflammatory process and also help in articular cartilage repair and regeneration. The present study concluded that 2 doses of PRP injection decrease the joint pain, alleviate the symptoms, and enhance the activity, daily living quality of life in short-term duration. Conclusion: use of 2 doses of PRP intraarticular injection in the management of osteoarthritis knee provides excellent pain relief, improvement in the quality of life, which is more effective in the early stages of osteoarthritis. PRP is safe, easy, minimally invasive, and cheap alternative in the management of knee osteoarthritis.
How long you expect the relief of pain?
Sir, 6 months to 1 year.
6 months to 1 year. Okay, thank you.
So did you have a count of platelets at any one of the cases? How much is the platelet count that is required for this particular?
No, sir.
No. Without that, you do not know whether the required, how much is the required platelets at the end of second centrifugation?
It's 3 to 5 ml.
No. Platelet number. No, without knowing this particular basic count, how can you inject? That is number 1. 2, did you withhold the analytics during your
no, sir.
Your period?
Withhold, sir. Means
you said no, then
no, sir. Withhold the
because
analytics.
the very idea of PRP in grade 1 and 2, it is only functional. That is the relief of pain. Suppose had the patient has taken painkiller,
yes,
we do not know whether it is because of PRP or analysis. How could you differentiate? This is number 2.
Yes.
And then you said after that also you have taken X-rays. What X-rays? What are the changes in the X-rays after 2 doses of PRP? Because nothing will be seen except for joint relief. So these are the 3. Okay, thank you.
Okay, thank you, sir.
Correct all these things when you are present the next time.
Okay, sir. Thank you, sir.
So next paper by Konidara Nagarjuna. Again, PRP injection for treatment of partial ACL tear.
Good morning, everyone. Today, my paper is using PRP injection for treatment of partial ACL tear. Introduction. Exact incidence of the ACL injuries is unknown, but it is estimated about 4 lakhs ACL are torn each year, and about 2 lakhs reconstructions are done. Classic history of the ACL injuries begins with non-contact deceleration, jumping. Other injuries include external forces applied to the knee. Operative management includes the repair of the ACL and reconstruction with either autograft or allograft tissues, depending on the grade of the tear. Conservative management can be done for grade 1 and grade 2 ACL tears. If a non-operative approach is chosen, it should be aggressive. It should be with aggressive rehabilitation program and counseling about the activity level. PRP is one of the non-operative approaches. Platelet-rich plasma is defined as the volume of the plasma fraction of autologous blood having a platelet concentration above baseline about 3 to 5 times the normal range. Platelets contain bioactive proteins responsible for the attractive macrophages, mesenchymal cells, which not only promote removal of the necrotic tissue but also enhance tissue regeneration. Platelets, after activating, release a group of biologically active proteins that bind to the transmembrane receptors of the target cells, promoting cellular recruitment, growth, morphogenesis. Growth factors released from the platelets include the platelet-derived growth factor, endothelial growth factor, insulin-like growth factor, vascular endothelial growth factor, and transforming growth factor B, which stimulate the healing and repair. Objective to study and evaluate pain and instability and functional limitation of the knee joint following the autologous platelet-rich plasma injection among adults with grade 1 and grade 2 ACL tears. It is a prospective study conducted among 21 adults who are aged between 20 to 60 years who presented with knee pain due to ACL 1 and 2 grade ACL tears to the Department of the Orthopedics in GSL, Rajahmundry. Inclusion criteria. The patients came with the complaints of the knee pain due to grade 1 and grade 2 ACL tears and willing for the PRP injection and who are aged between 20 to 60 years with active lifestyle. Exclusion criteria: patient with known diabetic mellitus, refusal of the consent, previous history of the knee surgery, use of NSAIDs, and infection or ulcer at the site of the injection. Data collection: all the patients who represented to the orthopedic OPD satisfy the inclusive criteria are about 21. The data is collected from those 21 patients. The initial assessment: primary information include the primary information and including age, gender, body mass index all are recorded, and MRI basic investigations and MRI of the knee was done. Once the diagnosis was established as grade 1 or grade 2, PRP injection was given to the patient and are followed up to 6 months, and outcome is scored with the basis of AKSS score. About 34 ml blood was drawn from sterile condition, centrifuged for the preparation of the PRP. After preparation of the PRP was injected into the ACL under the guidance of the ultrasound. Using AKSS score, level of the pain, knee function are evaluated and recorded for each patient immediately before injection and after 3 months and 6 months later. Results and discussions. Mean AKSS clinical score for grade 1 ACL tear before injection is 71, and after 3rd month is 86 and 6 months is 95. Whereas mean AKSS functional score is before PRP injection is 76 and at 3rd month it is 87 and 6 months it is 95. Mean AKSS score for grade 2 ACL tear before injection is 65 and 3rd month is 71 and 6 months is 75, whereas mean AKSS score before injection functional score is 63, at 3rd month it is 69 and 6 months it is 74. Conclusion: finding of the study shows that platelet-rich plasma injection is effective mode of treatment for patients with grade 1 more than grade 2 tears of ACL tears of knee. PRP therapy is effective and significantly decrease pain functional limitations in patient. Autologous PRP injection is also safe and useful modality for treatment of conservative management of grade 1 and grade 2 ACL tears. These are differences. Thank you, sir.
Thank you.
So how could you inject this particular PRP into the knee joint? Is it ultrasound?
Yes, sir, with the use of the ultrasound.
So PRP should be done under sterile conditions.
Yes, sir.
Ultrasound.
Sir, ultrasound also.
So on the sterile.
Yes, sir. Sterile only, sir.
Sterile ultrasound I have not heard, but I don't know. Sterile, how can you have draped it?
Probe will be sterile, sir.
Probe will be sterile.
Yes, sir.
Okay.
In your study, have you taken any young adults athletics?
Sir, no athletics came, sir, but students came, sir, with sports activity. Who are in active sports, he came, sir.
No, because the study says even a grade 1 and grade 2 injuries.
Yes, sir.
With the simple exercises and good muscle building, it can go well with normal activities.
It's a grade. It's a with grade.
No, this will holds good when you do the young athletics activity. Okay.
Yes, sir.
Since you're applying for some club or anything,
Yes,
that carries some meaning. Okay. Thank
Okay,
you.
sir. Thanks.
May I invite Vijay Bharat to speak on management of tibial diaphyseal fractures with interlocking nail.
Good morning, sir. Today my paper presentation, management of tibial diaphyseal fractures with interlocking nail. Introduction, tibial shaft is the combination site of the long bone fractures due to its superficial location. Common in young or middle-aged people. Incidence is 2 per 1,000 individuals. Closure reduction and cast immobilization have previously treatment for low energy tibial shaft fractures. Recent decades, the use of intramedullary locking nails has become more popular. Aims and objectives: to study the period of union and union rate on radiological evidence, to study the range of movements at knee and ankle movements, to study the complications, and to study end results with other methods of treatment and other studies. Methodology, materials, study design. A prospective interventional case series study was performed over a period from December 2020 to November 2021. Study setting: orthopedics, Ashram Medical College, Malkapuram, Eluru. Study sample was 30 patients. Follow-up and evaluation. Patient is usually followed up at the 4 weeks, 8 weeks, 16 weeks, and 20 weeks and 6 months. X-rays are taken at every visit, and patient is assessed clinical for fracture union. Inclusion criteria: greater than 18 years of age, both males and females. Type 1 and type 2, and type 3A according to Gustl-Anderson classification. Segmental and comminuted fractures. Acute fractures which is less than 10 days old. Exclusion criteria: age less than 18 years. Type B, type 3B, 3C according to Gustl-Anderson. Patient medically unfit for surgery. Patients with open physis, pathological fractures, fracture non-union and delayed union. Pre-operative assessment and planning. On admission in the ward, detailed history was taken, noting mode and severity of injury, extent and type of trauma to the tissues, and detailed examination of the affected extremity. This is the patient position. We go for approach for patellar tendon split approach. Patient position on the traction table. Okay, this is a case scenario, sir. Pre-op X-rays and post-op X-rays, and after 6 months, case 1. This is the post-op movements. Another one is the case 2, sir. Post-op observation, complications: any restriction of movements at knee and ankle joint, any change in the limb axis, partial weight bearing started immediately on second post-operative day with the help of crunches. The average duration is range 2 to 4 weeks. Full weight bearing, the average duration of full weight bearing was 6 weeks. Results are assessed on the basis of ALHO and Acl criteria. Thus, this criteria considers 6 aspects: tibial malalignment and shortening, range of knee motion and extensor leg, range of ankle motion, foot motion, pain in limb, swelling. The functional assessment of the result is one on the basis of per Edwards, resumption of the activities of daily living, resumption of the occupation, pain-free movements and walking, squatting and sitting cross-legged. This is a union time with the grade of fractures. Closure fractures, mean union time is 16 weeks. And compound fractures, grade 1 is take 15 weeks, grade 2 union takes 17 weeks, and grade 3A takes 19 weeks. Union in about 100% of the fractures of the upper third united by greater than 16 weeks, about 80% of fractures of middle third united by 16 weeks, and about 19% by 20 weeks. About 60% of distal third fractures united within 16 weeks and 100% by 18 weeks. The average union time was shortest in the fractures of lower third of tibial shaft because of the dynamic interlocking technique with distal locking. Post-operative complications, we can see the superficial and deep infections and 2 patients and 1 patient, compartment syndrome and neurovascular injuries and thromboembolism or phantom embolism, stiff knee joint and implant failure and delayed union. Implant failure. A bent nail. One patient had bent nail after he started full weight bearing at 4 weeks. The same nail was continued but with guarded weight bearing until the fracture united. Broken nail, you can see that we had no cases of broken nail. We had 2 cases of breakage of locking bolt. Probably because of early full weight bearing, both fractures united in 18 to 20 weeks. Infection is a superficial wound infection was managed with the dressing and oral antibiotics. One patient had deep infection and presented with discharging sinus at proximal incision site. Partial weight bearing with the dressing and antibiotics were continued till the fracture unit until then the nail was removed and petalite and bearing cast was applied. Delayed union. Pemister bone grafting was in post-operative groin to the toe cast applied for 4 weeks. Gradual mobilization was then started. Both the fractures united within 8 weeks of bone grafting. This is the results. Comparative final results of various series of different modalities of treatment of tibial fractures of closure interlocking techniques. Discussion. The present method of closure tibial nailing omits the disadvantages of other method while including their advantages. It is advantageous over the period of AO technique. Due to the availability of new broad spectrum antibiotics, the golden period of 6 hours can now safely be extended for compound fractures. With the use of new third generation cephalosporins, we were able to operate our cases presenting even as late 7 days. Reaming resulted in the destruction of all vessels of the medullary canal. They found necrosis of inner 50 to 70% of cortex after reaming, while medullary nail without reaming can use minor damage to the blood supply. Conclusion. The fractures in our study united in an average of about 17 weeks. Interlock or intermedullary nailing done under image intensify has proven to be a one-time procedure leading to union in almost all the cases. This procedure allows early weight bearing, leading to earlier fracture union with less mobility, with less morbidity. Because of high union rate and low infection rate, we consider close interlocking nail as the best mode of treatment for diaphyseal tibial fractures. Thank you.
Thank you. Is there any take-home message in this paper? Just casually presented. Anyway, thank you, sir.
I think with this, we conclude the morning pre-paper session. And we thank the organizers for giving the opportunity to chair the session. Thank you very much.
Thank you, sir. Thank you. Here, now we have the spine session. It will proceed. And in hall B, there is a pelvis establisher session, which is going to be started in hall B. Hall B, the speakers are ready. In hall A also, the speakers are ready. I think those who are interested in pelvis stabilization can proceed to hall B. Those who are interested in spine can stay here. Thank you.
This is translated to this one. The voice. అంటే ఈ వీడికంతే ఉంది ఒకటి అట్లా Okay, na? So I request all the delegates in this dining hall to come to Hall A or Hall B, whoever has completed their breakfast, kindly proceed towards Hall A or Hall B. The scientific sessions are about to start. Chairpersons is all the delegates who have completed their breakfast kindly proceed towards Hall A for spine and Hall B for further academic sessions. The next session will be on lumbar disc prolapse case presentations. The chairpersons for this are going to be Dr. Surya Prakash, Dr. Nageswara Garu, and Dr. Naresh Babu Garu. And the expert panel will be Dr. Mallikarjun Swamy, Dr. Srinivas Reddy, Dr. Srikanth Reddy, Dr. Arun Kumar, Dr. Nagendra Garu, and Dr. Narendra Reddy Garu. So I request all these people to be ready so that we can proceed without wasting further time. Now, all the delegates in the dining hall who have completed their breakfast, kindly proceed towards Hall A or Hall B. I request all the delegates in the dining hall who have completed their breakfast not to wait there. Please proceed towards the academic sessions, either in Hall A or Hall B. Hall A, we have spine. So, respected chairpersons and delegates, after the brainstorming session of yesterday night, I hope you all had a feast both academically and culturally. And today we are going to start our session, morning session. We completed our free papers. And today we'll be discussing about the first case is going to be spine. With the chair of with the permission of the chair, can I proceed ahead? Yes, sir. The chairpersons for these sessions are going to be Dr. Surya Prakash Rao, Dr. Nageswara Garu, and Dr. Naresh Babu Garu. We have the expert panel here, 6 members, Dr. Mallikarjun Swamy Garu, Dr. Srinivas Reddy, Dr. Srikanth Reddy, Dr. Arun Kumar, Dr. Nagendra, and Dr. Narendra Reddy. The case is going to be presented by Dugineni Mahesh Kumar, and the moderator for this session for the case 1 is Dr. Leela Prasad B. Can I request them all on the dais, please?
Dr. Mahesh Kumar, please go ahead.
Good morning, respected faculty, delegates, and my dear friends. Once again, welcome all you to Ongole on behalf of OSSAPCON. Today, I am going to present two cases. My first case is
I'll just announce the format of the discussion here. Presenter will present the case and the moderator will take over and he will be asking the questions to the expert panel, and then we'll come to the consensus. At the end of the discussion, the presenter can present what he has done for the exact case. Like that, we'll be having two cases followed by lectures.
a 20-year-old boy walked to OP with complaints of lower limb radiation for the past 1 month, and it's aggravated for the past 5 days. On examination, left side SLRT is 50, power of both lower limbs is are 5/5, and no neurological deficits. Here are the pre-op radiographs, AP and dynamic views. And here is the MRI. This was taken on November 2021. It's the lower end plate cut of L4. This is at L4 L5 disc level, and this is for showing normal neural structures.
So we go back to the images, and I'll ask Leela Prasad to lead the discussion.
So Mahesh, we are looking at a 20-year-old boy with left-sided
radiation.
Yeah, so left probably L5 radiculopathy.
Sir.
So how severe was the pain? You were saying he's able to walk.
For the past month, he was able to manage whatever pain with it, and for the past 5 days, he is not able to tolerate, sir. So he came to OPD.
So because you mentioned his walk to the OPD, so I was just thinking on the severity of the pain. So, and what about the MRI? So X-rays, no instability.
Yeah, taken, sir.
Show the MRI. So any comments on the MRI, the panel members? Shrikant?
Looks like the first episode. No disc degeneration, like hydration, everything is well maintained. So I would like to go for conservative treatment as a first line treatment, not for this case.
Any different opinions?
Sir, first thing, was he on the conservative treatment for the past 1 month?
No, he was.
No.
He was.
So definitely, if that is the main factor to look after, because if he was on a conservative treatment for the past 1 month and still the pain has aggravated, then the treatment option would have been changed. But still now it's definitely pharmacological therapy.
One thing to add, on examination, how are the SI joints and the hip joints?
SI joints are normal, sir.
Yeah, it's better to have a screening of SI and hip with every LS spine when in a young male patient.
SI joint and hips are normal.
Because this looks like a very minor disc bulge, I'm really surprised that this could cause severe pain. So first, I should exclude the other causes of left leg pain, SI joints and hip joints.
moreover, annular tears, we have presentation will be like that of a disc, right?
Okay. There's no annular tear over here. There's no annular tear over here. So next. Sir.
I think in this case, we are not highlighted the whole spine. Scout film should be taken, number one. May not relevant to this case. But at the same time, distal vascularity has to be checked. That is not mentioned, isn't it? Of course, as well mentioned by them, you have to rule out any inflammatory disorders also, isn't it? Always better to be with a whole spine scout film along with SA joint, as you mentioned. That's a good point. Yeah.
And I manage conservatively with conservatively for 15 days. I use steroids, sir, in the decreasing way. After 15 days, he came to OPD. He is completely normal, quite happy with the treatment, and he left.
Yeah, this is one important point what Mallikarjuna Swami has pointed out. Distal vascularity and vascular issues. Post-COVID, the leg pains actually after DVT incidence is very high, and also thrombosis, arterial thrombosis are also getting very high. So can you describe the dermatomal distribution of the pain? Did you?
Yes, you have not mentioned
Dermatomal distribution of the pain.
Dermatomal is L5, sir. That too, we can't differentiate dermatomal that get only radiation pain. Other than that, nothing is there.
No, was it any specific pattern? Was it behind the leg or on the side of the thigh?
No, only lateral aspect.
Lateral aspect. So that confirms to points out L5. And I think now regarding this whole spine MRI, most of the MRI centers are giving the whole spine scout film as well.
Yeah. Actually, I took it from PAX. Sorry, I missed it.
So this is a case of L4 fat disc collapse. Responded well to
Again,
conservative treatment.
continuation is there.
Yeah, continue.
Elder Prasad, see, you said you had put the patient on steroids, right?
Yes, sir.
Do you routinely do that, or is it something, a protocol which you have developed in your practice? Because suppose, for example, now with COVID, as people have said, indiscriminate use of steroids, you've seen in the newspapers, hip arthritis is becoming a big problem. So now even for a very mild bulge like this, if you keep putting on steroids, it may good for the, I don't know if it really does so much for the disc, but then definitely you are putting it hips at
Actually,
risk.
what protocol I am following right now is for the small disc and dural tears. I start with DEFCOD 6 mg TID for first 5 days. From 6th to 10th day, I will taper to BD, and from 11 to 15 days, I will keep on OD, sir.
It is nowhere steroids are given as a standard of care in management of the lumbar disc related issues, or just probably it's a practice option.
Sir,
I think 15 days is a little too much. Just give him a short course of steroid for maybe for 5 days, and if the pain settles down, then you can stop the steroids.
To augment what Dr. Suran told, see, as mentioned literacy, there is no support for you. Suppose if you're using as an NSAID anti-inflammatory also, it's a well-contained disc. It has not come out of the annulus fibrosis, isn't it? Suppose it's causing local autocoid reactions. Suppose if you use as an anti-inflammatory, that is not required also in this case. It's a well-contained disc, isn't it?
So if the pain is severe also, I think instead of giving oral steroid, a transforaminal would be more better, I think, so, than an oral steroid. If the pain is severe.
No, actually, this is a well-contained disc. I think they will do very well with the physiotherapy and other NSAIDs. I feel our colleagues also will agree. There is no role of steroid and personally speaking in this case.
Okay.
the same patient turned to me on Feb 22, and he was carried on a stretcher. Now he came with lower limb radiation, severe, and on examination, left SLRT 40, right cross SLR 50, EHL weakness left side 3/5, and ankle dorsiflexion weakness on left side. And bowel and bladder are intact. The X-rays are more or the same, no instability noted. And this is a
This is the repeat MRI.
repeat MRI on Feb.
Yeah, so almost looks the same.
This,
Can you
Is there any, like, did you put the both slides side by side? Did you put both the slides side by side? The previous MRI and the.
Maybe a mild increase in the bulge, but so it's a case of relapse of the radicular pain, and it's as you have said, it's very severe pain.
Yes, sir.
So what are your options now, Nagendra?
As per the MRI, there's no much increase in
Yeah,
the disc
correct.
prolapse or compression, sir. I think clinically examination, some other cause has to be ruled out first. I think we would be missing on something else also, because with this deficit, we don't expect
Yeah,
3 by
with this such such a small disc, you don't expect such severe pain.
Yes.
Yeah, fair enough.
I think we all know that what are the MRI findings is hardly matters actually. Your clinical examination is matters always the case. You may be having a huge disc but no deficit. You may be a small disc with a major deficits. But when you clinical correlation is not correlated with the imaging, you have to re-examine the patient, re-look into it. But when you are correlating both, it means something. What I emphasize that you should put effort, all the effort. Clinical examination is the first.
Somehow this patient with this MRI picture coming with a foot drop, there is a gross clinical and radiological mismatch. So instead of jumping onto, disc or a lumbar disc rupture as the cause for that particular entity, I think you should investigate him thoroughly to see why he has developed the foot drop.
You can augment with your clinical examination. You can go for an ENMG studies that will tell you exactly this really dealing with the neurological issues or something else, isn't it?
Any other
what all investigations, maybe panel you can ask for. If you have a clinical radical mismatch, how do you evaluate in your regular practice? Maybe Narendra Reddy can
Get
start.
NCV, sir.
NCV.
Yes.
Nagendra?
Same. Just peroneal now we'll be examining and we'll be looking for any NCVs and ENMGs.
Srinas, NCV. Srikant.
Also, as
So anybody wants to take whole spine screening, go cervical,
Definitely.
thoracic?
It was mentioned previously that cervical was whole spine was normal, so that's why we're not.
I took we get
Contrast
whole spine
MRI.
screening, sir.
Any role of contrast MRI? We had a case where we ultimately ended up in identifying something like similar case. We went on investigating for reason for the pain. So ended up with intradural AVA malformations, so which were not picked up on a routine MRI because they show like fluid voids. Unless you take a contrast and closely look for them, you can't find it. But as Surya Prakash sir said, with this MRI, we are still not convinced about the neurological deficits.
Were you convinced that this was the cause of the foot drop and disc pain?
I mean, clinical, no distal vascular deficits and no other organ, this thing. No, other than spine, I didn't find anything specific. So I took him for surgery. Intraoperative axillary disc fragment, which was there in axillary disc fragment. I took it up post-operatively on the second day. Normally, I discharged on second day. Second day, he was able to walk comfortably and he gained power 4/5.
Interesting.
Then you should look back whether it is really neurological deficit or painful inhibition of power, something like that. So it's very unlikely to have a very gross deficit.
With this kind of MRI.
Only one possibility because this MRI is taken in supine, not in loading.
And why didn't you try this root block?
No? You have to think of dynamic MRI actually. Low weight bearing MRI that could have been answered.
I think there's an important point here. Whenever there's a clinical radiological mismatch, so you should always go back to the patient, re-examine him. And if you have any doubts, better get him evaluated by a good neurologist and reconfirm it's because of disc only. And EMG NCVs are very technician dependent because I mean you should tell him what you're looking for. And I'm sure most of us cannot read this, cannot make out from this EMG NCV we just prescribe, then we don't know what to expect from it. So it should be better done in in conjunction with a neurologist.
Sir, any
It's very
intra
technician
pictures, sir?
dependent.
Intra pictures, anything? Axillary disc in this case, usually caudal migration will present in axillary disc.
Axillary disc.
And this is very fair disc bulge.
Yeah, this looks like a very
Intra
naive
pictures
disc.
would have been better.
What I suggest in this case, if you leave this patient for a natural history of IVDP, you would have recovered. Surgery is not allowed.
And
Sorry to say that.
why didn't you try this root blocks? Because in your treatment options, you have mentioned the transfemoral steroids. Why didn't you give a thought for it?
Frankly speaking, I'm not trained, and moreover, in my area, no.
Okay, fair enough. So I think you must be the better clinical judge because you have seen the patient. You're not seen the patient, so
Actually, in one of the talks earlier where free papers are presented, there was a paper on the tibial fractures. See, in the first statement of the slide, previously the tibial fractures were being treated with cast and reduction. That was one of the statements, as if was a thing of the past. So it's like this. Maybe there are other compulsions for which the procedure was performed, but as long as the surgeon and the patient are happy,
so all is
then
well that ends well.
That's where
It's
the
okay.
matter ends.
No, he was discharged.
No,
Sir.
Mahesh,
Good,
no,
good.
the discussion should not end with wrong
Again,
impressions.
continuation is there, sir.
So it's once you see an image like this, in spite of patients having too much a deficit, if you are not convinced with clinical radiological correlation, it's always mandatory to look for the causes until you identify a cause and then document and do it.
Continuation is there, sir.
So the take-home message for this case is whenever there is a clinical radiological mismatch.
No, he has one more follow-up.
Gurunda? Okay. Carry on.
After 1.5 months, he presented with left lower limb radiation. Left SLR is 40, and left. These are the power, sir. This is the MRI following surgery after 1.5 months.
Iatrogenic disc prolapse.
So initially you had right side dipsy right?
No, left
side.
Left.
Yeah, of course. It is definitely sitting on the narrow root now.
Yeah, now we are convinced.
Yeah, this is what Eugene Karaji describes. When you have a contained disc, huge disc, if you want to remove that content, it is extruded, sequestrated outside the annulus, outside the PLL. It's very safe to take it out. When a disc is very contained, the annulus is intact. The only way you can take out the disc is to do a annulotomy and go inside and take the disc piecemeal. So those cases, he documented that those patients had a worst outcome and the highest chance of recurrent disc prolapse. And also the patient, if he is very young and the disc height is more than the vertebral height disc height ratio is so high, then they have a very high chance of developing deficits. Recurrence. This looks like recurrence, but we still can't say whether it is disc fragment or not unless you take contrast MRI and then document the hyperintense fragment is the disc or not.
Sir? Yeah, sir, paid, sir.
So anyway, so now we are convinced that the pain is due to the disc. So what next?
Sir said maybe on contrast MRI. Because revision surgery, convincing patient for a revision surgery.
So contrast MRI has been done and it has been confirmed it's a disc, recurrent disc.
If at least now on examination, the power is near normal, and now the only symptom is pain again. So is pain a absolute indication for a redo surgery? That is what we have to think now.
So what will you do?
Probably I will try with a neural block again.
Okay.
Instead of going for a revision discectomy and a fusion, because pain is always a relative indication with a normal neurology.
So patient says, "Na pain alagana taggipovali."
So whatever
Already
the patient says,
surgery
if anything goes wrong, it is the surgeon who has to answer. So we should not go with what the patient says. We have to take our own judgment. That's what I feel, and we have to convince him according to our own idea.
So you will go for a block.
I'll try with the block. If
Yeah.
there is
Arun?
improvement, then.
Getting the patient back to the OR within a month itself is not an easy job. So once definitely, as Nagendra said, the trial of conservative therapy again plays a role in like a block. We can just tell it to that, discuss it with the patient himself. Yes, we are going to try it with the block and see if it works out. And if that does not work out, and then we can get you back to the OR again and get your pain down.
If you are convinced and if you have decided to do surgery, again, will you do revision discectomy or fusion?
So you have given a block, it does not work. So what next?
Then definitely revision discectomy. As seen, the facet joints are good. There is no instability as such. So I would go for revision discectomy again.
Naresh?
So this case, if you had ended up doing surgery, my personal choice would be do fusion, because you burnt your fingers twice. I don't want to have a third chance. And also it's documented in the literature, the younger the patient contained the disc, there is high chance of recurrence. Yes, you can still manage with the discectomy, but you should be very confident and convincing the patient, and also look into his occupation, what kind of job is involved, lifting weights or office job. But it looks a little overkill to fuse this disc segment, because disc is very pristine. And it's only the fragment which is coming out. But if you see the long-term results of these patients, once you do discectomy and fuse, you can forget about the pain forever. If you are able to convince the patient that it may come again, but I am avoiding fusion for you, that's a personal choice. But in my practice, this kind of second discectomy which happened in my hands, I don't take a chance of doing discectomy again. I prefer fusion.
But
Yes,
at the age
sir.
of 20 years, there is chance of adjacent segment after
Yeah,
5
that's
years.
there.
That's
No, I'm not worried about this. I'm worried about the present segment. So if you tackle the present segment, then you talk about adjacent segment. You are unable to tackle the present, how you want to do the adjacent segment. So this is how I argue with the patient. If the patient is convinced, it's fine. If the patient is not convinced, we will tell them, I have a convenient statement to the patient. I'll go inside, check and see if everything is fine. I'll leave do discectomy. If not, I'll fuse it. If I find very unstable while doing discectomy, but we need to take flexion extensions and find out what is the reason. It's a simple discectomy in a contained disc has prolapsed. How sure that this won't be relapse again? The third time disc prolapse can happen again.
BSP, sir.
I think younger the patient, better to fuse the revision. You may escape with an older patient, but as Naresh told, better to fuse it in this case.
Is alpha sacralized? I did not see that. So it's not sacralized.
These patients actually, after a month itself, they come back to you for another problem. So when you tell them that you want to do just to do again a discectomy, the next question they will ask you is, what is the chance that I may need another operation later? So these are the issues. I think I partly agree with what Dr. Naresh has said, because it is basically now becomes more of a practice option. Suppose if in a government hospital or in a public sector, massive hospital where the costs of the surgeries are taken care by another entity, government, insurance or something, then basically the patient only has to undergo operation. The money matters, is not much bothered. But a cash patient into a private hospital, it's very important that his worries are addressed. So, but the best way is to put both the options in front of him on the table and let him choose, so that you have an escape when they come back to you. Suppose, God forbid, a third incident happens, and that probably would warrant an intervention. Then, yes, you can say that I have already told you earlier, there is a possibility that that is also there. I mean, what Naresh has said is very important, because again here, it's a question of retaining the patient, and your income also comes into consideration. But these are different options, but this is not science. Science is, yes, you have to put both the options right in front of him and then let him choose what he wants. But here, both the revision discectomy and fixation fusion are okay, according to me.
So both are the options, viable options. Yeah. That's the first option.
We'll go for, we're running out of time. We have
Gopal sir, next model.
yeah, a quick, next. So next case will be moderated by Dr. Gopal Krishnaya. We'll quickly finish and then go to the lectures. Yeah, what was done after this?
No, I advised to Fusion, sir. They will come on Monday. I think.
Post-conference fusion. Yeah. So we're going to say all the conference, this panel has agreed to fuse the patient. So, so you have a scientific evidence, expert panel opinion to fuse that is.
Second case, sir. 30 years old male with the right lower limb radiculopathy since 10 days. And he is complaining of difficulty in walking and doing daily activities. On examination, right SLR is 40 and power normal and bowel normal. These are his dynamic X-rays. MR. Say L4, L5 sequestered at this right side.
I should go back to X-ray.
Sir, X-ray, sir. Sorry, sir.
Yeah, Dr. Srikanth. So what is your opinion on seeing the X-ray?
So there is disc angulation in flexion extension. There is increase in angulation at L4-5 compared to the other disc. And there is a narrowing of the disc space also. So that's one main, and there are posterior osteophytes at the L4-5 level also, as you can see.
So do you consider any instability at the
Definitely,
level?
clinically, I will rule out instability, like there is instability catch or anything like that.
On
during
X-rays?
examination. Yeah, X-rays are showing mild instability also. There is no listhesis as such, but there is disc angulation as well as posterior osteophytes as well as decreased disc height.
Extension is oblique view, sir. Koncham oblique extension.
So, Dr. Leela, sir, so do you consider instability as a translation or a change in the angle at the disc level?
Yeah, both are
what do you
important.
consider?
Yeah, both translation as well as angulation is also important. But here I think this angulation is very mild. So I would, how about the back pain? How severe is the pain?
Sir?
How severe is the
He
back pain?
not able to even turn on bed and he is not able to mobilize. Huh?
More of back pain or more of leg pain?
Leg pain.
Leg pain.
Leg pain. Because
So-
of that leg pain, he is complaining.
So, Mahesh, what is his profession?
Sir?
Profession?
Tea shop vendor, sir.
The very fact that in an acute scenario, he is able to open the disc space so much indicates that the back pain is not that much.
Yes, sir.
With this much, if we can get in a flexion, if we
Yeah.
can do this much, this means predominantly it's radicular.
Yes.
That's what he is like. His leg pain is more of a, because of that radiation, he is not this thing.
And again, it's very, see, upper buttock pain sometimes is said as hip pain and back pain. So
Yes, sir.
we have to clearly see where the patient points his fingers at, where the pain is.
And again, patient, you have given a history of only 10 days history of radicular pain because the disc looks a long-standing problem. So does he have any previous episodes of back pain before leg pain?
No, sir. He for the past 10 days only. Previously, he didn't have
Never
any back
in
pain.
his- Okay. So MRI is quite clear. So Naresh sir, what do you do for these patients?
This kind of scenario, go back to the sagittal X-ray. I consider it as a adjacent segment fusion level because the L5S1 is sacralized X-ray also. So X-ray, once X-ray. You see that the rudiment disc at S1. So this is almost like above adjacent level, which is highly possibly unstable situation. That's the reason why you could see that much of disc herniation happening at that patient at that level, and that is a potentially unstable segment, but may not be clinically unstable.
And sir, Surbegar sir, do you think this event was happened only 10 days, whether the disc degeneration has been there for a long time and with a sudden some kind of physical activity, it is aggravated?
No,
Or
this
it's
is definitely, see, a substantial portion of disc or the nucleus coming out could have happened 10 days back. But I think this chap must have had annular fissures, tear, some sort of a disc rupture, either central or to one side, for quite some time in the past. Because many people have these symptoms and they don't really complain anything. Suppose, like many times we have seen somebody comes with a severe left-sided radicular pain. And then when we do an MRI, he has the one level disc, which is completely on the opposite side. Actually, if the patient said if the pain is on the other side, he would have still contemplated to the tune of given considering surgery. So these are very common. So I think it is very, very possible that substantial disc rupture would have already happened earlier. The last 10 days back, maybe a sudden thrust of nucleus migration.
So do you consider the above disc in this case?
So it is a typical case of Bartolotti syndrome, isn't it? It is already L5S is fused.
Yes.
L4-5 has become like L5S1 now. The high chance of disc failure is very high. Yes, colleagues have mentioned it is gone for quite a long time. Probably it has come to the end point that time he has presented with the last 10 days. That's all you can say.
So how do you manage this case?
Definitely by seeing MR, it tempts me for surgery. But
Yeah, definitely
duration
surgery is
only-
required. So there is
but
no doubt
showing
about the
short duration
surgery.
of symptoms, no weakness.
No. Okay.
Can
So-
we try conservative?
So do you want to try conservative in this case?
I said MRI is definitely pro for surgery, but
No, not
patient
the MRI.
notice-
The patient is having severe pain, not able to turn around in the bed.
Then microdiscectomy.
So you do microdiscectomy. Okay.
Sir, fusion because disc itself is there's reduced disc space and dehydration is there and angular.
So what kind of fusion you want to do?
So T-leaf, sir.
T-leaf.
T-leaf,
Okay.
complete T-leaf. Because taking out the disc from micro discectomy level, it will be difficult also. Micro discectomy.
No.
Is difficult or easy in this case?
Difficult or easy? Extruded
Maybe it
disc.
is extruded, but taking out this amount of the extruded piece from the small area, it might injure the nerve root also sometimes. And post-op radicular pain, I have seen, sir. There's very big disc. I'm very happy during when I take out the big piece from the axilla, from the shoulder, wherever it is, and post-op they'll say some numbness,
No.
the pain.
See, the disc extruded fragment should not dictate your surgery.
No.
At least microdiscectomy
Fusion. I mentioned fusion for the different reasons, sir.
I think this fragment can be comfortably taken in a microdiscectomy. That's not a big problem. Because the extruded piece is lying outside. Only thing is you need to mobilize the root and take out the fragment.
No, for
If
this case,
you're not
fusion,
able to remove, you can do a little lamina, undercutting of the lamina so that it facilitates the disc removal.
Gopal, since this is a huge extruded disc and it's only 10 days duration, what's the harm in waiting? So this is an extruded disc and it's known that it can be phagocytosed. Why not?
So it's as sir told, it's you and patient should decide. So we can talk anything, but
So I think
given
definitely
the
it's
circumstances-
worth waiting for a while, keeping him under strict follow-up. If he still worsens, then we can always do a surgery later. But I think it's worthwhile giving a conservative
So
trial.
how frequently you manage this kind of cases conservative? Are you successful managing these cases?
So for the conservative trial, even with this kind of
Can
discs,
all-
if just there is no deficit or anything, but I just put them on follow-up.
With this kind of radiological picture, with severe pain, clinical radiological correlation, what is your success rate with conservative treatment? Okay. Sorry.
So all disc pathology, we have a role of conservative. There is nothing called except cauda equina and intractable pain. These are the two things. Suppose it's ruled out instability. So although it is in all literature says there's an acute massive disc has come out, it has high chance of resolutions, high chance of it will reduce, isn't it? Compared to the small disc paracentral sitting on always and irritating the nerve. Massive disc always known to go for self-resolutions, all according to literature, unless the patient don't have any bowel and bladder, still we can enroll a conservative management in this case.
But most of the patients, they will have some kind of sensory symptoms for whole in conservative.
Just
That's what
sensory
I
symptoms are not only the indication for surgical.
Exactly as sir said, sensory symptoms is definitely not an indication for surgery.
So the canal doesn't look wide enough. I think if there had been measurements given in the MRI report, this doesn't look like a wide canal. This looks like a narrow
As we
canal.
already mentioned, literature not supporting the immediate intervention in a massive disc prolapse, acute, because they have got
What
a
is the harm in
natural
waiting?
resolution. Unless patient is not ready to wait and vice versa.
What is the harm in waiting? He has no deficit,
Unless,
just pain.
I
Wait for another 10 days.
I think there are few points which we have to consider. Why do we ever do a discectomy or this? Because we want to give the patient a better quality of life. Again, the context changes from scenario to scenario. For somebody who is say a 45-year-old or at this age group with such a distress, and he cannot afford to wait so long before he can go back to work. So in such a patient, definitely I feel waiting and trying to allow his own body to resolve it may take 6 months or a year, but he'll lose so much in the process. See, that is one part which we have to also consider. Suppose this happens in a housewife and who has so much of support at home and she doesn't need to do anything. Maybe we can still wait. But then looking at the sort of pathology this has been, for all you know, I think there could have been deeper layers which have been already ossified or calcified because it's a very chronic problem. And this sudden acute spurt of the nucleus probably which has come out of some crevice is responsible for this. My threshold for surgery is very high in this, but for my threshold for fusion is less because this patient had disc degeneration for a long period of time and was not having back pain. So I think the facet joints and the entire environment, maybe segmental stability with muscles and all are quite okay. So probably, and then you see the adjacent segment is already degenerated. So at what level you will stop? You can't keep fusing from above and above. So in this scenario, my threshold for surgery is there. I would definitely offer a surgery for this patient. And I would go for a standard microlumbar discectomy, but then I'm sure the same thing can be accomplished with endoscopes as well.
That even I totally agree with sir. What sir said was absolutely right. One thing, we are not in the era where we put the patient on bed for the next few months and tell, yes, you're going to improve in the next few months, but you lose your quality of life, but you'll improve in the next few months. But that is not going, we are not in that particular era as I personally feel. So this definitely is a surgical case, even in my particular option.
I did open discectomy. Huge sequestrated fragment was taken out. Sequestrated disc.
Micro or endoscopic?
Anything, wherever your hands are good.
In this case, always literature supports that fragmentotomy is do well than total discectomy. What you have done is correct, whichever the method you would like, micro or endo, whatever the.
So I think most of the panelists agree for discectomy, not fusion. Okay, thank you.
Thank you, sir.
Sir, thank you. Thank you, Mahesh. Thank you, Leela Prasad. Thank you, the entire panel for your expert inputs. Now, now we will move on to the next lecture by Dr. Mallikarjuna Swami on decision making in PIVD. Sir, please stick to the time. We have a lot of orations waiting. We want to quickly finish and start the orations on shop time.
Good morning to everybody. First of all, I'm thankful to OSSAP team, Ongole team, Dr. Malladri Naidu Garu and Dr. Jayashekhar Garu, for giving the opportunity and having me here. Of course, he's already discussed very well about how to manage intravertebral disc prolapse, conservative versus surgical. I'm going to rebrush these things. And you know the burden of lumbar IVDF is about 5 to 20 cases in 1,000 adults. Most of the seen in the 3rd and 5th decades, males are predominant. And more commonly seen in the 25 to 55 is the 95%. About 5% cases may present in the back pain amounts to the intravertebral disc prolapse. And most common cause for in the younger age group, especially below 45 years. What is discosis? Is nothing but intradiscal tissue displacement, as you see in here. And next comes to the protrusion and prolapse and fibrous ankylosis. That is the end stage natural course of the disc. Degenerative disc diseases is a state of altered morphology and hence compromise mechanical efficiency of the disc, in which disc is unable to transmit loads evenly across the vertebral axis. And annulus perebrosis is preserved when you talk it about on intradiscal problems. When it comes out, then only you call it as uncontained disc. It will be determined by, you can always identify the MRI as well as the injecting the dye. So when it is non-contained disc, it may be grading will be there. It may be still contact with the disc, and fragmented means it will separate it from the parent and it will come out to the canal. And pathophysiology of IVDP could be biomechanical and biochemical, and it follows the pathophysiology. Most of the time, disc comes out. We all remember that it's a remnant of the notochord. It is not exposed to our immune systems. So once you come out, it into the epidural space, and immune system will be activated by media of 2 ways. It may be TNF alpha or interleukin. Suppose you follow this path, it can be resolved on its own. Suppose it's not followed, prostaglandin pathway takes up, it will cause us the severe nerve irritation. This is, one should remember that herniated intravertebral disc, about 75% cases can go for resorption if you wait for the natural history. And about 50 to 75% resorption, and all these cases, only 12% of the cases may require surgical interventions. And radiological regression of clinical symptoms, one should remember that the clinical symptoms seen before changes in the MRI, no correlation between the radiological regression and clinical symptoms. So how to approach to the patient with the intravertebral disc prolapse depends upon the young active adult or middle-aged or elderly or sedentary. One should go to the natural history and history taking the patient, whether the patient had repeated leg pain with a back pain, or back pain plus or minus claudication. This is more important when you are tackling. That means that whether it's having the only neurological symptoms associated with instability or not. Word of cautions, treat the patient, not the scan. Adequate counseling is very essential for each given case. And what are the evolution can be done? X-rays, most important is a dynamic views, flexion and extension. Doubtful cases can go for an oblique view. An MRI is the gold standard. CT scan, electrophysiology, one should not forget when you are not correlating clinically. Discography and psychosocial evaluation also for the completion's sake. To rule out instability, one should see vacuum sign, which is the most important. You can see there's an nitrogen collection in between the intravertebral disc flaps. Most of the time it will be loading and extension. It can absorb the nitrogen. Sometimes it can be released into the epidural spaces. And one should not forget to know any instability by taking the dynamic X-rays. In the MRI, one should not forget to take whole MRI. Scout film is important. One should not go for an lumbar spine means only lumbar. Whole spine screening is important for all the spine treating cases. Look for the signs of instability, especially fluid-filled facet joints. Especially it is more than 2 millimeters. It indicates that you are dealing with an unstable spine. At the same time, facet cyst. These are the two things subtle. Most of the time you may not observe in the MRI. These are the things or indicates that it may be having the subtle instabilities. Always one should look for the facetal fill fluid. Conservative measures, of course, rest. Of course, there's nothing called bed rest. One should not be more than 2 days. NSAIDs, physical therapies, not recommended in the acute phase. Muscle relaxant, corticosteroids, and limited evidence in the literatures. 90% cases respond to conservative measures in span of 6 weeks. Positive outcome factors, absence of crossed SLRT, and spinal motion extension that does not reproduce the leg pain, large extrusion and sequestration disc have the better prognosis, relief of especially 50% a leg pain at the end of 6 weeks, good fitness level of the patient, progressive improvement in neurological deficit and within 3 months. Unmotivated, no psychological issues, self-employed patient, they will do all better with your conservative outcomes. What is the poor outcome? When the patient you have clinical examination, cross SLRT positive, leg pain reproduced in an extension, contained and subligamentous disc, this is more important, and not recovered 50% leg pain at the end of 6 weeks, progressive deficit, Cauda-Equina syndrome, psychological issues, workers' compensation, unmotivated, these are all the poor outcome of factors. So factors which do not affect prognosis, like degree of SLRT, response to the bed rest, response to the passive care, age and gender, degree of neurological deficit, except progressive deficit, and Cauda-Equina syndrome. Outcomes with conservative management, non-surgery cohorts showed less improvement of WAS-B and WAS-L scores at 1 month. No difference between the surgery and non-surgery cohorts observed about at the end of 2 years. So non-surgical management may be a negotiable option even for surgical candidates in the shared decision-making process. That's more important when you're counseling the patient. Conservative versus surgical, long-term outcome surgical and non-surgical management of sciatica, secondary to lumbar disc herniation, 10 years result from the main lumbar disc spine. Although initially they show very good results for your surgical intervention, at the end of 10 years, you have marginal difference. Selective neuro root blocks is an outpatient procedure, fluoroscopy guided, good results in properly selected patients. My indications for selective neuro root block, posterolateral disc herniations, leg pain more than the back pain, non-concomitant stenosis, and less than 6 weeks of symptoms, unilateral pain, and good clinico-radiological correlations. One should observe here, arrow-shaped radiculogram have a higher success rate. Indications for surgery, intractable pain, significant or progressive neurological deficit, abnormalities of bowel and bladder, or sexual dysfunction, nothing but Cauda-Equina syndrome. Disc deflations, it can be laser or it could be automated disc removal or chemonucleasis or ozone. And none of these procedures I do personally. There is no experience of these procedures. Microlumbar discectomy is a gold standard procedure, adequate illumination and magnifications. It is very precise surgery. It can be technique for disc removal. It could be fenestration and laminotomy or interlaminar. Whichever the procedure you well listed, one can go ahead with this. How much disc to remove? Fragmentectomy and aggressive discectomy. Coming to this debate, fragmentectomy equivalent to re-herniation complication compared with discectomy, lower incidence of recurrent, low back pain, and higher patient satisfaction. Other surgical techniques, it could be tubular, endoscopic, transforaminal, or interlaminar. Which is best? Clinical variables like back pain, leg pain, and length of stay, slightly better with endoscopic. Magnitude of difference is very small. Difference is of no clinical relevance. Outcomes of tubular and microdiscectomy for lumbar disc herniation are largely almost equivalent. Do what works well in your hand. Leg pain with significant back pain. Fusion in cases with significant predominant back pain is always the option to fuse in your given case. Or again, come to the which fusion one should do. Depends upon the surgeon's preference, most commonly followed TLIF. You have a lot of options. You have at least 5 options. Olden time we used to do PLF, TLF, LLF, OLF, or ELF, or global fusion. But most commonly followed procedure is nothing but TLIF. Massive disc herniation to fuse or not. Discectomy is higher incidence of low back pain in recurrent herniation and segment instability, fusion adjacent segment, and degeneration. Functional outcome discectomy is slightly better in the fusion. Choice of procedure should be individualized. depends upon surgical expertise. Discectomy should be preferred, especially in developing countries like us. Disc herniation and modic changes, it may be type 1 and type 2. Negotiable correlation with the clinical improvement undergoing discectomy is better with a type 1. Total disc replacement, of course, won't suggest in personally in my patients. Summary, inadequate history and clinical examinations, leg pain or back pain predominant. Treat the patient and not the scan. Always take dynamic X-rays and whole spine MRI. Give a fair trial of conservative management. Fragmentectomy is good enough. Fusion should be undertaken only in indicated cases. Thank you. Thank you for your.
Thank you very much, sir. If any questions, we can take 1 or 2 questions before moving on to the next lecture. If there are no more questions, we can answer during the discussions. Thank you very much, sir. I will now request Dr. V. Suryaprakash Rao, sir, from Hyderabad to speak on surgical art of discectomy.
Hello, good morning. Before I begin, I would like to thank Dr. Naresh Babu and the organizers of the OSAP for asking me to come over and share our thoughts on this. Once we have chosen to do the discectomy, so this lecture is going to be very basic, just trying to understand or revise what is it we are intending to do in the discectomy procedure. Here, we're going to first review the brief anatomy and then just look at the few instruments which are going to be used, very important. Then what are the steps we, in the surgery, and then what are the other approaches? See, this particular, the image onto the left, do you have a pointer working here? Yeah. Yeah. This one. Anyway, so this is how a pristine neonatal, just infant's disc, and this is the elderly disc. So the homogenization of the disc and the complete degeneration is what happens. And it is in the early half when from this stage, it comes to this stage. From this stage, this comes to this stage, you have these disc ruptures, which really create problems. And then generally, as classic McNabb teaching, we have 3 stories. First story, which is the disc story. Then we have the second story, that is subpedicular level. And then we have the top story. So we have to identify which level is the disc. And then we have 3 zones. We have subarticular zone, which is under the facet, foraminal and extraforaminal zones. These are the zones with which we need to look at before in the scans to see where exactly the fragment is lying. And then one of the very important things is to know what is a traversing route and what is an exiting route. Suppose in this segment, we have L4 pedicle and an L5 pedicle. The route which goes under the L4 pedicle is the exiting route, and then which goes over the disc of L4-5 to exit under the L5 pedicle is the traversing route. So usually the L4, L5 disc prolapse does give rise to only L5 radicular symptoms, unless whereas the disc has gone to the side where it can affect the upper route, and suppose it is too big, so it can affect both the zones, that is both the traversing and the exiting route. So we have to be aware of all these as we see on the scans as we plan the surgery. Then coming to historical perspective, I think right from 1934, one of the first recorded, but then those surgeries were done transdurally. Later on, 1939, Lowe and et al. Have come on and developed the dural retraction and the removal of the disc. And then originally there was no imaging. So people used to expose right from L2, L3 to the sacrum. identify the sacrum and then count the vertebra before they used to do discectomy. And then from the late 70s onwards, with the invention of the microtubular retractors and the microlumbar instruments, this microsurgery has become fairly standard, and now it is accepted standard of care. And of course, Mallikarjuna Swami Garu has spoken about all this, so I'm not going to waste my time on this. Now, it all depends on how we need to go. Either we can go on the midline or either we go on the side. It all depends on which side you have the problem. And then paramedian and muscle splitting approaches are used usually for the foraminal discs and the extraforaminal disc, and midline posterolateral subarticular portions. Whenever there is a disc, it is usually approached translaminarly. And what are the various steps? Of course, anesthesia and positioning of the patient, then the access to the interlaminar window. Then we have laminotomy and ligamentum phloem resection and nerve root retraction, mobilization, followed by annular incision and removal. And the amount of laminotomy and ligamentum resection, it depends on how much one opens up the interlaminar disc space during the positioning of the patient. And here, generally, when people position the patient with regular horizontal bolsters, they sort of preserve the lumbar lordosis there. And then when we do that, which is the standard position as we plan to instrument the spine, the spinous processes posteriorly crowd together and it becomes difficult for the people to access. So then different positions have come forward. We have special positions where hips and knees are flexed to 90 degrees. Then there is a knee chest position, or the same position with horizontal bolsters with the kidney bridge and breaking the table. These are all techniques are employed to open up the interlaminar disc space. The problem here when you open up so much of interlaminar disc space is that the ligamentum flavum becomes very taut, and if there is a concomitant ligamentum flaval hypertrophy or a subarticular stenosis, many times in that position, because the disc remains free, the root remains free, then you wouldn't identify it. But when the patient comes back to the normal position, yes, you see a residual lateral canal compression. Of course, this is the steps of a classical laminectomy. I think most of the people here who have been into this field for last 20-30 years would have seen it, where here there is a technique which is shown using a nibbler, where you have first you remove the lamina completely, and then you remove the in toto, and then you remove the ligamentum flavum, you expose the root, you then retract the root, and then you do the classical laminectomy. The thing is that you preserve the pars above and the pars below, and you resect the entire lamina and a small portion of the superior half of the inferior vertebra, inferior lamina, so as to see the exiting roots under the pars of the inferior vertebra. Then, of course, these are all the important improvements. Obviously, microscope. Then you have this retractor, Maculas retractor. Now it is popularly known as Amanis retractor here. Then this instrument is really important. The third instrument, the bionated one, because as you retract, you need light falling into the field. And then we have this L probe then, and of course, upcuts and discectomies are mandatory. Generally, yes, once you expose here, you see the ligamentum flavum. You see the ligamentum flavum here. You see the ligamentum flavum. You make a small, separation here, and then you use your upcutter to make the laminotomy here, and then you retract the nerve root and remove the disc. And then use this L probe to check if there are any loose fragments in the pathway of the exiting root, and then also under the dural sac to see if anything is left. And many people wouldn't want to do an aggressive discectomy where they just explore the annular tear itself and then use the dural instrument to see if there is any fragments come out. Some people prefer to do a proper window of the annulotes and then go inside and check for the loose fragments. And then, of course, I think Dr. Mallikarjun Swami has addressed these questions. How much of course, amount of disc he spoke about. Now here there is how much of root needs to be retracted from the midline. Generally, I would say it is not a great idea to retract almost to the other side. Maybe to the midline is probably which we consider it as safe. But then when you see the narrow root very tented over the bulging nucleus, which is migrated posteriorly, it is always better to make room, do some discectomy, piecemeal work, and then the pressure on the dura comes down, and then you can safely retract. And some people, as I told, use only the annular tear to use, but some people make a big window. It's a personal choice. And how much of disc? My personal take is to remove whatever fragments are outside and go inside and check for any loose fragments and take them out. And then more resection doesn't have any great results compared to sequestrectomy. So the only another care one needs to take is as you push your discectomy forceps or pituitary into the disc space, you have to check the integrity of the anterior annulus, because if you go beyond that, there's a very high chance that you may take a biopsy of the intestine or the aorta. And then, of course, once we see the roots free and there is no loose fragment inside, and that would be the end of the discectomy. Of course, extra for foraminal approach, you need to go on to the parasplitting approach, look at the root which is coming from above, retract it laterally and take the disc out. Then we have these endoscopic discectomies which are popularized by Destendu. This is a microendoscopic discectomy. This is also fairly popular technique. And then we have the tubular discectomies with serial dilators, matrix of Medtronic has it. And then we have other approaches from Young, which are transforaminal approaches. And then we have arthroscopic approaches to basically using arthroscope. Sometimes you have a uniportal endoscope. So we have only one port, the same port for which visualization and surgery is done. And then we have two ports here where one, like a typical arthroscopically, one port for the light and the camera and other port for the instrument to do the discectomy. But then whatever approach you take and whatever procedure you do, remember the discectomy surgery is essentially to improve the quality of life of the patient there. And then we should ensure that the narrow root is free. And as a surgeon, we can only free the narrow root and then hope for the best as far as the patient prognosis is concerned. Especially in any young patient, when we are attempting to operate, we have to always warn the risk of recurrence of the disc. That actually will save your skin later in the day. Thank you.
You can stay back.
I think without wasting our time, we'll go for the next session and go for the persisting leg pain after discectomy. Case presentation by Prithvi Reddy.
So we'll have a short case presentation to lead to the lecture.
Naresh, sir,
Yeah.
shall we go ahead with the felicitation for session 1, before we proceed to session 2?
So we'll continue, sir. All are same.
Okay,
So we're
we'll
going
all
to stay here. Yeah.
Okay,
Yeah.
okay, fine.
So we'll have a very quick 1-2 minutes presentation followed by the lectures.
Keyboard. Good morning, one and all.
I'm Dr. Prithvi Kumar Reddy, spine surgeon in Malika Spine Center. Today, I'm presenting an interesting case about persistent leg pain after discectomy. We have a 51-year-old gentleman presented initially with bilateral lower limb radicular pain since a month, more on the right side compared to the left. Pain is so severe affecting his activities of daily living with severe claudication. He was evaluated initially elsewhere 10 days after the onset of the pain. On clinical radiological evaluation, he was diagnosed to have L5 transitional vertebra with lumbar canal stenosis of L4-5 level. The MRI picture showed stenosis at L4-5 with Bastrop disease at 4-5 and type 1 modic changes in L4-5 level. For the similar complaints, he underwent surgery in the form of posterior decompression, laminectomy, discectomy elsewhere. But following surgery, he was mobilized, but he had persistent pain with gradually progressing and worsening radiculopathy even after the surgery. After surgery, he presented us for the same. On clinical examination, he had an unhealthy surgical scar with slough and granulation tissue. He had SLR positive bilaterally at 60 degrees. And on examination, power was found to be 3/5 in L4 and L5 myotomes. Post-surgery, on clinical evaluation, the plain radiograph is this. An MRI post-surgery. These are axial cuts pre and post surgery of L4, L5 level. The persistent pain and severe radiculopathy, what could have been the reason in this case is the interesting thing.
Thank you, Prithvi. So we will get answers for all your questions in the lecture by Dr. Suryaprakash Rao, sir. So please have the lecture of Dr. Suryaprakash Rao, sir. Persistent leg pain.
Hello. Persistent leg pain after lumbar discectomy, it's definitely a big nuisance problem for all of us who do operate these cases. But then let's try to understand exactly why exactly this actual pain, why people have pain with the lumbar disc. Well, there are times when I have a patient who said, sir, I've got a lot of pain in the leg. And then when I asked for an X-ray of the spine, then I said, when there is a pain in the leg, why are you asking for an X-ray in the spine? So yes, we do encounter such patients, but then we need to explain to them that there is a problem there. Then we have to show them the bulb and the switch analogy, like switch is here but the bulb is there, but when you press here, that lights up or something like that. So in sense that yes, there are multiple reasons why this happens. Well, mechanical decompression, deformation, pressure on the nerve, we expect that should sort of compromise the microvasculature, irritation of the nucleus pulposus, because we all know that the disc protein is a sequestrated protein and then body mounts an antibody response to that. There could be intraneural inflammation, ischemia that can lead to functional changes, hyperelastability, a lot of other things. So this is the background for which you understand. We see them in 3 clinical scenarios, as I understand. One is no improvement after surgery. Patients come with severe radiculopathy. You operated on him, no relief. He comes back, or he says, still my pain has not gone. Then we have situations like patients come with radiculopathy, severe. After surgery, they will say, sir, whatever you have done, I don't know, but my pain is far worse now. That scenario also can be seen. And then they have a period of pain relief following which they have recurrent symptoms. I think Dr. Naresh is going to address that in his lecture, where there can be a disc rupture at an adjacent level, recurrent disc prolapse, epidural fibrosis, spinal instability, arachnoiditis. I think these are not being covered here. This, one of the first cause is a wrong level surgery. Yes, it is possible that when somebody is positioned, yes, sometimes it is possible. And it's not definitely uncommon. Whenever we have a long-standing compression or a very chronic disc where we see all those earlier changes already manifest, maybe some already pre-existing root compromise is there. In such cases, it is possible that they may take a long time for recovery. Then yes, insufficient discs removal or a missed fragment. Sometimes the disc may be compressed at 2-3 areas, but you have addressed 2 areas and you have not addressed the third area. Definitely the patient will have pain. Then of course, recurrent herniation. Then additional nerve root compromise is one of the biggest problems, especially when we have nerve root anomalies. Well, these things are definitely beyond our control at this point in time. But then, yes, we need to be aware of these facts. There can be a physical nerve root injury or during the surgery or trauma or whatever handling we have done intraoperatively can give rise to these problems. And as I told in the previous lecture, especially the patient has a disc rupture severely pressing on the nerve. At the same time, he's got a flaval hypertrophy and concomitant lateral canal stenosis. Though you decompress in the positioning, the ligamentum flavum has taut and you feel there is no lateral stenosis and you have not done a medial facetectomy, and then patient comes later with these symptoms. This is also possible. Then if you fail to recognize the segmental instability, spondylolisthesis in the patient, and of course extravertebral nerve compression along the course of the sciatic nerve, anywhere problem can happen. Well, of course, medical problems might be existing because this medical problem is there pre-existing, but after surgery, somehow it gets precipitated. Wrong level surgeries are not uncommon. According to one paper, 1 out of every 2 surgeons had one long level surgery in their career. So if we think that we have around 40 spine surgeons here, I think we have 20 wrong level surgeries done. And lumbar spine is the most common. And many times when there is an extremely small incision and then when we want to sort of retract and do, it is always possible with the pre-existing lordosis to get confused. And of course, whenever there is a scar, bony tissue, compromise, sometimes it is missed. Especially in patients who are obese and osteopenic, sometimes your lateral C-arm may not be very good in showing you if you don't have a good C-arm. That's another problem. And there is only and single preventive strategy, which is intraoperative X-ray. Once you have placed your retractors, once you have placed your tube, once you have placed whatever you need to do, then use your Penfield 4 or any instrument, you put it into the interlaminar space, into the midline, take a lateral view, and then reconfirm that you are in that disc space. I think this is gold standard and there is no alternative to this. Even if it means that it takes an additional 10 minutes, it is worth it. Of course, chronic radiculopathy is a big problem because there could be structural changes in the nerve root, chronic inflammation, formation of fibrosis or adhesions of the root, and combination of these factors. And of course, with chronicity, these come psychosocial and reporting sick issues. Patients who have been not going to work for a long time and then who will be using this back pain and radiculopathy as an excuse definitely do not do well, especially when there is a compensation associated with it, because they would want as much compensation as possible, claiming that they have not done well. Well, of course, psychological issues, depression, hysteria are definitely there. As we discussed earlier, that insufficient disc removal, retained fragments, and how much disc to be removed, Mallikarjun Swamy has already told. In my practice, I tend to do an annulotomy, check for loose fragments, and remove as much loose fragments as possible from the intervertebral disc space. And of course, sequestectomy has got better outcomes, but then instead of sequestectomy, if you do very, very limited fragmentectomy, there is always a possibility that you may miss fragments. But when we are doing this sequestectomy procedure, it is mandatory that you check the entire area 2-3 times to ensure that you are not left out anything. And of course, insufficient decompression of concomitant lateral canal stenosis. Then we have this recurrent disc herniation, which will be dealt in detail by Naresh. And then, well, we should be aware of this narrow root compromise, narrow root anomalies. Sometimes we have two roots coming out of one interspace. Sometimes we have one root splitting and taking into two roots and coming out. So these are definitely there, because most of these anomalies were detected in cadaver studies. So, and it's very difficult to suspect them preoperatively. But then I'm sure with a skilled radiologist, we will be able to identify. I suggest whenever you suspect such pathology, it is always better to go to the radiology suite, sit with the radiologist and tell him what you are suspecting, so that both of you can sit, analyze. As the sequences go on the monitor, you will be able to identify. Definitely hip pathology is very, very important. And then we have seen our friendly neighborhood neurosurgeons operate a lot of lumbar cases, thinking in terms of lumbar disc, and then ultimately they have AV and hips. This is also fairly commonly known. So it is very important that these pathologies have to be identified. Well, epidural fibrosis is an entity, but then there are people with epidural fibrosis with no clinical symptoms and also with clinical symptoms. So it is very difficult to correlate epidural fibrosis with the problems, but then most of these patients with epidural fibrosis as a diagnosis do not do well with surgery. So these are all the diagnostic tools: X-rays, MRIs, radiographs, MRIs, CT scan, myelography, EMG nerve conduction studies. These are all the tools we can use to sort of help us out to localize the lesion and to understand the pathology before we plan for any treatment. And then in management, of course, physical therapy is the first, then pharmacotherapy, rehabilitation, and intervention techniques like selective root blocks, facet, sacroiliac joint injections, radiofrequency pulses, epidural steroids, transforaminal, then treatment of psychosocial aspects, multidisciplinary programs, and last comes the spinal cord stimulation. All these armamentarium have to be used very judiciously in a recalcitrant patient for best outcomes. In summary, let me point out to you that it is not uncommon that we find a dissatisfied patient complaining of residual leg pain following a lumbar discectomy. Patients with long duration symptoms are at a higher risk, so we have to take extra time counseling these patients. Then from our side, we can reduce the intraoperative handling and retraction to minimize the iatrogenic damage which we give to the patient as we operate them, and identifying the high-risk patient before surgery. And if at all it is with a treatable cause, like a retained fragment or a specific entity which has been missed during an operation, they will do very well with surgery and appropriate revision surgery. And appropriateness of the treatment is dependent on specific combinations of the relevant patient factors. And all these have to be considered for treating such patients. Thank you very much for your kind attention.
Thank you, sir. And next topic, you'll go to post-operative discitis. Case presentation by Dr. Aditya Shekhar, followed by lecture by Dr. Leela Prasad.
Good morning, everybody. I'm Dr. Aditya Shekhar, Spine Fellow in Malika Spine Center. I'm going to present a case of a 50-year-old female who has presented to us with sudden onset low back pain, which was for 2 weeks, and which was progressive in nature and sharp shooting in character and associated with febrile spikes. The pain was 10/10 on VAS scoring. She had a history of surgery 3 weeks back for low back pain radiating to her left lower limb, and her preoperative complaints have subsided completely after the initial surgery. And she was symptom-free walking for 1 week. And there was no history of any discharge from the surgical site after the initial surgery, no history of trauma, and bowel and bladder were normal after the initial surgery. She was a known diabetic with poorly controlled blood glucose levels as seen in the slide, and highly elevated inflammatory markers with ESR being 50, CRP of 70, and WBC count of 25,600. On examination, there was a healed scar and no discharge from the scar and tight paraspinal muscles. And there was no local rise of temperature, but severe tenderness in the paraspinal region and midline. And attempted movements of the lumbar spine were severely restricted and painful. Her bilateral SLR was 80 degrees and neurological examination was normal. This was the initial presenting X-ray to us, where we can appreciate the post-operative status at the L4-5 level and L5-S1 level in the form of laminectomy. And when we have obtained MR radiographs in view of elevated inflammatory markers, we have noticed hypointense lesions in the affected vertebral bodies at L5 and L4 and intervening disc space. And on STIR imaging, this is what we found: hyperintense affected vertebral bodies with hyperintense foci in the L4-5 disc space. And now the question is how to manage this case.
I request Dr. Leela Prasad sir to come and give his lecture.
Any issue?
I'm waiting for my slides.
Yeah. Yeah, if it's taking time, we'll have a next lecture and then come back to you. Is that okay? Yeah.
Good morning, everyone. It's indeed a wonderful experience to get back to physical conferences. Probably in a spine session, this is probably the highest attendance I've ever seen in the past few years. Good to see people getting interest in spine. Next, next speaker.
Yeah, we are running out of time. Leela, we'll just sort it out because orations are waiting. Most prestigious sessions is coming up. I'll request Dr. Sai Krishna to present a short case presentation, followed by Dr. Gopal Krishna to give the lecture on dural tears. So audiovisual people, please keep ready the next lecture. Same slide.
Good morning. I'm Dr. Sai Krishna Gadde, OSAP Fellow in Spine Surgery from Malika Spine Center, Guntur. Today, I'm presenting a case of a 75-year-old female who's a homemaker coming with the complaints of low backache since the past 7 years. Back pain is insidious in onset and progressive in nature, associated with radiation of pain to bilateral lower limbs and occasional paresthesias. She was operated for the same symptoms 2.5 years ago at another hospital. Though her claudication symptoms were relieved, persistent backache was there associated with frequent episodes of headache since then. And recently, since 1 week, she developed new onset bladder incontinence. No history of recent trauma, constitutional symptoms, or gait disturbances, or no other contributory, past personal, family, or habitual history. So on examination, she's a moderately built woman oriented to time, place, and person, having stable vitals with no obvious toxic features. And on inspection, she had a midline surgical scar over the lumbar spine with no obvious dehiscence. Circumferential swelling is present around the scar, which classically increases on coughing. There is no obvious discharge or visible sinuses, and on palpation, swelling is soft in consistency with no local warmth or tenderness. Attempted movements are restricted with pain. So this is a short clinical video in which we can notice the bulge is increasing on coughing. And on neurological examination, all the myotomes of the lower limb was having power of 4/5, and the lower dermatomes sensations are impaired with intact perineal sensations and maintained anal sphincter tone. In her hematology, ESR is slightly higher, being 35 mm, and CRP is positive, and rest all blood parameters are normal. This is the pre-surgical images prior to the first surgery done 2.5 years ago, where we noticed degenerative levoscoliosis of the lumbar spine. And on the sagittal imaging, there is multi-level disc degeneration in all the lumbar levels associated with ligamentum flavum hypertrophy and near lumbar canal stenosis at almost all the levels. So this is the condition in which the patient presented to us in our hospital a month ago. Here we see the correction of the deformity with instrumentation of pedicle screws from L1 to L5, and good intertransverse process fusion is seen. And to evaluate the swelling, we conduct an MR imaging, and on the T2 weighted sagittal sections, we noted a hyperintense lesion posterior to the dural canal. At the level of L3, there is a communication from the spinal canal to the hyperintense lesion. And on T1 weighted images, the hyperintense lesion turned dark. And confirming it as a fluid on T2 weighted STIR images, the lesion is hyperintense. So we were confirmed that the lesion is filled of fluid. And at the level of connection of the dural space to the lesion, there are no obvious herniation of nerve roots. So how do we proceed with this patient?
Thank you, Sai Krishna. I think Gopal is going to give a detailed lecture on how to deal with the dural tears.
Good morning, everyone. First of all, I would like to thank the organizing team and Dr. Naresh Babu sir for giving me this opportunity. So I'm very happy to see good attendance. After a long time, we are meeting again in our state conference. Today, I would like to talk most of the orthopedic surgeons are feared about this complication, dural tears in lumbar spine surgery, because most of the times we do only extradural. Most of the orthopedic surgeons, we don't know how to handle the dura or spinal cord. So we are very much worried about dural tears. So I will go through the lecture. So dural is the most frequent complication in lumbar spine surgery, and at times it is the most frustrating for an operating surgeon during surgery. And it is an unintended complication. So whenever you encounter a dural tear, so suddenly your plan, and sometimes you may go blank, what to do next. So although the term dural tear is commonly used, but the incidental or unintended durotomy has been suggested to use, because the word dural tear itself implies a degree of carelessness. That's why the term unintended or incidental durotomy is the word is being described in the literature to describe this complication. So it is described from 1 to 13% of incidence in various primary lumbar spine surgeries, whereas in revision surgery it is 17%. And 6.8% of the dural tears may go unnoticed during surgery. So this is the incidence of the dural tears. In a simple disc surgery, it can happen in 2% of the cases, whereas in lumbar canal stenosis cases, 1.8%. Whereas in degenerative spondylolisthesis, especially with severe lumbar canal stenosis, the incidence may go up to 9%. Whereas in revision spine surgery, it is 17.6%. And if there is an associated juxtafacet cyst, especially in degenerative spondylolisthesis or severe lumbar canal stenosis, the incidence will be up to 18.2%. So these are the various risk factors for dural tears. Number one, it is more common compared to the males, it is more common in females and elderly people, and degenerative spondylolisthesis and juxtafacet cyst and revision spine surgeries. So most of the times we encounter dural tears in our early days of learning, and when you are doing in the first, maybe in the first 10 or 20 cases of your spine surgery, you encounter the dural tears. And sometimes if you are in a hurry to do, suppose if you have a next case is waiting, or you have a program with your wife, or if you are planning for a movie, in those are the circumstances where you get this dural tear and you stuck there. So the dura is vulnerable during the entire your surgery, starting from your exposure. Suppose if you don't see or identify a occult spina bifida, once you put your calf, it will directly land up in the dura and it can cause dural tear. And during a revision spine exposure, if you are going through the scar tissue, there is a more chances the dura can injured. And while you are removing the lamina or a hypertrophied ligamentum flavum, there are small additions will be there. Unless you separate the dura from the lamina, you may encounter a dural tear. So, and another tip is, when you are using most of the times we use 45-degree subcutter and it is easy to do. But when you are doing a decompression on the caudal lamina, suppose you are doing a L4, L5 laminectomy and you are doing a L5 laminectomy from cephalad to caudal direction, it is more prone to involve the dura, include the dura in the upcutting. That's why, especially when you are doing a cephalad to caudal decompression in the caudal lamina, it is better to use a 90-degree subcutter rather than a 45-degree subcutter. So this 45-degree subcutter is more prone to include your dura in the. And again, when you are doing a revision spine exposure, it is always better to expose the normal, that's the virgin area. From there, you make a tissue plane and go through your target's area. And after the laminectomy, you should try to avoid sharp bony edges and spicules to prevent further dural tear. They may pierce through the dura. So these are the 4 frequent happening zones, critical zones, that where the dural tear can happen. That is the caudal margin of the cranial lamina. Unless you separate the lamina from the dura, there are more chance. And again, cranial margin of the caudal lamina, when you are doing suppose in L5 lamina, in the L4, L5 laminectomy, and the herniated disc level, especially when there is a calcified disc, central calcified disc or paracentral calcified disc and sharp, which is protruding at the root dura junction. When you are mobilizing the root, that is the area where the dura can be injured, because it is very difficult to mobilize in a calcified disc, especially a huge disc. The disc is calcified, so it is not amenable. So there is more chances for the dura to injure. And the other part is the medial most aspect of the facet joint where the ligamentum flavum attaches. So that is the area you need to do a foraminal decompression. If you are doing a foraminal decompression, the root is just below the foramen, and that is where the ligamentum flavum attaches. While removing the ligamentum flavum, there is more chances you may include the dura. So what is the outcome of dural tear is, they may develop a headache, they may lead to formation of a pseudocyst, or it can form a dural fistula, which may prelude to arachnoiditis and the wound healing problems, infection, and rarely it can cause meningitis. So once you encounter a dural tear, the first and most thing is don't be panicked. That is the most important thing. What you need is just stop your surgery and wait for some time. And once there is a dural tear, the other headache is all the rootlets, they come out of the dural tear, and so you will be in a panic situation. So what you need to do is you just put a patty over the dural tear and finish your decompression job. Finish your whatever the discectomy or decompression. Then address the reassess the dural tear. So once you have done the decompression job, the most important thing is you have to get a good exposure of the area. So achieve good hemostasis. So you can pack gauze pieces around the muscles so that there is no blood leaking. Then most important is you have to reduce all the rootlets. So if there is a blood is soaking from the wound, you put a suction, the rootlets will go into the suction. So that's why you have to achieve absolute hemostasis in attempting a dural repair. Then you hold the edges of the dural tear with your plain forceps and try to reduce the rootlets with the dissector. Once you reduce the rootlets, 2 minutes. Sir.
Yeah, we're
Once
running
you
out of
reduce
time.
the rootlets, you can repair the dura by 40, 50, or 60 prolene. So if watertight closure is achieved, no additional precautions are required. You can keep a drain if the surgery demands, and no bed rest is required. Once if you do a Valsalva maneuver, if your closure is not watertight, then you can use adjuvants like fibrin sealants, muscle patch or fat patch, or commercially available collagen patches you can put. So in those cases, when your watertight closure is not there, you should request the anesthetist to get a smooth anesthesia recovery to prevent coughing and retching during recovery, and bed rest for 3 days, and leave the urinary catheter for 3 days and give good laxative to prevent the straining. So if you are not able to do a dural tear repair during surgery, in those cases, it can be covered with fascia, muscle, or synthetic materials are available. And these are the commercially available sealants where you can use them and do a watertight closure. Sometimes small dural tears can cause more problem rather than a big dural tears. In those cases, we may need to open a bit to do a dural repair. So sometimes the dura is teared, but the arachnoid is intact. So there is a CSF is not leaking. But in those cases, you can put a fibrin soaked gel form or a just simple gel form and do a watertight closure. That is enough. There is no specific restrictions required in the post-op. Suppose when you encounter the dural tear during post-operative period, intraoperative is gone missing. So what you need to do, go for a step-by-step approach. So patients will have symptoms of persistent headache, nausea, vomiting, and photophobia. And you can see a fluctuant mass and clear discharge. If there is a clear discharge, it's okay. If the discharge is associated with hematoma or seroma, you need to do a lab test to identify the CSF is there. That is the beta-2 transferrin test can confirm the CSF. The reason for the postural headache is the CSF leak. The confirmatory diagnosis is the postural headache. Once if you do a head elevation, the patient gets headache, that is the postural headache, the confirmatory of the CSF leak. So you can do confirmation by MRI or CT myelo. And so how do you manage a post-op CSF leak? Simple, put the patient on absolute bed rest, do a pressure dressing or adhesive tapes, and foot end elevation, and give oral acetazolamide tablets. Most of the times, small dural tears will settle with this. If you are not able to control the dural tear, this is the continuous lumbar drainage is the very good option, simple and safe option, where the anesthetist can keep a epidural catheter in the subarachnoid space and do a controlled drainage of the CSF. That is 10 to 15 ml per hour. That is an amounting 30 to 400 ml per day for 2 days. On the third day, you clamp the drain and see there is a wound, soakage from the wound. If there is no soakage, you can remove the catheter. So the take home message is don't be panic. Dural tear can happen for all. If possible, do primary repair best and watertight closure, and continuous lumbar drain mostly successful for post-op leaks. So unintended durotomy does not affect the long-term outcome of a primary disc surgery. So it may take another 20 to 30 minutes of time, but it doesn't affect the outcome of the index surgery. Thank you.
Thank you, sir. I'll call next topic case presented by Dr. Prajwal, recurrent disc prolapse, followed by Dr. Naresh Babu will give lecture. Yeah. Yeah, that's fine to me. We request again, Dr. Leela Prasad is going to speak on
Leela Prasad, technical team.
Yeah, post-operative discitis.
Good morning, everyone. Yeah, sorry for the technical glitch. There was a message on the group for all the presenters to post a short CV. So a very short CV of mine, and was also to post a photograph. Yeah, that's it. So post-operative discitis, another nuisance complication of discectomy surgery. So it was first described as clinical entity in 1953 by Turnbull, and it's essentially defined as primary infection of the nucleus pulposus with secondary involvement of the end plates and the adjoining vertebral bodies following a surgical discectomy. Incidence, an average incidence is 1%, mostly in lumbar disc surgeries. And usually there are no risk factors per se for post-operative discitis. And whether it's an aseptic process or infectious process, it's not has been established without any doubt, because positive cultures are only seen in about 50% of the cases. And the most important thing is early diagnosis, and delayed treatment can lead to increased morbidity. Clinical features, essentially, it's a clinical diagnosis. Typically, patient has an asymptomatic period after the surgery, and he comes up about 2 to 3 weeks after surgery with back pain. And at this time, the wound is usually well healed. Back pain is the main feature. It's a real pain for the patient as well as for the surgeon. The typical patient typically presents 2 to 3 weeks after the surgery. The back pain is very severe axial back pain. And patient it's really painful. It's painful to turn in bed. It has difficulty in getting up from sitting position. And he usually comes to the clinic holding his back, supporting his back. And he might be having night pain as well. And there may or may not be radicular pain. If there is any abscess in the epidural abscess, he might be having radicular pain. And also a neurological deficit. If there is any epidural abscess compressing the roots, you might have a deficit. Constitutional symptoms like fever are rare. Inflammatory markers, ESR, CRP are very non-specific. ESR takes about 3 to 6 weeks, so it's very difficult to depend on ESR for the diagnosis. However, CRP is a good marker to depend on. CRP returns to baseline within 10 days. So any persistent elevation of CRP after 2 weeks should raise the suspicion of an infectious process going on. And as I've said, CRP is definitely much better than ESR for the diagnosis of post-operative infection. And this nowadays, this procalcitonin is being used widely in the diagnosis of sepsis. However, it is not of much use in post-op spine infections. And this neutrophil lymphocyte ratio and absolute lymphocyte count are better indicators of post-op infections. Coming to the X-rays, in early stages, X-rays may be normal. If a patient comes with pain after the surgery, even if a normal X-ray, you should have a very low threshold for MRI. You should definitely go for an MRI. However, in late stages, you can see changes on the X-rays. You can see disc space narrowing. You can see end plate changes. And in very late stages, you can see collapse of the disc space, and you can see local kyphosis. MRI is very good diagnostic tool, a very sensitive diagnostic modality. However, it is not very specific, and the changes may be similar to other infections as well as routine post-op epidural collection. MRI may show, it shows a hyperintense signal in the vertebral bodies in the T2 images as well as the stir images. However, in T1 images, it shows a hypointense signal in end plate as well as disc. It shows abscess as well. And bone scans, technique PET scan, they're usually not necessary. MRI is enough. Diagnosis is basically clinical diagnosis supported with lab findings and MRI. Management conservative is mainstay. Surgical may be necessary depending on symptoms. The first thing is to identify the organism. You should make an attempt to identify the organism. That could be done by blood culture, aspiration, either it be a CT guided or a CM guided. Sorry, CT guided, CM guided, or endoscopic. Endoscopic guided has a better yield. Antibiotic protocol is based on the culture pattern. The previous protocol is 4 weeks of IV and oral for 6 weeks. Now 2 weeks of IV and 4 to 6 weeks of oral is sufficient. So this is a French study which says for 2 weeks plus 4 weeks oral is sufficient. And there is another study which says oral antibiotics are good enough. However, if cultures are negative, what next? You should repeat the culture, or you go for an open culture, open biopsy. And if, though you can give empirical antibiotics, though this is not scientific, but if in clinical practice, you are forced to give empirical antibiotics depending upon your common pathogens of your OT. So with conservative treatment, if your antibiotic, if you have positive cultures, if you give the right antibiotic, the patients heal uneventfully. Indications for surgery, repeated negative cultures to identify the organism, pain which is not responding to conservative treatment, severe unbearable pain, instability, local deformity, deficit, all these are indications for surgery. Surgical options may be simple debridement, irrigation of the disc space. It could be done with open or MIS. Instrumentation and debridement and fusion, and instrumentation alone. This is, you can give instrumentation alone, but you have to go for a long segment instrumentation. Implants can be used in setting of infection. And if you are using bone graft, autograft is the best. And if you are using cages, go for titanium cages, as they are less prone for colonization. These are a few cases. This is a 2-level discitis. This was not picked up, though MRI was done. They're showing subtle changes of infection over here. It was not picked up early. It was not diagnosed. Then it ended up with erosions. Patient had severe instability, severe pain. I advised surgery for this patient. Unfortunately, he didn't come up for surgery. And this is the same patient 7 years after, well healed. This is another case. So this was treated with surgery, the debridement and fusion. This was a neglected case, a simple L3-4. This was 1 year post-op. This guy is still roaming around with such a deformity and a lot of severe pain. Still, it's 1 year post-op. Is still going around with pain. This is a TLIF was done. Take-home message. So high index of clinical suspicion. Whenever any patient comes with back pain after surgery, importance should be given to identify the organism, and then appropriately can treat it either with conservative or surgery. Thank you.
Thank you, sir. We'll call upon last topic of the session. Dr. Prajwal, please. Recurrent disc prolapse.
Good morning, everyone. I'll be presenting a case report today. A 43 years old male patient comes with complaints of low backache with left radicular pain since 2 weeks after lifting heavy object. Pain is of sudden onset, progressive in nature, aggravated on movements, and partially relieved on rest and medication. Pain was associated with paresthesia over the left foot and also weakness of the left ankle. Bowel and bladder function appears to be intact. Coming to past history, patient gives history of similar complaints with right-sided leg pain and underwent spine surgery 3 years back. And post-operatively, patient was symptom-free and able to do daily routine activities. Procedure underwent in 2019 was in the form of posterior spinal decompression with right side laminotomy and partial discectomy at L4, L5 level. Coming to local examination of spine, there was obliterated lumbar lordosis with paraspinal muscle spasm with midline yield surgical scar mark present with no evidence of sinus, swelling or discharge. On palpation, there was no local rise of temperature, mild diffuse tenderness present over the lumbar region, and range of movements were painful and restricted. Coming to neurological examination, left L4, L5 power were 1/5 on left side. On right side, it was around 4/5 according to MRC grading with altered sensation over the left L4-5 dermatomes. Knee and ankle reflex appear to be diminished on left side compared to right side. And all surgical blood parameters were within normal limits. This was the 2019 MRI showing evidence of diffuse disc bulge at L4-5 with right paracentral protrusion causing compression over the thecal sac and right neural foraminal compromise. Recent X-ray showing evidence of posterior spinal decompression with right side laminotomy at L4-5 level. And current MRI showing evidence of extruded intervertebral disc at L4-5 level with central canal stenosis and bilateral neural foraminal compromise with post-operative changes. So what is the next line of management?
I request Dr. Naresh Babu to give his lecture on recurrent disc prolapse.
Thank you, Prajwal. So I'll be giving a short lecture on risk factors for recurrent disc herniation. Discectomy is a highly satisfying and commonly done procedure for prolapsed disc with excellent long-term track record. And that is a bread and butter for general orthopedic surgeon as well as the spine surgeons. But negative perceptions, the fear of recurrence, the only fear of doing a discectomy, while doing a discectomy or after discectomy, every time patient comes back, how is your leg pain? How is your leg pain? How is your leg pain? That is a common question we keep on asking. That is the fear of recurrence. So when do we call a disc as a recurrent disc prolapse? So another disc herniation more than 6 months after index operation at either ipsilateral or contralateral location is known as a recurrent disc herniation. The incidence is as high up to 15%. The risk factors, can we predict the recurrence? If we can predict the recurrence while before operating, so you'll be careful in operating the patient or choosing the patient or offering a exact surgical procedure. There are different, others have given different risk factors. It's aging from age, gender, smoking, BMI, duration of symptoms, alcohols and other activities. And there are a lot of multi-center research has also been done. Coming to the age, it's a debatable question. It all depends on the character of the disc, how it herniates. But younger age is known to have higher disc, recurrent disc prolapse because of the long years ahead and also the manual work, what they do. And also the older patients, the non-recurrent group are higher in the older patients. The men are more prone for recurrent disc herniation, and the smoking is known to cause recurrent disc herniations for significant association of 18.5% recurrent disc herniation. Nicotine has a direct effect on the end plate vascularity. Whenever chronic nicotine toxicity can lead to microvascular obliteration, and then that can lead to recurrent disc herniation. So cough increases intervertebral disc pressure. Nicotine causes vasoconstriction, and the hypoxia and poor circulation leading to recurrent disc herniation. Somehow the diabetes patients are also prone for recurrent disc herniation. Whenever you're operating a patient with diabetes, it's always take a caution to that high incidence of recurrence is possible in these patients. Coming to the type of disc herniations, which disc herniations are more prone for recurrence?
So this has been described by Eugene Karaji, which has been mentioning in the morning. He has described 4 types of disc herniations anatomically, how they herniate. You can see the first one is fragment fissure. In this particular case, you can see there is an annular tear, which is like a fissure, and the disc comes out. So this kind of patients has a low percentage of recurrence because you can just take out the disc fragment which has come out and the fissure will close. But the second type of is fragment defect, where there is a lot of defect in the annulus before operating itself. And then you take out the disc and the defect is open. It's like opening the door, so the disc can herniate multiple times. And there is a fragment contained herniation. This kind of contained herniations had the best subjective results. The disc has prolapsed, but it's contained. You just need to give a nick and then take out the disc. But the no fragment contained disc, these are the patients who had worst case of disc recurrences. This is a case which was presented by Mahesh in the morning. The first case when we try to operate and do a annulotomy, then there is a high chance of recurrence. So, but there is no way we can take out the disc without incising the annulus. So you should be careful in choosing these patients and exact type of surgery what we offer. So ultimately it boils down to how much of annulus is intact, how much of the annular defect is there before operating the patient. If the disc has come out, it's very easy to take out the fragment and the annulus can heal very nicely. If you have to cut and open the annulus and create the defect, then also there is a high chance of recurrence. If the disc has herniated due to a large defect already creating inside the annulus, they also have got a high chance of disc herniation. How do you know intraoperatively that this patient has got such type of herniation? Once you retract the nerve root, if you see the annulus is intact, should be very careful, should not try to give a large defect in the annulus to take out the disc. And those fragments like exclusion fragments, if you see small fragment popping up, you can just try to push the disc adjacent to the defect so that the disc herniates out automatically rather than you cutting and opening of the annulus. So other factors, which kind of discectomy is better, it's already been discussed by Dr. Suryaprakash Rao sir. And other incidents where there is a high chance of recurrence is the modic changes. With the patient presents with the modic changes adjacent to the vertebral disc herniation, these patients are known to have a recurrence disc herniations. And again, the patients with the retrolisthesis, if you're operating on a patient with retrolisthesis, should be very cautious because there is a segmental instability existing. These patients also can come back to you with disc herniation. Other way also to look at these patients is the facet orientations. With the patients, facets are oriented sagittally, then they tend to slip off post-operatively and patient can develop recurrent disc herniations. So this is how its tropism exists. On the right side and left side, there will be a difference in the facet orientations. Coronal on one side, sagittal on the other side. Adolescent disc herniations, this is also a very important factor. When we are operating on adolescent disc herniations, this disc herniate along with a piece of end plate. So to take out the disc, you need to cut that end plate and do a little bit of osteotomy unless you can't decompress the nerve. These patients also tend to have a recurrent disc herniation. To conclude, the meta-analysis shows smoking and diabetes has got high incidence and a use of disc height index, like disc, how much is the height of the disc, higher the height of the disc, chance of recurrence is high. And modic type, lumbarization or sacralizations and retrolisthesis, they cause highest chance of recurrence. Thank you very much for kind attention.
For completing your talk within stipulated time. Thank you, organizers. On behalf of all our chairpersons, thank you once again.
So you call all the speakers for a group photo once we finish off
before,
chairperson's felicitation.
Yeah.
All the speakers come on to
all the expert panels, please.
Dr.
Mallikarjun Swami.
And then we'll move on to the most
Sri.
prestigious session of
Dr.
the annual
Srinivas.
conference, the orations.
Dr. Srikant, Dr. Arun, Dr. Nagendra, Dr. Narendra Reddy, kindly be on stage, please. Dr. Leela Prasad Garu, Dr. Gopal Krishnaya.
Please, everybody come up.
Please come over the dais, please.
Yeah.
Dr. Mahesh, Dr. Mallikarjun Swami, Dr. Srinivas Reddy, Dr. Srikant Reddy, Dr. Arun Kumar, Dr. Nagendra, Dr. Narendra, Dr. Leela Prasad, and Dr. Krishnaya. Roses తీసుకురండి ఫస్ట్ పడింది చూడండి పని చేస్తున్నారు ఫస్ట్ రోజెస్ తీసుకురండి వీళ్ళకి ఇవ్వండి తర్వాత అందరికి రోజెస్ ఇవ్వండి షాల్స్ కూడా తీసుకురండి. షాల్స్ 3 షాల్స్ అండి. Just a minute for the photographers, we'll just put a shawl and then we'll take photos. Thank you. Let's proceed towards our prestigious orations. May I invite upon Dr. Durga Prasad Garu, State President of OSSAP, and Dr. Naresh Garu. He's already on the dais. So please come. So please take over the proceedings of the orations. Thank you.
Respected President of Orthopedic Surgeon Society of Andhra Pradesh, Dr. Y.V.K. Durga Prasad Garu. Sir, please take it. This is the most prestigious session of our annual conference. To salute our predecessors on whose name the orations have been initiated. It's my privilege to present the Professor Vagreswarudu oration. I will read out the short biodata of Professor Vagreswarudu, and we will be calling our orator of this year to the dais, and also Professor Chavali Vagreswarudu is born in a doctor family in Rajamandri, a place famous for Vedic pundits and poets. His father was an Ayurvedic doctor, and he developed interest in orthopedics while he was working with Dr. M.G. Kinney, trained by Dr. V.R. Tayamuniswamy, an eminent orthopedic surgeon, the first person to start a full-fledged orthopedic department and first professor of orthopedics in Andhra Medical College, Visakhapatnam. In 1948, while he was working in Stanley Hospital, he was deputed to Andaman and Nicobar Islands, where there was a polio epidemic was happening. On seeing the plight of polio victims, he developed interest in the rehabilitation of the polio patients. He was awarded fellowship to undergo training in rehabilitation of polio victims. He was always worked with passion, zeal, with an aim to make the polio patients not to depend on wheelchair and calipers and crutches. And he started Rani Chandramani Devi Hospital in 1965, started a camp of operations, and founder of Balaji Institute of Birds, what we called in Tirupati. And Vagreswarudu instituted medals in his name for the best paper presented by the consultants in AP chapter of IOA, IMA Visakhapatnam, IOA chapter Tamil Nadu, and medals for meritorious students in MS Orthopedics. He was president of Indian Orthopedic Association from 1970 to 1972, and the president of IMA of Andhra Pradesh for 1977 to 78, and founder president of IOA chapter of Andhra Pradesh in 1968. IOA conferred fellowships on him for this meritorious service to the association, and also for his service on physically handicapped persons in 1978 at Madurai conference. He conducted IOA meetings in 1971, 1990, and IOA conference was conducted in Visakhapatnam. Conferred with the honorary doctorate degree by Andhra University for his valuable service to polio victims. So these are his citations. Now it's my privilege and honor to introduce the orator of aggressive orator of this year, Dr. B. Shivshankar. I request Dr. B. Shivshankar sir to come onto the dais. I request Dr. Viray Chaudhary garu to accompany him onto the dais. So please, in the center, please. Yeah, I'll just read out your CV, sir. It's not just because of his competence, not just because of his capability, but because of his character and chemistry. We are here and felicitating him for giving a excellent oration. Professor B. Shivshankar, Shiva sir, as we fondly call him, he was IOA president for 2021. We had a fabulous IOA conference, IOACon at Goa. And we were discussing yesterday that God was very kind to give a short gap to conduct him, the magnanimous IOACon with 7,000 participants. Shivshankar had his undergraduate education from Hubli, post-graduation from Solapur. After additional training in Madurai, Birmingham, UK, and Germany, he is practicing in Solapur at Ayer Orthopedic Center. Many of us know, and we visited and we learned, trained under him. And since 1993, which is an ISO certified hospital. Shivshankar has an excelled himself in the field of orthopedics, and he is known for his innovative works in the field of orthopedics all over the country. He has developed many special newer techniques and instruments. The specialty of him is he never names all his techniques with his name. All his techniques and instruments go with Solapur name. So Solapur technique for interlocking nailing, fractures of the femur and tibia, Solapur type of external fixator for distal radial fractures, Solapur sleeve for keyhole surgeries of femur, Solapur sleeve for keyhole surgeries of DHS and modified instruments, broken nail extractor, adapter for K-nail, condylar screw technique, and screw removal stuck drying. And we famously fondly call him as interlocking man of India. So he is the one who popularized interlocking nail across India, conducting many live workshops and demonstrations. And he has 12 prestigious orations. We will add one more to him. There's 13 prestigious orations from different state chapters. All state chapters are privileged to have his orations. And he has written textbooks and CDs and journals of 20 different CDs of operative techniques has been released by him. So I request our Honorable President, Dr. Durga Prasad sir, to come and felicitate and give the certificate of oration before he starts his oration. Some music, please.
it has already come. Okay, forward. Okay, video. You have there? I don't see here. So it's there. No, sometime video, I have to click on the button. That's right. Anyway. Slide thing, video play. Anyway, that's fine. Good morning, everybody. At the outset, I would like to thank the OSSAP for having awarded me this oration. Actually, the earlier biodata, it is 12th, but today it is actually the 23rd oration I am giving. I must thank the Prakasham District Orthopedic Association for all the coordination they have done in bringing me here. I am very happy to talk about a subject which was very close to the orator, orthopedics, though he started the polio and made it so popular here. Today, the topic I have selected is aseptic non-union of the femoral shaft with a interlocking nail in situ. The reason I selected was when I saw the brochure of OSSAPCON from Ongole, the CME topic was non-union. I selected that let me go with the theme of the conference, that is non-union. And I'll be restricting myself to femur non-union with a nail in situ. Being an interlocking man, I would like to restrict myself to that. So I'll be speaking only with nail in situ and no infection. Majority of the non-union are due to inadequate surgery or iatrogenic. Majority of the time, the nail breaks as fracture doesn't unite. The common causes of non-union are thin nail, that is mechanical instability, open nail, biology is questionable, fracture fixed distraction, static locking or delayed dynamization, weight bearing not done properly, or patient kept on non-weight bearing for a prolonged duration of time. Majority of the cases, it's a combination of all of them. So if the non-union is due to instability, give mechanical supplementation. If it is due to biology, give biological supplementation in the form of bone graft. If biology as well as mechanical instability is the cause, then you have to supply both of them. Here is a case of non-union with a canal which was unstable, just treated with a interlocking nail of thicker size that gave stability and the fracture united. Another case, statically locked, patient was not weight bearing and the nail broke, and that was the time the patient came to me. I just did a exchange nailing thinking that internal grafting will happen due to the reaming, but unfortunately that was a decision wrongly taken by me. As you can see further, this is after 14 months, the patient was doing excellently everything. Then he came to me after 5.5 years or 7 years. He came to me in 2010. I thought that the fracture was united and I removed the implant, but you can now see the pre-operative picture was not that good. But after removal of the implant, I realized that there is a stress point probably that could have been avoided by bone grafting properly. I removed the implant in 2010. After 2.5 years, he was doing fine. With a trivial injury, he broke the femur. And was it a fibrous union? That was the question. This time I did everything. I did shingling, multi-lock nailing, proximally 3 screws, distal screw, 3 screws, freshening of the ends, bone grafting, everything I did. Just at 4 months, you can see beautifully the fracture consolidated. Today, if the same patient comes to me, I will be doing additionally plating with bone grafting. That is the augmentation plate with bone grafting, because I don't want to take a risk while I'm doing a second surgery. So that is the topic I'll be speaking in the next 20 minutes. Friends, Non-union requires absolute stability that can be given by only plating with compression, not by nail, because your interlocking is away. Unless it's a ischemial fracture, the rotational stability is not given by nail. So for a absolute stability with a non-union, you require plate. And if you are a nailer like me, then you can augment the stability by putting a local augmentation plate. Nail gives stability over long duration, long length, and plate gives near stability to this fracture. I was attending a Zimmer trauma meet in Bombay sometime in 2011. Dr. Ram Prasad from MIOT Chennai presented few cases of augmentation plate done for non-union of the femur. Then after seeing this presentation, I was really, especially for junctional area fractures, I thought I should try them and I started working on them. This is a case, you can see the proximal bolt is broken. The fracture has gone into non-union and the fracture has not consolidated as the dynamization was insufficient or the fracture collapsed too much. This I treated with a nail with an augmentation plate. I bent the plate to C shape. I call this as wave plate. I will talk about the advantage of wave plate little later. This is immediate post-operative picture. This is after 3 months. This is at 2 years. You can see that the fracture has consolidated. And after 4 years, I have removed the implant in this patient. Another case, again a statically locked done. That is the culprit here for the dynamization not allowing and the fracture going to non-union, oligohypertrophic non-union, it had gone. You can see the ends of the bone. Probably it was the open nailing also done, and hence the end is very ivory. I treated that with again nail with augmentation plate with bone grafting. This is immediate post-operative X-ray. This is at 6 months. The clinical picture at 6 months, you can see beautifully the patient had an excellent function. 4.5 years time, he came for implant removal, and I have done the implant removal in this patient.
It has become round all around, so it is not having a grip. So even I tried to remove other bolts and
this is the removal of the augmentation plate.
Special drill bit. And inside. And this is the extractor bolt by direction. I can see that there is a good grip now. It's not moving. And now you can see that the screw is coming out. Sometimes the other way of doing is take out the plate completely and
there was a broken piece also in the femur. Patient was very much psychologically concerned about that piece. So what I did was from the opposite side, after removing the plate, which you just now saw, I just hammered that bolt out. That's the reason why I always tell you should keep the bolt long on either side so that if it breaks, it can be removed from one of the side. So I could remove this, and this is the end result in the same patient. Another patient, canal with the instability, that too open nailing was done, and I again in the same fashion I treated this patient in 2014. 2014 I had treated patient after 3 months, never came for follow-up, and just before the lockdown I had sent her letters saying that please do come visit. On 4th of February 2020 I sent a letter to know the follow-up, and recently just on Monday she came for follow-up. Till 8 years she never came for follow-up. On Monday she came, and you can see that the fracture has beautifully consolidated. This is the clinical picture on 15th of March, and I have removed the implant. And here also there was a problem in removing the locking bolts. I could remove. There were 2 locking bolts above and 2 locking bolts below. I could remove one each from both the segment. So what I did was, because of the wave plate, I could use the plate cutter and cut the plate, and I made it into a single screw with a plate, and I could rotate and take it out. This is another case. Again, 10 years back, nailing was done. Again, a varus, you can see there was non-union. I had to change the entry side. So I used a Steinman pin. You can see the Steinman pin there. And again, I did everything, shingling, bone grafting, and augmentation plating, changing the entry by putting a Steinman pin. These are the pictures of shingling. Then this is the Steinman pin and also the guide wire, which is acting as polar screws. And this is at the end of the surgery. Nailing and plating has been done. It is a simple radius ulnar plate I have used in this case. And you can see a Steinman pin kept laterally so that the nail will not migrate back to its original track. So with that intention, I have blocked the lateral canal of the earlier one by a anteroposterior screw. And this is at around 4 months time. The patient had an excellent function and it has gone into union without any problem. This is the clinical picture at just 4 months time. This is another recent case. This case was treated in 2013 by a DHS, went into non-union and the implant broke. The second surgeon did interlocking proximal femur nailing in 2014. And in 2017, again that broke. So this is the time I was involved in this case. Again, in this case also, you can see the entry is from the tip of the trochanter. Varus is the culprit here. So here again, I did the same way, blocked the earlier tract, made a separate tract, and you passed a Steinman pin as a blocker. And I reamed. You can see the good valgus in the immediate post-operative picture in 2017. This patient also never came for follow-up. Literally, I did it with another surgeon in Sholapur. I sent many times WhatsApp messages. Finally, I could get his mobile number because he never came for follow-up. Then, after repeatedly contacting him, he was just 15 kilometers away from Sholapur only, but even then he was not coming to show. So this is recently he came in on 23rd February. You can see beautifully it has consolidated. These are some of the clinical picture of the same patient. Patient is able to walk. This video is not running. Can you make it run? Okay, anyway. He has a shortening of 1 inch on that side, but because of the graft which we have taken, he has got a lurching gait on that side. I said we can increase the length, but anyway, this is now 64 years old person, so he is not too keen to get anything done. This child was treated in childhood with a plate for a fracture shaft femur, came with a fracture above at the proximal hole site, treated with a locking plate, and again that broke. This was the time I got involved in this case. Again, did a femur nailing, long nail with a augmentation plate with bone grafting. This is after 1 year. You can see when the patient came for follow-up in August 2020, he had a nice consolidation and good result. Subtrochanteric fracture treated with a regular nail with a entry from the tip of the trochanter, again went into varus. Then the nail broke. The surgeon only removed the culprit, the proximal nail, which was irritating. He removed that, and I was involved almost after 6 months after the initial surgery. While doing the surgery, I reamed the canal, but unfortunately, I didn't use the 15 millimeter reamer which comes with the proximal femoral nail set. I had just reamed the canal with 12 millimeter, and I just hammered the 12 millimeter, 11 millimeter proximal femoral nail. You can see there is a vertical split from top to bottom. That happened on table. I was not prepared for that. I just did some wiring, and whatever the correction I had got by changing the entry site, because of the vertical split, I lost majority of the correction. And the bone was very, very soft also, because the patient had not walked for almost 1 year. And this is immediate post-operative picture. The patient is able to walk. And this is after the fracture consolidated. I'm still not happy with this varus, subtle varus still there. But anyway, fracture has consolidated. She is diabetic and there was a discharging sinus. So recently I removed the whole implant, and also I have put a antibiotic coated beads. Another similar case. Again, I went to Dr. Nitin Deshpande at Kolhapur and did a similar way. I have treated the case. before I removed, because the neck screws are properly positioned, I have passed anti-vibration guide wires first, then I have applied the plate, and then the patient has sent these pictures, because these pictures are not taken at Kolhapur, and the patient is able to walk. Is a what you call, he catches fish for his livelihood, and he's going and doing all the activities without any trouble. You can see that he was walking very nicely, and he will jump to the boat and he will do the thing. Another case, again, I did with Dr. Nitin Deshpande at Kolhapur. This was a case 8 years back. The nailing was done, and the patient suddenly started getting more pain. And this X-ray was sent to me. I said, we'll do that again similar way. I decided to go on 24th of March. So on 21st January, I took the X-ray. The fracture appeared a little united. So I asked them to get you can see on 22nd March, the X-ray looks, it is appeared united. So I asked them to get a lateral X-ray. Then once a lateral X-ray was taken, I was sure that this is a non-union. And again, in this case, I have removed the nail, the broken implants, and I have done in the similar fashion. I have done the treatment. The proximal broken piece of the nail has been removed. I'm intentionally showing all this broken screw removal and broken nail removal, because that will add a little more knowledge to not just the augmentation plating I am doing. This is a broken nail extractor designed me. You can now, after applying the extractor, I am removing the distal bolt, and I am rotating and removing. You can see that I am not hammering out. The nail was loose. I am rotating anti-clockwise and taking it out. So that is very, very important. Many times we just apply the broken nail extractor and try to hammer, that gets dislodged. So you keep continuously giving the anti-rotational force even while you are extracting. So these are all the implants which have been removed. You can see the threads cut by the broken nail extractor in the nail. This is again treated with femur nail, with augmentation plate, with bone grafting, and this is immediate post-operative X-ray, 2 months picture, 8 months picture, and the patient is doing fine. So if you think how you can make a drill around the nail, always use a K-wire. Just hit the nail, slip beside the nail, and make a hole with the K-wire. Then you can drill with a drill bit. Otherwise, if you directly use the drill bit will break. So that is very, very important. Distal femoral fracture, again, I have used the similar technique. A non-union case I have used blocking screws both anteroposteriorly and mediolaterally, so that the nail will be jailed to one side. There is 2 anteroposterior screws and 2 mediolateral screws that will corner the nail to one part of the canal. And this patient started walking within about 2 months time, full weight bearing. At 9 months time, you can see that beautifully it has consolidated. This is after the implants have been removed at around 2 years time. This technique I have used even in many other places like humerus. This case was operated multiple times, femur. This is second time the plating was done, and the plate and the screw broke. That was the time I came to the picture. I did the augmentation plate with nailing and bone grafting, and you can see after 6 years, beautifully the fracture is consolidated and it has healed. Another case, humerus nailing done in every distal fracture. In 2013, I did the same nailing with augmentation plate with bone grafting. This patient has never come for follow-up. Somehow I got the mobile number and the address from his case paper. I sent messages to his son and he sent me the pictures. I have not seen the patient clinically, but the fracture has united beautifully. The last case I am going to show, multiple surgery done. I am in practice for the last 29 years and I am treating this patient for the last 27 years. So the first surgery was done in Gulbarga in 1994, and as the plate bent, it was removed and the cast was given, and he came to me in this position, and that was the time I first operated, and I did a regular femur nail because that was the time in 95, 96, there were no other nails available at that time. I intentionally kept the nail out so that I could do 2 proximal locking in this patient. This is the nail broke after some time. No, not nail broke. The tip of the nail which was out side too much was irritating. So I had to remove the nail. Once I removed the nail, the fracture had not healed. So I did a stacked canailing. So there was a varus deformity. I did a stacked canailing, and that stacked canailing also broke in 2006, almost after 10 years after the surgery. I removed the stacked canailing both by using the extractor as well as the screws and broken piece were removed. I did a recon nail. Again, the recon nail I was unable to pass because I didn't change the entry site. I was using the tip of the trochanter only at the entry. I didn't change it much. And again, because of that, I was unable to put the second screw. Again, so this broken nail extractor has been published in Dr. Tanna's book of interlocking. So he came back to me again in 2011 with a broken recon nail. This time locking plates were in yoke. So I did the locking plate with bone grafting. So bone grafting for the 4th time I am doing, and the surgery for the 7th time he underwent. Again, in 2015, he came with a plate walking off, and I suggested that we'll remove it and do something else. I said that I'll do the augmentation plate. He didn't come back 2015, and he came in 2018 with broken plate. So he was managing with like that only for all these years. In 2018, I didn't want to take any chance. I did everything. So I did nailing, plating, double plating. You can see there is a lateral plate as well as an anterior plate, bone grafting, because nails and stacked nails all broken. That's why at least the implant should not break. With that intention, I did this surgery. So this is femur nailing with augmentation plate. And these are 2 months. Just before the lockdown, he had come. This is at 6 months. This is at 9 months, 18 months. Just before the lockdown, the patient came. For the first time, he was happy. He wanted me to remove the implant. I said, let's get the CT scan done and then we'll remove the implant. But because of the lockdown, he has never come back to me. At last, after 25 years, 26 years, there was some happiness on the face. So friends, hypertrophic and non-union in the femur can be hypertrophic or atrophic. Hypertrophic needs only stability and with a thicker nail. Atrophic, if there is a vasculature is questionable, you have to add bone grafting. If stability is also not good, then nailing with augmentation plating is also a very good option. And to prevent non-union, good stability till the fracture unites with thicker nails, avoid static locking or dynamize in time, allow walking partial to full weight bearing depending upon the fracture stability. In established non-unions, shorter working length by using thicker nail and local augmentation plate, augment biology with bone grafting if opening the fracture, removal of avascular ends. Compression plating is also a very good option, especially in junctional areas, but that is not the topic I am talking today. I thank everybody, especially I pay my rich tribute to the past president of IOA, Professor Dr. Vagreshwarudu, the first orthopedics professor from Andhra Pradesh. And when I was going through the biodata of him, really he has done a human service, and without saving a penny for himself, he has dedicated his life for the polio patients, and whatever the money he has been earning or getting, he has given to the associations which he was involved, the hospital and as well as the RSS. He has given. A man comes empty-handed to the land. He went back empty-handed without making any rich thing, but he has rich place in everybody's heart for the work he has done and the human service he has done. I'm seeing Professor Jagdish from Birds. The Birds Hospital has been started by him in Tirupati. I thank the OSAP and the local organizing committee for having me here. Thank you very much.
Sir, thank you, sir. Thank you very much for your excellent lecture presentation. We are honored to have you here, and this is very useful to us. You are a legend, sir, in interlocking nailing. Thank you very much, sir.
Thank you very much, sir. Now we will move on to the next oration, the prestigious oration, Narasimha Reddy oration. Can I have the slides of Narasimha Reddy oration, please? Sir, before lecture, after lecture? Felicitation. Before lecture, after lecture? After lecture, yeah. Okay, sir. Can I have the slides of screen here? The second prestigious oration of our association is named after G. Narasimha Reddy. It's Professor G. Narasimha Reddy oration. Professor G. Narasimha Reddy memorial oration was started. Can I have the slides, please? I'm not able to see here. Yeah. Yeah, thank you. Dr. Narasimha Reddy memorial oration was started in 2018 after our state got separated from Telangana. So we had to create a second oration. That happened in Tirupati 2018 in the state conference. Narasimha Reddy was a student of Kurnool Medical College. He did his MS from Andhra University. He started his career in Visakhapatnam, working as an assistant professor. He worked as a civil surgeon in Kadapa and Kurnool for a couple of years. Later, he became the head of Department of Orthopedics at King George Hospital, Visakhapatnam. And he is also the superintendent of Rani Chandramani Devi Children's Hospital of Vizag. He was chairman of organizing committee for National Orthopedic Association annual conference held at Vizag in 1990. He conducted a number of polio camps with the spirit of Dr. C.H. Vyagreswarudu and help the poor people. And he's always loved by his students, and most of who have settled as a professors in the same hospital are settled across the world. He is survived by his wife, Dr. C. Shyamala, who was the head of the Department of Pediatrics and retired principal of Andhra Medical College, Visakhapatnam. With this short introduction, I'll request Dr. Malyadri Naidu Garu to accompany Dr. Bhaskarananda Kumar Garu, who is a orator of Professor G. Narasimha Reddy, orator of year 2022. So please come under some music, please.
మనకు తెలుగులో సామెత ఉంటుంది సార్, ఎదిగే కొంది ఒదిగి ఉండాలని అనే దాని సామెతకి మా ప్రొఫెసర్ భాస్కరానంద్ కుమార్ గారు నిలువెత్తు నిదర్శనం అని చెప్తాను. Because I am a student of him in MS. Both me and Jagdish were his students. And it's my privilege to be here reading his CV. And he is a former professor and Department of Orthopedics, Consultant Orthopedic Surgeon and Hand Surgery Services, Kasturba Medical College, Manipal. He married to Dr. Nalini Bhaskanand Kumar. She is a professor of pediatrics in Kasturba Medical College, Manipal. He speaks more than 10 languages and he speaks Telugu also. His mother tongue is Tulu. He is a visiting consultant in hand surgery in Bird Hospital, Tirupati, and Virid Hospital, Dwaraka, Tirumala. I am briefing it a little bit. He has given a lot of international lectures in California, France, Germany, and Amsterdam, etc. And he was awarded in Amsterdam on a subject paper called Primary Atlantoaxial Orthosis at Charot International Award Orthopedic Conference at Amsterdam. His hobby is Yakshagana. Kantamandu telusunto Yakshagana ante is very, very popular in Karnataka. And he has got largest series of study on congenital hand anomalies, radial club hand, thumb reconstruction children, and polycization, etc. He has got more than 40 publications, both internationally and nationally. He was awarded as Indian Hand Pioneer Award in August 2021. He was awarded International Federation of Societies for Surgery of the Hand, IFSSH. This is going to receive in London this year, 6th June 2022. With this small introduction, I request Professor Bhaskanand Kumar Garu to present his oration.
Mr. Chairman, Dr. Durga Prasad and Naresh Babu, members of the Orthopedic Society of Andhra, ladies and gentlemen. At the outset, I must thank the organizers for having called me for this oration. There is something common between me and Dr. Narasimha Reddy. I'm not going to go through his entire biodata because already it has been told. Common thing is that I'm an orthopedic surgeon. My wife, Nalini Bhaskanand Kumar, is a pediatrician. So is Narasimha Reddy. His wife is also a pediatrician. I got only one kid, but I always tell my wife looks after two kids. It's my daughter and me. She always thinks I'm also a kid and advises me every time, and I follow it. And Narasimha Reddy conducted the Indian Orthopedic Conference in 1990 at Visakhapatnam. I gave the talk that day in that place on congenital hand anomalies. Entire symposium was on congenital anomalies in the orthopedics. Somebody spoke on foot, except club foot, of course. And I was to give this, but previous speakers, when they were giving the talk, I realized it's a big hall like this with the 6 doors on either side and at the back in the front. Every time they would open, the slides would go blank. Dr. Jagadish, who was a postgraduate then, gathered 6 people to stand near the 6 doors and saw that every time somebody entered, door was closed immediately so that slides were not disturbed. And I'm very happy to tell you, I got a standing ovation for my talk. A lot of seniors came and embraced me because at that time, nobody was doing much work on congenital hand anomaly. And I'm happy that Narasimha Reddy was the chairman of the organizing committee at that time. Yeah. Now let's go to the topic proper. Creation of thumb. I must confess, I started my work in Manipal to start with. You will realize that the loss of thumb is a disability. Eklavya had that disability, but today we can correct it. Because especially, I always tell, you will remember your nose only when you have a common cold, that you have a nose. Similarly, you will realize that you wanted a thumb when you don't have it. The misery of people without thumb is terrible. The loss of thumb leads to 40% disability. And there are many conditions where the thumb is congenitally absent, Bloth type 2, 3B, and 4 and 5, radial club hand, and sometimes ulnar club hand, mirror hand, and some case of acrosyndactyly, just examples where I started my career. And these are the various types of thumbs that you can see, which needs to be reconstructed properly or replaced. Mirror hand, there are only fingers and no thumb. I call it banana hand, another club hand, and acrosyndactyly. All these things, the thumb is very inadequate, and our aim is to create a thumb. How to do it? We have polycization or vascularized toe transfer, on-top-plasty, etc. It involves the transfer of one of the fingers of the same hand to create a new thumb. That's called polycization. And giving you an example, just I'm running through a few cases only. The index finger we approach like this through its skin incision. Digital artery is separated of it going to the neighboring place. It's ligated. And extensors are divided into 3 slips so that they can be inserted subsequently to the intrinsics. Intrinsics are separated. You will see on either side of the index finger, we are releasing the index finger, intrinsics, and reposition it and suture only at the base and the intrinsics. And it will stand in position like this. Now, showing you a picture of this kind is no use. We have to show you the results. I'm very happy that till date, the last polycization was done in Tirupati. We had totally have done 437 polycizations till now. Most of the time, it is in radial club hand, and all other indications are seen here. As I told you, this place has given me the richest number of cases. I must thank Dr. Jagadish for this, because he was the man who made me the visiting professor there. And that is the greatest Guru Dakshina he could ever give. But today, I am a very rich man as far as my experience in these things are concerned. Dieter Bagramko, with whom I had the opportunity of working for about 15 days only, I always call him the Michelangelo of hand surgery. The way he dissects is something phenomenal. Apert syndrome, if you see the syndactylized hand, he doesn't use marking pen, but he separates them beautifully. These are some of my results. Of course, you will see only the best results. Complications, I don't want to talk to you because I have lost 3 thumbs out of 437. The case of mirror hand, if you see here, X-ray shows 7 fingers, and you will see the polycized hand. And that is the result. The child is able to do the opponents, gripping, everything is possible. Now, we did a small time, long-term follow-up, not that everybody came, because my patients are distributed all over the country. Even from Lucknow, I have patients. So getting them together is not all that a possibility, but for somebody's thesis, we could gather some patients. We selected only those who have in-home polycization was done 5 years earlier. And we could meet 85 patients with 117 thumbs, in fact, polycized digits. And we evaluated, we found that really excellent was only 12. Maybe by other standards, it's not, because excellent means they should be able to do everything, including driving and all that. And good, For all practical purposes, it was good. From patient's point of view, it is excellent. In 64, fair in 36, and poor in 5. I lost 3 thumbs till now. As you understand, most of the time, poor and fair results are in radial club band because varying grades of changes are there. And you cannot, there is nothing called a single, common thing in radial club band except that radius is absent in many forms. Just to show you one of the results, this boy had come to me, Srinivas Gowda, at the age of 18 years. And he came to know that I am doing this, and he was very keen it should be done. Those days, the textbooks used to say, never do polymerization once they are getting used to the functions which they can do with 4 fingers. Because he insisted I did that. But today I will do it in every patient who comes late to me because the results have been very good in adults. See the way he's picking up the pins. See the way he's jumbling with the cards. And see the way he's driving. So this boy is my prize catch, I always say. Acquired polymerization, especially traumatic. Initially, we have done this procedure like this. Then that index finger was polycized, as you see in the picture. Results 5 years later, he's able to do all the activities. This is the X-ray after 5 years. And sometimes when there is acquired traumatic loss, we do what is called polycization. We transfer the toe into the hand. Great toe is transferred. Badly crushed wound, thumb is almost lost. Then we had done a pedicle graft there. And of course, toe has been transferred. And that is the result what you see. Some patients do not want any of these things. They want a thumb to be reconstructed what is available. This patient had an amputation at the level of the head of the metacarpal. So all that we did was lengthening. We lengthened it, and got this much of length. Later, of course, it was inadequate for function. So we had to deepen the web space. After deepening the web space, that's the result. After deepening the web space, that is the result. So only thing is it is a long-time procedure. Patient should be told that it will take almost 6 months for her to do any function. Then I have coined this terminology called spare part surgery. Sometimes patients come with a crushed hand, some fingers are lost. You can use the lost finger into something. Just giving you an example, that's a very badly crushed hand. That is how it looks after the debridement. Half of thumb is lost. The index finger, though looks, it is there. The base is totally lost. There was no metacarpal. So what he did was this index finger could be transferred onto the on-top lastly of the thumb. So that's how it is. And that's after the transfer of the remaining index finger on top of the thumb. And that is the function. This is another child with a condition called symbrachydactyly, where you will find the X-ray shows that there is no thumb beyond the metacarpal, and there is an adjacent digit with no metacarpal, but distal portion is there. So we release the syndactyly to start with, and then when things healed, we transferred that digit on top of the thumb. As you see here, now we'll find a thumb there. So unwanted small little part, we could use it for creating a thumb. That's the function of the child. Good opposition. At another acrosyndactyly, you will find that the thumb is only half. There is one digit that is adjacent to the little finger, which is available for transfer. Otherwise, it is useless anyway. And we transferred like this. That's how it looks like. Now we'll see a long thumb. And that is the function. That is the thumb. and that is the function. Interesting case from Tirupati once again, a man who has got a limbo garden. If he comes to know I come to Tirupati, he will come with some 25, 50 limbus for giving it to me. This man's hand was, because of electrical burns, he had lost the thumb. And if you see the middle finger, it is very cicatrized. That was not moving, unlike the index finger and the little finger, a ring finger. So the middle finger was bad. Anyway, it was not bad from my point of view. I thought I will use it for creating the thumb. So this is how we have created the extra length of the thumb, and that is its function. Interesting man from Srikant who came from Davanagere. He was a carpenter who used to work in Visakhapatnam, carving the doors and all that. And he lost his thumb, which was treated elsewhere. This crushed thumb, crushed hand, they were treated very badly with K-wires. You will see that these K-wires are not touching any of the bones. I'm not naming the surgeon or the institution or the place. They are, I call them internal external fixators. It was not doing any job. We removed that. When he came, this was the picture. Index finger had that, just the base of the index finger was there. Thumb is looking like a thumb, but not moving it. Totally, it was stiff. Dorsal skin was very bad. And if you take an X-ray, you will see thumb MCP joint is totally destroyed. That's why it is so stiff and painful. And he didn't have extensor tendon either. So what we did was, we borrowed that index finger. If you see the index finger metacarpal joint is very good. So vascularized transfer of that into the MCP joint of the thumb, we have done that. And we also grafted that area which did not have the. We used the extensor tendon of that for creating the continuation of the extensor of the thumb. And I'm very happy to tell you, this is how it looks after everything heals. And that is the function. He's able to open ends. I'm very happy. He went back to Visakhapatnam to complete the contract of doing carving of the doors. So more than anybody, I must thank the Tirupati temple authorities who have created that beautiful hospital called Birds. And Jagdish subsequently started another hospital in Dwaraka Tirumala. It's called Words, Venkateshwara Institute of Research and Technology. So these are the two places where I have done maximum work. I should say 75% of my congenital hand hemorrhage work has been in these places. I'm a lucky man. I was born in a place called Katil in South Kendra district. And one of the philanthropists have built a hospital now, 100-bed hospital, fully equipped. And afterwards, he handed over to Kasturba Medical College. They have invited me to be a visiting man. Once in 15 days, I go there to my native place and I'm working. Now in a month now, out of 30 days, 10 days, I work in the temple hospitals. I'm a lucky man and being blessed by him. Yeah. Thank you very much. Thank you.
Thank you very much, sir. That was a wonderful presentation. Words of wisdom from lifetime of experience. Thank you very much for showing us the path. Thank you very much, sir.
I have one small request. With the permission of the chairman, Jagdish will talk about it.
Sure. It's our privilege and pleasure. So our OSSAPCON Ongole is privileged to have the launch of Professor's textbook. Yes.
Just, I'll speak.
Good morning to everyone. It's my privilege and my professor given me opportunity to release his, well, how can I say, a book on Bhishma's lost life. So first he wrote that book in Telugu, then being it translated to in Kannada, and recently it's done in Telugu at Tirupati. So he chose this platform. Mangalore University. So he chose this platform to release this book. And another interesting thing is the Mangalore University added this one as a subject in the degree, second year degree college also. The thing is added. So we are very fortunate today to release the Telugu version of the same from Ongole in presence of my friend Dr. Malyadri and the president and the secretary. I thank you very much, sir, for the opportunity given. And I hope in future it will come in Hindi and Marathi and all other languages. We hope it will come and it will be more educative and giving what the Bhishma, his thoughts and all in his last stage of his life. Thank you, sir. Yeah, please claps, please. I request my professor to say a few words about this in Telugu.
మన్నించండి, తెలుగు బాగా రాలేదు. ఈ బుక్ నేను తుళు లాంగ్వేజ్లో ఫస్ట్ చేసినాను, తర్వాత కన్నడ లాంగ్వేజ్లో ట్రాన్స్లేషన్ నేనే చేసినాను. మా అక్కడ కన్నడ ప్రొఫెసర్ నుంచి చూసి ఏమయ్యా 3 years అయింది, మీరు ఇది ప్రింట్ చేయాలని చెప్పినారు. ప్రింట్ చేస్తే within 3 months it got, the Mangalore City people phoned up and told me that I should give it to them for the second year BA students. So 5,000 copies were printed at that time. Ippudu totally Kannada has about 6,000 copies have been already printed. తర్వాత సాంస్క్రిట్లో ఒక వాళ్ళు చేసినారు, మలయాళంలో ఒక వాళ్ళు చేసినారు, తిరుపతిలో నరసింహాచార్య చెప్పి వాళ్ళు ట్రాన్స్లేషన్ చేస్తున్నారు. మీ అన్ని చూసి మీ అభిప్రాయం నాకు ఇవ్వండి.
Some of these copies are kept in the cafeteria, sir. If anyone is wanted to take, I think we got 50 copies around. Anyone is interested, you can take there.
Thank you, sir.
Thank you very much, sir. So now we'll move on to the third most prestigious oration of our association, the past president's oration. It's customary for every year, the previous year's president will give the oration. I request our past president, Dr. S. Subramanian Rao sir, to come onto the dais and Dr. Veeray Chaudhary garu to accompany him. Request our Honorable President, Dr. Durga Prasad garu to read out his biodata. So please, you can come and sit here.
Dr. Subramanian garu, our past president, is also my guru when I am doing my PG days in Kurnool. He has conducted several polio camps we used to attend as PGs. He has done his MBBS and MS from Kurnool Medical College. He has worked as orthopedic surgeon at District Hospital, Kadapa. And presently he is working as professor, Department of Orthopedics, Fatima Institute of Medical Sciences, Kadapa. And is also consultant surgeon at Sai Nursing Home. And he is president of COSA. And he is member of several associations, OSSAP, Bombay, BOS. And has done several courses under BOS. And is multi-talented, arthroplasty, arthroscopy, pediatric spine, and presented several papers. He conducted several camps, pediatric ortho CMEs, live demo workshops, and TFN, knee, shoulder arthroscopy. And he's basically interested in doing PRP stem cell procedures for various orthopedic conditions, including OA. Sir, I welcome you to give the oration. Before that,
we'll honor him first. I request our president to garland our past president. Music.
Slideshow పెట్టేస్తాను. బట్ పని చేయట్లేదా? ఓకే. అది పని చేయి. Slides first color. Sir, check.
So before the slides are coming up, I request all the aggressive medal competitor presenters to hand over their presentations to the presentation desk.
Pointer తో పోతుంది కానీ
All the Vagressor medal presenters, please hand over your presentations. So we'll immediately start after this one.
Good afternoon, friends. Dear President, Secretary of OSSAP, my dear senior and junior colleagues, let me first thank, as a customary to the OSSAP, previous President's oration being continued, and it will be continued in future also. Thank you very much for giving this opportunity by our OSSAP and Prakasham Orthopedic Association, local organizing committee of OSSAPCON 22. Actually, topic given and brochure is PRP in ONE. But before going into the PRP in ONE, I would like to just brief what is regenerative medicine. Without that, we don't understand the PRP mechanism. इसमें नहीं जा रहा okay. Start from the beginning start here. So coming to the regenerative medicine, it's a branch replacing engineering or regenerating human cells.
Sir, you can use that monitor to look at. Yeah.
To restore, re-establish the normal function. Coming to the orthopedic regenerative medicine, it is to augment the natural healing process to heal or even grow back the damaged tissue like muscle, tendon, ligament, and even bone also. There are various modalities to improve to create regeneration of the tissues. These are the physical modalities: exercise, low-level laser therapy, and radial shock wave therapy. Coming to the other modes of regenerative medicine are orthobiologics. Use of biological tissues found in the human body, such as blood, fat, or bone marrow, to regenerate the tissues. Orthobiologics are 4 types, or rather 5th generation. First generation, we are already using hyaluronic acid, and most of us are well versed with the hyaluronic acid. Coming to the 2nd generation, it's platelet-rich plasma, autologous conditioned serum, platelet-derived extracellular vesicles. 3rd generation are bone marrow aspirate concentrate and bone marrow-derived mesenchymal cells. Coming to the 4th generation, it's the adipose-derived mesenchymal cells and stromal vascular factor and Goldic. Lastly, the 5th generation, which is under research, is gene therapy. What is PRP? The plasma that has been enriched with platelets, which release growth factors and other cytokinins that stimulate healing of bone or soft tissues. Normally, the blood contains 93% of RBC, 6% of platelets, and 1% WBC. Plasma, rather PRP, contains 94% platelets and plasma, and only 5% of WBC. Platelets are megakaryocytes derived from the megakaryocytes, contain growth factors and become activated and release all the growth factors. The mainly platelet-derived growth factors are lot number are there of them: platelet-derived growth factor, transforming growth factor, and more important is vascular endothelial growth factor. Mechanism of action of this PRP is it blocks the pro-inflammatory cytokinins from binding the chondrocytes, strengthen the extracellular matrix, increase the hyaluronic acid production from the synovium. Coming to the classification of PRP, number of classifications are derived, but we commonly follow Mishra, which is a simple classification. Leukocyte rich or leukocyte poor PRP, but few are zero RBC. This is very important. The count should be more than 5 times the normal count of the platelets of the human, that particular being patient. And here the leukocyte poor are used only in intra-articular condition that prevents the inflammatory chain, whereas leukocyte rich will be used in soft tissue conditions like any tendinopathies or enthesopathies. Still, there is lack of standardized procedure or preparation system for the PRP. The quality and quantity depends on the preparation system. There is what I follow is I'll show you the later technique. Coming to the usage of PRP in orthopedics, in addition to the intra-articular injection of into the OA-knees, there are a lot of other conditions, right from shoulder, partial rotator cuff injuries, tendinopathies like medial and lateral epicondylitis, and retrocalcaneal bursitis, plantar fasciitis, and mostly PRP is popularized by the sports injuries. PRP is completely safe, backed by huge amount of scientific data, at least 10 RCT and 4 meta-analysis and 15 plus clinical studies. Coming to the next second generation regenerative, orthobiologics, autologous conditioned serum. This autologous conditioned serum is prepared from the patient's blood by a process involving incubation, centrifugation, and filtration. The main difference between PRP and ACS are it contains interleukin receptor antagonist that blocks the inflammatory cascade, and it's more useful compared to PRP in OA-knees. This is the indications for ACS, and this is the process of preparation of ACS, autologous conditioned serum. The process is a little bit cumbersome, but still there are now companies have come down with machines which reduces the procedure, but a little bit costly. Coming to the plasma platelet extracellular vesicles, it's being a direct derivative from the platelets. It has got more efficacy than the PRP. These growth factors are extracted from the platelet extracellular vesicles and then used for different musculoskeletal conditions. This is the method. The platelet segment are subjected to again a processing where you can extract the extracellular vesicles. Third generation are bone marrow aspirate concentrate. To the bone marrow aspirated blood is concentrated to get more number of mesenchymal cells and growth factors, decreasing the concentration of hemopoietic cells. Harvest technique, usually from the iliac crest, anterior or posterior. And the iliac crest is divided into 6 segments. And most of the time, the richest source of mesenchymal cells are there in second and third segments. But for a beginner to get a good quality of bone marrow, it is better to aspirate from the posterior, where the iliac tuberosity, there will be a lot of thickness to introduce our bone marrow aspiration needle. That's called Jamshedi needle, 11 number. Coming to the preparation, the bone marrow which is collected is double centrifuged, and then the bone buffy coat are used for the intra-articular or various procedures. Again, here the lack of standardization of the technique. The harvest, it depends on the site of aspiration, number of sites used, especially the needle. Nowadays, the end tip needles draw only one directional blood. So that needle tip, Jamshedi needle tip should have side ports also. And don't aspirate blood directly from one site. Multiple sites are very important to have richest number of mesenchymal cells. So we use to increase the number of MSCs and growth factors, density gradient method or medical grade Ficol is used in processing so that we get more number of mesenchymal cells in the buffy coat. Coming to the other third generation are stromal vascular factor. The adipose tissue is the richest source of stem cells or mesenchymal cells. The process of extraction of stromal vascular factor are lipoaspirates, usually from the abdomen we get, and then after lipid integration, the total stromal fraction is isolated, which contains mesenchymal cells which have multipotent activity. This is Goldic. This is another next generation regeneration. Stem cell therapy or cell therapy with the help of specially designed gold particles using patient's own blood. The gold induces cytokinins which are helpful in blocking the inflammatory cascade. Lastly, the fifth generation, this is still under process. Just as we are getting the genetically modified food, we are into the gene therapy of osteoarthritis. The vector packed with the therapeutic gene is introduced into the knee joint, which with the help of vector, it enters into the cell chondrocytes and modifies the genes and starts producing the genetically strong chondrocytes which repair the osteochondral defects. Coming to the physical modes, everybody knows exercise mobilizes the early stem cells into the peripheral blood. Exercise is the so far only proved, scientifically proved one which regenerates the tissues. Static non-weight bearing exercises, do it regularly, correctly, and don't do it. These are the various methods to, especially in this, the TheraBand loop, you can carry it anywhere. You can improve your quadriceps hamstring, because just giving any injection is not at all an important, even whether do a replacement or whatever the thing may be. We have to improve the muscle balance. So this is another method. Scientific support that exercise generates your cells. Again, exercise is regenerates the muscle. Endurance exercises are very helpful in the development of stem cells also. Coming to the other physical modalities, lasers. Lasers, light amplification of stimulated emission of radiation, simply another form of energy that can be used to create physiological changes. There are 5 types of lasers, 1, 2, 3A, 3B, and 4. listed in order increasing power of and risk of biological damage. What we have using now is triple LT, low level laser therapy, that is called 3B lasers. The physiological effects of lasers are tissue healing, increased circulation, pain reduction, and decreased inflammation. If these lasers, when applied, increases the ATP and accelerates the healing process. Reactive oxygenase species positively impacting cellular repair. It releases nitric oxide, which improves the it causes the vasodilatation and increases the transport of oxygen and healing of the immune cells. The clinical effects, the cartilage, chondrocytes and collagen production is proved by scientific data. This is the scientific support. With triple LT, we can have a regenerative process. Another scientific combination therapy with the low-level laser therapy. Coming to the another physical mode, radial shock wave therapy. Shock wave therapy is a non-invasive method that uses acoustic waves to treat various musculoskeletal conditions. The principle is acoustic waves create compression and shearing forces leading on to what is called as a cavitations. These acoustic waves, when they are focused, it's called hard shock waves. That's used in breaking the stones in renal calculi like that. It's in lithotripsy. Whereas non-focused or radial dispersed, this is called RSWT. The broader effects increases, the RSWT increases healing and blood supply, reduces the pain. These acoustic waves, releases, various growth factors are released, and then which helps in the tissue regeneration. These are the treatment dosage. Side effects are minimal, and a lot of scientific data supporting this extracorporeal shock wave lithotripsy used in different orthopedic conditions. So after knowing all the regenerative modes, see, just using one mode, we may not get good result at all. So just giving orthobiologics like PRP or BMAC, lot of feedback from my colleagues that we are not getting good results. It's not the product, it is the case selection, everything. Joint preserving multimodal conservative management of osteoarthritis of the knee joint. Here, just to enlighten about the cartilage of the cartilage layers, pathophysiology of the osteoarthritis, the osteochondral unit in OA&E. Here, I just wanted to emphasize any joint, SANS theory, stability, articulation, neuromuscular coordination, and symmetry. If you stick on to the SANS treatment approach, that is concentrating on all these 4 factors while treating osteoarthritis of the knee joint, we can definitely get a better results. So the stability depends on the muscles and ligaments. We have to strengthen the muscles. Without that, we don't get good results. Even in the micro instability, extra millimeter of motion when repeated 10,000 times can damage a joint. So what happens in the joint? Normally there will be a breakdown, excessive instability loads, abnormal, poor lubrication leading on to abnormal bone and cartilage lesions. But at the same time, there will be reparative process going on. The healthy chondrocytes, control matrix remodeling, leading on to normal lubrication. There is repair and breakdown, both are continuously going on in a joint. In an arthritic joint, what are bad molecules? Mainly matrix metalloprotease and interleukin 1. These are the two ones which initiate the inflammatory process and leading on to the catabolic effect or breakdown. What about the good molecules in a joint? Tissue growth factor and then interleukin receptor antagonist protein. This is very important. We have a good molecules in the joint which blocks the bad molecules and initiates the anti-catabolic or anabolic effect. In order to fix, we need to know how the PRP works. PRP reduces all the bad molecules and increases the good molecules. What does a PRP do in arthritic joint? It rebalances the environment, improves the lubrication properties, stimulates cartilage synovial repair, and mobilizes the stem cell migration, which are very abundant in fat pad. Restabilize and an unstable joint. Coming to our protocol, we have day 1 triple LT low level laser therapy with good physio backup. Give intra-articular PRP and send the patient back. On 7th day, there will be again a low level laser therapy session and with physio. On 14th day, again, one session of triple LT and physio. Coming to the kit which I am using, I have used all the other kits and including hourglass, everything, conical glass or conical tubes, everything. Thanks to Dr. Amarnath for getting the patency for this kit. It's very good and definitely it is giving 5 times more than the normal platelet count. So this is the extraction process. Normally, I take 2 ml of ACD, acid citrate dextrose, and 18 ml of peripheral blood in 2 syringes, that's to 40 ml. But after a double spin method, I get, this syringe will have a removable stirrup. We have removed the stirrups and centrifuged, first centrifuge. We got the, this one. First centrifuge, we get the plasma, but the thing is, we should avoid the most of the buffy coat and especially the RBC, mainly the RBC. After that, second centrifuge. Finally, these are the platelets. Platelet concentrate. Our study to test the feasibility and efficacy of potential of 3 modalities of early ONE, triple LT, single mega dose 40 ml PRP and physiotherapy. We have included strictly the case selection is very important. Stage 2, where there is no change in the mechanical axis more than 8 millimeters. It should be less than 8 millimeters. And usually we have selected between 45 and 65 patients. Coagulative disorders are excluded and active infection malignancy cases excluded, and male-female ratio and age distribution. Follow-up, almost we have followed up majority of the cases up to 2 years. And our response to our treatment is 40 patients, we have pain relief without NSAIDs for the 24 months. Patients followed up in between also, we call them and then give whenever there is a slight amount of recurrence of the pain, we follow them with triple LT and on and off and with good physio backup. Regular physio visits should be there. 20 patients needed PRP after 6 months. Conclusion, triple LT, PRP, physio, multimodal management may be a definitive alternate treatment for osteoarthritis of the knee joint, especially stage 2. Our ongoing studies are triple LT, BMAC with BMAC with triple LT and physio for early ONEs. Triple LT, PRP, intra-articular and intraosseous for those patients stage 3 and stage 4, those who cannot afford or not willing to go for replacement orthoplasty. So here, normally I inject 5 ml of PRP into the joint and 1 ml into the phosphate pad, where there are a large number of stem cells are there. They get migrated into the joint and then give good mesenchymal cells in the joint repair, which helps in the repair. But in the so-called third stage, we are giving intraosseous on the medial aspect of the distal femur and then proximal tibia, 11 gauge needle again passed, and then inject 1.5 ml into the subchondral bone. Now, the theory is, it's also subchondral bone is also one of the responsible things for cartilage degradation. So we must respect the subchondral bone also, which improves the vascularity. The vascular endothelial growth factor will improve the vascularity of the subchondral bone. There are a lot of ethical concerns, but still, if it is done in minimally manipulated with homologous use, it is permitted. Take home message, orthobiologics will be a definitive alternative for various musculoskeletal conditions, especially ONEs. Multimodal management or better results, but PRP, BMAC alone will not act as a Sanjeevani. Patients come that once I have an injection, gone. Everything is, my pain should go. No, they have more responsibility towards their disease, like doing good physio, improving the muscle endurance. Without that, the results will be very poor. PRP or BMAC, will the needle replaces the scalpel in future? Let's wait and see. So I tend to agree with the vampires. Blood is good. It heals many things. Let us regenerate and rejuvenate. We are all in search of Amrut. Platelet-rich plasma, growth factors, stem cells, gene therapy, still a lot to get as an Amrut to maintain our regenerate or to maintain our vigor and vitality. So what do you choose? Treatment that temporarily improves but causes more problems in future, or treat the joint in a way to rebalance and heal it, or naturally the way it has to be meant to be. Let us stop making excuses. Just go for it. Thank you. Thank you for giving me this opportunity.
Thank you, Subramanian Garu. I hope you will find your Amrut in regeneration and you will win over scalpel. Thank you. To commemorate of our 50th foundation year of OSAP, Golden Jubilee, Excellence Awards were initiated last year. For unpublished original research work originated from AP, 2 awards will be given annually, one for senior category, more than 50 years, and one for less than 50 years. Last year, winners for senior category was Dr. Amarnath, and for junior category, J.S. Naresh Babu. As Dr. Amarnath is out of country, Naresh will be presenting his work. Dr. Naresh is chairman and head of spine surgery in Malika Spine Center. We all know his academic contributions. He won 15 national awards, 14 national awards for his research. His contribution to as co-investigator Ganga Hospital, open injury score, is published in Campbell's textbook of orthopedics. He will be presenting his work in development of AO spine, adult spine deformity patient profile. This is the one got $1 million global research grant from AO spine. Naresh.
Thank you, sir. By the time the slides come up, you can have the presentation. Yeah. Yeah. So we have, I think, small book release by Dr. SSV Ramana Garu. Sir.
So I invite Dr. Jagdish Garu and Dr. Bhaskar Anand Garu. Kindly accompany Dr. Bhaskar Anand Garu. The organizing team, please accompany Dr. Bhaskar Anand Garu. Sir, I think sir is not there. Sir is not there, I think, sir. Not there. Clear.
So we'll wait for the sir. So at the outset, I would like to thank the jury for selecting my work for the Golden Jubilee Excellence Award in the junior category. So this is on our work, 3 years work on development of AOSpine adult spinal deformity patient profile. For any ideal classification, it should identify the different severities of the disease and should facilitate communication and to the healthcare providers and researchers and assure accuracy and reproducibility. It should allow comparison of different treatment options and creation of treatment recommendations as well, and should correlate with the outcomes. If you want to have any good classification, that should fulfill all these criteria to be clinically relevant in our day-to-day practice. But deformity classifications, if you can see the spinal deformity classifications, the most common deformity classifications, what we see are for adolescent scoliosis in a young children, girls and boys in a very young age, where they have a pediatric deformity. The idea of developing these classifications are to prevent the progression. We need to identify the patients who are going to worsen as the growth increases till the skeletal maturity. That is the idea of classifying these patients, and also to recommend structure, identifying the structural curves, which curve needs to be corrected and which curve automatically corrects. So these are all radiological criteria. You want to correct the curve, and how you want to correct the curve, how do you want to balance the curve, how do you want to correct the curve at all or not. So none of these patients will come to us with pain. None of these patients will come to us with disabilities. But if you see in adult spinal deformity patients who are elderly patients with adult degenerative scoliosis, lumbar scoliosis, with degenerative disc disease, they all come with pain, disability, and our classification should also try to find out these factors and incorporate in the classification. So coming back to the classifications available, so MaxAB has initially tried to classify these patients into type 1, which is de novo scoliosis. Type 2 is a neglected adolescent scoliosis, and secondary cause neuromuscular and others. So MaxAB's classification is 3 categories, and Simon's classification, he tried to cover basing on the rotation. If the patient has got scoliosis with rotation, they are in one category; without rotation, a different category. But the major understanding of these deformities have actually started with the monumental work done by Frank Schwab from New York. He has devised and analyzed all these curves radiologically and found out that significant factors which has clinically impact are spondylolisthesis, lateral subluxations, lumbar lordosis, thoracic thoracolumbar alignment, and he found out radiological factors which really matters in patient's pain. And he used this radiographic criteria to develop a classification. This is the classification what he has proposed, adult spinal deformity classification for scoliosis. And you can see this classification has got coronal curves, thoracic curve, or lumbar curve, or double curve, or no curve in the coronal plane, but only sagittal malalignment. And sagittal modifiers were also developed. PI minus LL mismatch, pelvic incidence minus lumbar lordosis, global alignment, and pelvic tilt. If you carefully see, this classification is very, very popular and is most widely used classification across the globe. But basically what we proposed, or proposed from my side to the AOSpine, is this classification is purely radiological. This should be okay if you are treating the patient with cosmetic deformity or radiological deformity. But if you're treating a patient with pain and claudication, how can these radiological factors or matters? You are not treating the X-ray, we are treating the patient as a whole. With that concept, we proposed clinical consideration should be included in classifying the patients with adult spinal deformity. It behaves differently from the adolescent spinal deformity. So pain, disability, claudication, neurological deficits, comorbid factors. And then we analyzed what exactly is there in the literature and try to identify. This was published long back in 2018, where what should be ideal classification system should have. So we analyzed all the factors of this. And then we also really try to do, these are the 4 cases. And with these 4 cases, we have classified exactly with the current classification of Frank Schwab, the worldwide used classification. Interestingly, all these 4 patients fall into same category, same classification as a group. But the first patient, if you see, has got severe lumbar canal stenosis, radiologically same, but severe lumbar canal stenosis. What you need for this patient is a decompression. And the second patient is morbidly obese. So whatever you do, you're not going to get a good result. And third patient has severely osteoporotic, and fourth patient has got multiple comorbidities. So radiologically, they all may be similar, but clinically, they are all different categories, and you can't combine them into a single group. That was my proposal, and that proposal got accepted, and we won the $1 million grant from the AO Spine to develop the classification. And we also analyzed the existing classifications and try to find out all the factors which were listed and useful for the patient's perspective. And you can see none of the classifications really identify the leg pain, duration, obesity, osteoporosis, hypertension, etc. So we also did a systematic review of all the literature and then we found out that 54 classification systems exist in adult spinal deformity. And the most prevalent, frequent used is SRS SWAPS classification. But no classification is comprehensive. I had a multimodal set of things, and then we need a adequate classification system for high methodological quality. That was the inference. And then we developed this AO Spine adult spinal deformity patient profile. This is a paradigm shift in our thinking of treating a patient with adult spinal deformity, just not looking at the X-rays. We need to see the patient as a whole. I'm very happy to be associated with this as a leading principal investigator. So this just published last year. Myself and then the co-authors are from Kenny Kwan from Hong Kong, and Yabin Wu from Switzerland, and Chaglar Yu and Ahmad Talani from Turkey, and Kenneth Chung from Hong Kong, and David Pauly from USA, and Jongmin Park from Korea, and Manabu Eto from Japan. Lawrence Lenke. Lenke is the one who created the major classification for scoliosis, adolescent scoliosis. She is also part of our classification. So Lawrence Lenke and Merinda is a research associate, and Marinus D. Kluwer. So, and I'm privileged to be associated with this AO Spine Knowledge Forum in developing his classification. This is the AO Spine adult spinal deformity patient profile. This is available for regular usage, now published in the website. So what we have divided is we have modified Delphi consensus study. We called upon 4-round Delphi process with 2 online two online meetings, 1 face-to-face meeting, and 1 final round, with 54 adult spinal deformity experts who has published more than 50 articles on adult spinal deformity across the globe and from 5 continents, so that the distribution will be equally spaced. And threshold for consensus, we ask the patient, all the panels, we give a question, patient has got pain, do you want to include the pain in the classification or not? If the more than 70% of experts agree, then we incorporate that into classification. And then we do on rounds again and again, multiple rounds until 4 rounds, we get a final classification. And those responses less than 30% of agreement were excluded on the day 1 itself. And those with ambiguous criteria, ambiguous items were again sent for the 2nd round with some literature research to add upon. So this is the final output. We can see each case. We got a general health status, spine specific status, radiology, and type of the deformity. So this classification reverses our thinking process. Radiology becomes only one part of the classification. In addition, we have general status and neurological status and quality of outcome and the radiological status, which includes MRI. Interestingly, we operate, none of us operate on any degenerative scoliosis patients or elderly patients without MRI, but the classification never talks about, existing classification never talks about MRI. So the demographics were included, the general health status and spine specific status. We see functional ability, back pain, leg pain, expectations, and neurological status of the patient. And then imaging, radiographs will be taken, coronal and sagittal, and MRI for the neural compression. So etiology also included as one of the cause. So whether it is primary degenerative or de novo or osteoporosis related or neuromuscular scoliosis. So the coronal plane radiographs are also included, sagittal plane radiographs, and that how we fill the profile. Once we have the full profile, then we can classify these patients into different patient categories. So earlier classification systems had a morphological and etiological foundations, but more recent classification concentrated on the sagittal spinopelvic parameters. Although classifications were able to group patients into similar radiological characteristics, the management guidelines could not be applied. And ours is the first classification, and this opens up the opportunities and thinking in a different perspective. It's a paradigm shift in our understanding of adult scoliosis. Just not look at the X-rays, see the patient as a whole. And this ASD profile provides a multimodal patient profile and methodologically describes the patient as a whole. And different combination of these parameters can evolve into a good set of patient profiling. And the patients with similar profiles can be managed, potentially developing a decision-making pathways. Thank you very much for your kind attention.
Thank you, Naresh. This is an excellent work you have done. Wish you all the best.
Sir, we can proceed now with the.
Yeah, that ends the oration section. And has Dr. Bhaskaranand come from his break? If he is not there, book launch SSV garu ledu adi and these so we'll proceed ahead with the next session. That's Dr. Vagresudu gold medal paper presentation for consultants. We have 7 consultants participating in this, and the chairpersons who are going to chair this session, Dr. Gudaru Jagdish Garu. Sir, are you there? Okay. Next is Dr. Mallikarjuna Swami Garu. Sir.
Sir will accompany.
Sir.
President will be able. So I'll tell the few rules. This is a competitive session, gold medal session. So we have 8 minutes for presentation and 2 minutes for discussion. So please stick to the time. Time also has a points marks awarded to the timing as well. I request all the presenters to come and occupy the front rows. So we are going to soon start the Vagresudu gold medal competition session. Request Dr. Mallikarjuna Swami Garu also to come on to that. Can distribute the forms to the
before this this session starts. Let me announce that today we are not specifically having any lunch break. It's a work lunch, so whoever is free can go have it, but please don't crowd the hall there. Please be seated here. If you find any space there, go there, have your lunch, and please come back to your seats here. So let's encourage speakers by more numbers. Thank you.
The presenters are ready. We can start, sir. Jagdish sir is coming. Yeah. Or you can start now. So our judges, Dr. Dakshinamurthy Garu and Dr. Poon Chandra Garu. So they will be explaining the procedure for awards and other things.
So the criteria for judging the best paper, first the subheading is the discussions and conclusions, clarity in stating the conclusion, logical conclusion that is relevant to the research problem and the result of experiment or testing, recognize limits and significance of results, evidence of students' understanding of scientific of technical principle, theoretical or practical implication recognized, what was learned. Each, I think, one contain 5 headings. Skill in all the each category contains 5 marks. We will be grading from 0 to 5. The second is skill in communicating results, that is skills in oral presentation. That will have 3 subheadings: clarity in communicating research results to audience and to the judges, and appropriate use of audio-visual aids, and response to questions from audience and judges. This also carries 5, 5, 5. Grading will be from 0 to 5.
Now I call upon most prestigious session. The first.
Naresh?
Study of outcomes, sir.
Study of outcome of soft tissue defects in hand and wrist managed with reverse posterior intraosseous artery flap. Garlapati Shiva Shrikar.
Good morning, sir.
I invite
Brilliant point.
Jagdish Garu.
Okay. I think this are on this arrow, sir. Good morning, sir. Today I am here to present my paper on study of outcome of soft tissue defects in hand and wrist managed with reverse posterior intraosseous artery flap. Coming to the introduction, majority of the soft tissue defects in hand are due to the workplace accidents. So reconstruction of these post-traumatic defects of hand and wrist requires early debridement and wound coverage with flaps to minimize infection and to improve functional outcome by allowing early mobilization. So regarding surgical options, we have regional flaps, distant pedicle flaps, and free flaps. In regional flaps, the facial flaps based on radial artery perforator and ulnar artery perforator and reverse posterior intraosseous artery flap. In distant pedicle flaps, we have abdominal flap, groin flap, trunk flap, and free flaps. So coming to the decision making, we have chosen reverse posterior intraosseous artery flap in our study. Why did we choose this? Because it can be done in a single stage procedure and it allows early physiotherapy and can cover majority of the hand defects. No need to sacrifice major vessel like radial artery and ulnar artery, and it is a regional flap with a better cosmetic outcome. So aim of the study is to study the outcome of soft tissue defects in hand and wrist managed with reverse posterior intraosseous artery flap and share our experience. This is a prospective study over a period of 12 months. We have included 5 patients who were managed with reverse posterior intraosseous artery flap. And these are the observations of the study, out of which majority were males who had workplace accidents, and the mean hospital stay was 9 days. And coming to the operative technique, we have chosen the operative technique of Balakrishnan and et al. First, we will make the patient in supine position under the brachial block. Thorough wound debridement was done. Then the measurements of defects were noted for the dimensions of the reverse posterior intraosseous artery flap. Then the flap marking is done. So how the flap marking is done? Because first we have to make the patient lie in a supine position, and then we have to put elbow in 90-degree flexion and forearm in pronation, and we have to draw an axis for this posterior intraosseous artery flap from the lateral epicondyle to the center of distal radio-ulnar joint, and then a midpoint is marked on this line, and exactly a 1 centimeter distal to this midpoint will be the constant perforator. And other marking is also done, that is 2.5 centimeter proximal to the distal radio-ulnar joint, where this anastomosis with the anterior intraosseous artery flap lies. And This is the constant perforator we can see. And then coming to the superficial dissection. Superficial dissection is done by making this perforator as center from proximal to distal, and dissection will be done from radial to ulnar aspect until we see the extensor distorum minimi muscle. Then coming to the deep dissection, once this perforator is identified, we go deep in between the 5th and 6th compartments, and fascia is divided, and posterior intraosseous artery course is translated along the course. We go to the distal radioulnar joint and we elevate the flap before the anastomosis, taking the pivot, taking that as a pivot point. And we have to make sure that distal adipofacial pedicle is at least 2.5 centimeter width to increase the venous drainage. Then the flap is brought to through the tunneling to the soft tissue defect and anchorage there with the stay sutures, and the donor site is closed with split skin thickness graft. Coming to the results, all the flaps were closely monitored during the early post-op period for venous congestion, and operative limb was splinted and kept in elevation for 5 days and encouraged active and passive mobilizations of fingers to prevent it. The functional outcome was assessed using quick dash outcome questionnaire. The cosmetic outcome on a scale of 10 was assessed based on 3 parameters, that is flap thickness, color match, and the appearance of donor site defect. This is the quick dash questionnaire that we have used to assess the functional outcome. And coming to the results, with the mean follow-up of 9.4 months, the mean quick dash score assessed at the last follow-up was 17.26. The mean cosmetic score was 7 out of 10. So in our study, the site of defects mostly are in the dorsal aspect of first web space and ulnar aspect of hand. And regarding complications, we have encountered complication in only one patient, that is marginal necrosis of the distal part of the flap, probably due to venous congestion, which healed gradually without any intervention. In the cosmetic and functional outcome, all flaps were thin, non-bulky, and acceptable in all cases. These are few case illustrations. First is the radial side defect. This patient had a traumatic amputation following industrial injury. Since he had the first metacarpal joint, we explained him about the polycization, but patient refused. In order to preserve this first CMC joint, we did posterior intraosseous artery flap. This is a follow-up. And this is the ulnar side defect which occurred due to the blast injury. And this is also managed with thorough debridement and posterior intraosseous artery flap. And this is the follow-up. And next is the OLR side defects. This patient had an electrical burn injury where initially first web space defect was managed using the groin flap, and split skin thickness graft was applied to the volar aspect, and carpal tunnel release was done. But at a later date, the flap, the split skin thickness graft got necrosed. So we had to do the neurolysis of the median nerve, and then posterior intraosseous artery flap is placed there to cover the defect. This is the follow-up. And the other is the first web space defect. This patient had also a traumatic amputation following industrial injury, where it is managed by using posterior intraosseous artery flap after the polycization. This is in only this case we had encountered a marginal flap necrosis which healed gradually. This is the follow-up image you can see. And this is the other case. This is the only female patient in our study who had a desmoplastic fibrosarcoma protuberance. After the excision, this flap was used to cover that soft tissue defect, and this is the follow-up. Coming to the discussion, local forearm flaps based on radial artery and ulnar artery flaps were used earlier, but their usage decreased considerably ever since the posterior intraosseous artery flap gained the popularity, since it does not sacrifice the major vascular supply to the hand, which is not possible with the radial and ulnar artery based flaps. The usage of this flap has not been preferred in severe injuries to the forearm to ensure its viability. And the marginal flap necrosis due to venous congestion has been described in several previous studies. In our study also, we report the marginal flap necrosis in one patient with first web space defect, which healed well with the removal of few sutures and did not demand any additional procedures for its viability. All the flaps harvested in our study were thin, unlike the bulky radial forearm flaps, with a good cosmetic outcome and defect around the hand and wrist, contrary to the report by the Buckler and Frey, who reported bulkiness in almost 30% of their patients. So to conclude, this reverse posterior intraosseous artery flap is a preferable option for post-traumatic defects over the dorsum of hand, and it gives a good cosmetic appearance with a minimal donor site morbidity, and no major arterial source of the hand is sacrificed, but it needs meticulous planning, dissection, and good adipofacial pedicule to get better results. Thank you.
Excellent, good presentation, good work, and within the stipulated time. I request the judges to just have any questions to the presenter, please, from the judges. Yeah, audience also can ask, please.
Good presentation.
Thank you, sir.
Is it your work or somebody's work you are doing?
I have assisted in all these cases, sir. We combinedly did these
Right.
cases, sir.
Just answer me. Is
Yes,
it
sir.
your work? You have done it?
No, sir. I have assisted in all these cases, sir. It is primary work of my consultant hand surgeon, sir.
Yeah, this is the, okay. So it is not your work, right? Thank you. Because this is a consultant medal. Consultant means you can do independently. Thank you very much.
Yeah, we move on to the next
Thank you.
paper. Thank you. Dr. Prajwal is speaking on comparison of multifidus fatty infiltration in lumbar disc herniation, lumbar canal stenosis, and lumbar spondylolisthesis with healthy individuals. Please.
Good afternoon, everyone. I'll be presenting on topic comparison of multifidus fatty infiltration in lumbar disc herniation, canal stenosis, and lumbar spondylolisthesis with healthy individuals. Coming to introduction, multifidus is one of the vital stabilizer of the lumbar spine and plays a major role in the lumbar spine pathology. The physiological cross-sectional area is twice that of others, providing 2/3 of the muscular stability in the sagittal plane. Coming to aim of the study, our aim is to quantify the normal fatty infiltration of multifidus muscle from cephalite to caudal direction in the lumbar spine and to analyze alterations in different pathologies like in disc herniation or canal stenosis and spondylolisthesis, and its corresponding changes with respect to age group. Coming to fatty infiltration, Gottelier grading has been used for assessing the fatty infiltration of paraspinal muscles, which has 4 grades. Grade 0 has no fatty infiltration, whereas grade 1 corresponds to presence of fatty streaks, and grade 2 has fatty content less than the muscle. Grade 3 has equal amount of fat and muscle bulk, whereas grade 4 has more fat than the muscle. Coming to methodology, it is a cross-sectional study done from October 2020 to December 2021 with sample size of around 75, with control group containing 25 with normal healthy individuals and pathological group containing 50 either with disc herniation, stenosis, and spondylolisthesis. Coming to inclusion criteria, it includes MR images of 25 healthy normal individuals and MR images of 50 patients diagnosed with either of the pathology are included in this study. Coming to exclusion criteria, MR images with no proper visualization of paraspinal musculature in T2 axial images, and if any associated conditions affecting the degeneration like lytic lesions or vertebral deformity are excluded, and other etiological factors like infections, tumors, trauma are excluded. Coming to imaging protocol, for each MRI scan, level of